So is today's talk, Sheetal, is one more way in which you are giving back to the society what you have learned from masters in this field and what you have learned through your own experiences. You are giving back to a lot of delegates here and the faculties here so that they can become better surgeons and provide better care to the children they are treating. So with this I will stop sharing my slide. I would request you to share your slides and start your talk. Dr. Sheetal's talk today is going to be about elastic nailing, and there are 3 questions he's going to answer. When do we do it? How do we do it? And what we don't do. Over to you, Sheetal. The questions will be asked from this mic. So if anyone has a question, I would ask them to come here and you can ask question at the end of the talk from this mic. And then so we'll have around 30 minutes of talk and 10 minutes for discussion with Sheetal. Hospital, which has been voted, the orthopedic department has been voted as the best children's orthopedic department in USA. So that is what Sheetal comes from. Sheetal is basically interested in sports medicine and arthroscopy besides pediatric trauma. And he has published, he's edited 2 books. For those who are interested in pediatric knee, one on pediatric ACL injuries and another one on pediatric patellofemoral joints, and which are masterpieces. He has numerous research papers and articles and book chapters to his credit. As I was just going through his his introduction on the web, and he's mentioned that he believes in giving back to the society, and he feels that being a doctor has helped him in doing so. So his today's talk, Sheetal, is one more way in which you are giving back to the society what you have learned from masters in this field and what you have learned through your own experiences. You are giving back to a lot of delegates here and the faculties here so that they can become better surgeons and provide better care to the children they are treating. So with this I will stop sharing my slide. I would request you to share your slides and start your talk. Dr. Sheetal's talk today is going to be about elastic nailing, and there are 3 questions he's going to answer. When do we do it? How do we do it? And what we don't do. Over to you, Sheetal. The questions will be asked from this mic. So if anyone has a question, I would ask them to come here and you can ask question at the end of the talk from this mic. And then so we'll have around 30 minutes of talk and 10 minutes for discussion with Sheetal. Sheetal, over to you.
Okay, so can you hear me okay? Can you see my slide, my first slide? Okay, well, thanks for IFICS, for allowing me to talk. As Taral mentioned, I'm really glad to be a part of IFICS right since it started, and for the kind introduction that Taral gave. I'm sure that you all must be having a great time with Taral, Sandeep and Premal, and they are really very well experienced pediatric orthopedic surgeons, and so do take advantage of their presence there. I wish that one day I'll be there in person as well to interact with everyone. Good morning everyone. Here it's late night. I'm going to talk about complications and how we can avoid some of the things that I've learned. It's mainly a case-based presentation. I'm going to just show you cases of some of the complications that I've come across and how we try to manage those complications, learn from it and try to avoid it. So first of all, I'd like to congratulate Bangladesh for their victory today. They beat India today at the Asia Cup. So I know that it's not the finals, but to beat the finalists in itself is a big achievement. So congratulations for your victory today. I'll start with this slide because when I was training, we used a lot of ender snails, and I'm sure that you all must be using ender snails as well. So ender snail, they originated from this place Steyr in Austria, and there are very few publications, original publication by Ender himself, who came out with this snail. This is a publication from 1970 is when the Ender snails were introduced. And not too far after this Ender snail you can see this is a publication by Ender in 1970, and then from Nancy in France came out the publication from Jean-Paul Matezeau, who came out with this method of elastic nailing in 1979. So it's only about few years apart, the history between Enders and elastic nails. And still it's, elastic nails are considered to be recent, though they have been present since a long time, as long as the Ender snail have been present. The initial Nancy nails, the principles were the same as Ender snail, which is stacking of the canal. And you can see that there are 3 nails inserted in this initial publication. And then it changed the principle from 3 nails to 2 nails, and the principle of balanced nailing, that is 1 nail from each side to balance the fracture so it doesn't go in varus or valgus. Credit also goes to Lascombe because he was English speaking compared to Matezeau, whose English wasn't that good. Matezeau did come to Cincinnati Children's. We have, some recording of Matezeau at our hospital when Alvin Crawford was here. He's retired, but we had some live interaction with him. And then Lascombe's published the manual, which is an NC University manual on flexible intramedullary nailing. And this made the technique very popular once it was published in the English language. If we look at the manual, there are chapters on how to nail each bone of the body. So supracondylar fractures underwent elastic nailing, including fractures of the phalanges, metacarpal. Everywhere elastic nailing was performed in France. We only use it for long bones, but in clavicle and in other areas as well, the elastic nailing has been used in the European countries. So we'll talk about the mistakes that we can avoid, 10 mistakes to avoid during elastic nailing. The most important, and I'll stress a little bit on this, is the selection of the fracture. So if you look at this case, 12-year-old male who was wrestling with his brother who fell on his right thigh, he weighs 35 kilograms and he sustained this fracture. Now this is a long oblique, or you can call it a spiral fracture, which is also comminuted. So by definition, this is a length unstable fracture. And so length unstable fracture, when you do elastic nailing, there is a chance that it can collapse, especially if the patient is going to bear weight on it. So here the nailing technique was good, but the fracture indication was such that the patient had to be protected. In this case, the patient went on to bear weight, and 3 weeks later when he came back, there was 4 centimeters of shortening and there was protrusion of the nail. Now, you can exchange the nail, remove the nail, or you can insert the nail a little bit further, but 4 centimeter shortening is not acceptable, which means that this has to be revised. So what can be done? There are several options, and what we chose in this case was to put a plate. And this was a minimal invasive approach. The plate was just slid and then fixed with 2 screws above, 2 screws below, and that maintained the length without doing anything intramedullary. Other option is to use an external fixator, and that is very common. Now I've seen that in a lot of countries, this is what they would do right from the beginning if they have a lens unstable fracture. They would do the elastic nailing, and on top of it they would put a plate, or they would put an X-fix to maintain the length for the first 3 or 4 weeks. Then they would remove the X-fix and the fracture would go on to heal okay. The other options to avoid backing out of the nail is to use these end caps. And I would tell you that I don't have much experience and I'm not too enthusiastic about using these end caps, because you can imagine if the fracture collapses, it is better for the nail to come out or back out rather than protrude into the femoral neck or go out into the head area. So I would rather prefer the fracture to collapse. If it's going to collapse, I can revise it, but I don't want to have other injuries in the proximal aspect. So I wouldn't recommend using the elastic nail, but it has been popularly used in Switzerland. That is where this report is from. So the ideal indications for elastic nailing is length stable fracture, diaphyseal fracture, and patients who don't weigh too much, so it's less than 50 kilograms, and age less than 11 years. Now, if we go to tibia, then it's not the same. For tibia, the outcomes are not any worse if you do it in older patients or heavier patients. It's only applicable to the femur. Now, this is a report that Taral and Sukalyan, as well as our Indian counterparts, had published, and they showed no significant difference when you use elastic nailing with an IFICS or elastic nail with a bridge plate. So these are the different types. So bridge plating versus elastic nailing and IFICS showed no significant differences in outcomes. Now, if we look at where are the issues, then you would see that in major series that have been published, the problem comes when you try to nail the proximal and the distal fractures, not the diaphyseal fractures, but subtroch fractures and fractures that are in the supracondylar area of the humerus. Or if there is significant comminution of the fracture, that is when you can have a malunion, or that is when you can
recording in progress.
That is where you can get some collapse at the fracture site. We looked at our subtrochanteric and supracondylar femur fractures that were nailed, and we found that out of 36 supracondylar fractures that we treated, we had a 22% complication rate, including malunion. 4 patients required repositioning of removal of the nails, and then a limb length discrepancy as well. So it's not a great option, but we still use it at times. Same with the supracondylar femur fracture. The technique of nailing this fracture is that you have to put antegrade nails. Both the nails come from the greater trochanter, as seen on this left top slide. One nail, you can rotate it once it crosses the fracture site, and it would make the nail an S-shaped nail. The other one would be a regular C-shaped nail. And you can see that the fracture alignment is well maintained, but when we looked at 8 supracondylar femur fractures, 2 of them had nail site irritation at the greater trochanter. There was 1 patient with infection, and then it comes to 38% complication rate. So for supracondylar and subtroch fractures, the other options like plating are also good options besides nailing. If you're going to do nail, just be careful about following the patient closely. As far as technique is concerned, the ideal technique of elastic nailing is that there should be a maximum spread between the nails at the fracture site, and the nails have to cross each other twice, below and above the fracture site, not multiple times. So this is how a balanced nail works for tibia as well as femur. And then for the forearm, you can see that the tip of the nail should be pointing towards each other. The radius tip should be pointing towards the ulna, the ulnar tip pointing towards the radius, and that helps to maintain the interosseous space. We know about the size of the nail. We'll talk about it a little bit later. And this is an example of improper technique where the nail is crossing each other multiple times, not 2 times, which is called the corkscrewing, or a sign of struggle. That means you're trying too hard to put the nail through and rotating the nail multiple times across the other nail. So here it is crossing each other at 4 different areas instead of 2 areas. And there is also distraction at the fracture site. The reduction is not adequate, and the nails are not the same size. So the nails have to be same size if you want to follow the principles of balanced nailing, which means both nails balance each other, then they have to be the same size. The other issues with nail is during nail insertion. You can see here is that when you do a radial entry nail, I would not recommend doing it percutaneously, because when you're inserting around the radial styloid, you can then injure the superficial branch of the sensory nerve. So I would recommend that you open it and you see the nerve If it's coming the way, if it doesn't come in the way, you can go ahead and insert. You don't have to search for the nerve, but at least don't insert it percutaneously. There are several reports of persistent numbness or a neuroma of the nerve in a large series. There were 9 injuries, in about 937 patients, which brings it to about a 1% rate. And this is just a cadaver dissection showing the path of the nerve on the radial side. So when you're making your incision from the radial styloid, just make sure that you retract all the structures, including the first dorsal compartment, tendons, the nerve, everything goes dorsal. And then when you put your awl in or your drill guide in to take the entry, then the entry should be directed from a volar to dorsal direction, so that if you slip by mistake, you don't injure the neurovascular structures on the palmar side of the wrist. There have been reports of radial artery injury when taking the entry for the radial nail. So that's why you want to make sure that all structures go dorsal, and the inclination of your awl should be from a volar to a dorsal direction and not from a dorsal to volar. For the dorsal entry radial nail, the recommendation initially was to keep the nail flush, but what happens when you keep the nail flush is that the extensor compartment on the dorsal side of the wrist have a lot of tendons that pass through it, and you can injure the tendon if you keep the nail flush like this. And so we have had reports, and we have published this several years ago about cases of rupture of the extensor tendon, and this is one of the cases here. You can see that the undersurface of the extensor tendon is significantly damaged by the sharp edge of the nail. And then this is an example of an EPL rupture, which was then fixed by my partner, Dr. Cornwall, by doing a transfer. So the recommendation, if you're going to use a dorsal entry nail, then the nail should be around the Lister's tubercle, just proximal to the physis, but keep the nail bent at 90 degrees instead of keeping it flush. So on an X-ray, it should look like this. You bend it 90 degrees, so all the tendons, they pass around the bent part of the nail, and that way you can prevent an injury. Still, my preference is to use a radial entry nail and not a dorsal entry nail. As far as the size is concerned, then 2 nails should be of the same size. Each nail should be 40% of the canal diameter when you're using 2 nails. And for radius or ulna, where you're using 1 nail per bone, then each nail should be 2/3 of the canal diameter. So here is a case of a 13-year-old female, right hand dominant. She had a trampoline injury and had a right radius and ulna shaft fracture. And if you look at this fracture, this is a good fracture for nailing, but if you look at the size of the canal, it's very, very small. It's like 1.8 millimeters small. So here, when you try to insert a nail like a 2 millimeter nail, it might be really tough to put the nail across, and this is what happened when we tried to hammer the nail in. It separated the epiphysis because of the amount of force it would take to put the nail in. I had not seen a report on the normative sizes of the canal in pediatric patients in radius and ulna till this year. So this year a report has come out about the size of the canal, and in about 5% of the patient, the canal size is pretty small, and you cannot do an elastic nail safely. So it's important that you measure the canal size. If it's really small, then probably it may be better to plate this patient instead of putting a nail through a very narrow canal. If you get an incarcerated nail, which means that you are now across the fracture site, but you cannot impact the nail anymore, what are you going to do? You wait a little bit for stress relaxation, and then you can try. You can withdraw and rotate and reinsert the nail, or you can withdraw the nail and decrease the nail size, but don't keep on jamming the nail further if it's not going too smoothly. You can also cut the nail short. It's not like the nail has to always go across the entire length of the bone. As long as it crosses the length, which is equal to 2 times the diameter at the fracture site, then the nail should give enough support. So a short nail is okay, but don't try to jam it too much. Also, when you put the nail in the ulna, you need to remember that the narrowest part of the ulna is in its distal part, which means that at the end, when you're putting the nail and finishing your surgery, and you're giving the final 2 or 3 blows with your mallet, that is the time when you're going to get distraction, because the nail is going to be jammed distally. And so always check the fracture site once you finish the case, because if there is distraction, especially in ulna, it can lead to a non-union or delayed union. If the nail is too thin, then it's a problem as well, because it's not going to maintain this stability, which especially if you're going to be nailing, say, for example, the Monteggia fracture. So if you look at this example, the nailing of the ulna has been done with such a thin nail that the Monteggia fracture is not reduced. For Monteggia, you need a straight ulna, which means that you need a bigger nail, or you need a nail which is stout, like a Steinman pin, which can maintain the alignment. Here you can see that at the radial head there is still a loss of reduction because the nail is too thin. So this patient was revised. The earlier surgery was done at an outside hospital, and then this patient underwent revision. Here's an example of a 10-year-old boy, and you can insert a short nail like this. This is my patient. We did not insert the nail further because it was leading to angulation at the fracture site. We just left the nail like this, just this short, and then put a cast on, and the patient did fine. So a short nail is not a bad nail, especially with this metaphyseal diaphyseal junction fractures. If you try to put this nail all the way up to the entire length of the bone, you're going to have an angulation at the fracture site. So it's a good indication for a short nail. There are newer designs of the nail. This is one of the new designs. This was by Matazzo's son, and this design gives greater stiffness, and because it's not circular, it is easy to grasp it, and it has decreased the radiation in the operative time because the nail has a flat side, so it's easy to know which direction the nail is going, so you don't have to use the floor that often. As far as the nail material is concerned, the original nail is a titanium nail. The elastic nails were designed to be titanium nails, but Ender's nail are stainless steel nails. So if you merge the principles, you can do elastic nailing, which is balanced nailing, with the stainless steel nail. However, you need to know the properties of both the nails, that the titanium nail is not very easy to insert when it gets below a certain diameter, because then when you try to mallet the nail, it is going to bend because it doesn't have that much of the stability. It is more elastic than a stainless steel nail. So at times we would convert the titanium nail into a stainless steel nail. We would also like to use stainless steel nail for heavier patients and length unstable fractures, because it has shown to decrease the rate of malunion. If you look at this graph, it shows the elastic limit, or when would a stainless steel nail go beyond the elastic limit, and based on this, the modulus of elasticity of a titanium nail is almost half that of stainless steel, which means that it will take more force to put a stainless steel nail, but it would not bend. Here is a paper from our institution comparing the complications of titanium and stainless steel nail, and what it showed is that malunion was 4 times higher with titanium nails compared to stainless steel nail. And so in adolescent and obese patients at our institutions, we prefer to use stainless steel nails instead of titanium nails. Some other studies have not shown significant differences in the time to union outcomes or complication rate, and 2 studies showed malunion was less in stainless steel, but 3 studies showed no differences. So the jury is still out. I would just recommend that you pay close attention to the material of the nail you use. Both nails are available. For upper extremity, we prefer titanium nails, and for lower extremity in obese patients, we prefer stainless steel nails. What is the downside of using stainless steel nail? Is that it is a little bit stiff, so it can lead to iatrogenic combination, as you can see here. So if in a titanium nail, because the nail is more elastic, it doesn't produce as much combination as compared to stainless steel nails. If you do open reduction, you need to follow the patients closely. Look at this example. The patient had open reduction of the ulna, and this patient had a fall after 9 months, and the fracture was not healed enough, and it was going into a delayed union / non-union, and the patient had bent the nails. Now, what can we do at this time? You can remove the nails and you can plate the forearm fractures. The other option is that you can re-bend the nails, and that is also an option. You can bend them backwards, and then you can put the patient in a cast. In this patient, we did plating, but here is a report of a bending of the nails in situ, and there were several cases in this report, and the patients did well after they manipulated the fracture with the nails in situ. Here is an example of a tibia ORIF where the bone was almost coming out, so we opened it, we crushed that the comminuted piece that you see, the separate butterfly fragment with the black arrow. We morselized that piece and we used it as bone graft around the fracture, and at one point the fracture looked like it was healed, but then later on you can see that there is a refracture. So anytime you open the fracture, there is always a risk of having a delayed union and sometimes even a non-union. If you have a floating knee that you are going to be doing elastic nailing for femur and the tibia, you need to follow these patients very closely. Here is an 11-year-old boy who had a femoral shaft and a segmental fracture of the tibia that was fixed perfectly with elastic nails, and he did fine, everything healed well. But if you look at his follow-up x-rays, this is after his nails were removed, that you can see that it's going into a valgus deformity. If you look at when the nails were placed, it looked like it was okay, but when the nails were removed, you can see that it was going into valgus at that time. So we don't know whether it was an iatrogenic injury to the physis, but more likely it is the injury itself that causes to have a growth arrest, because if there is significant energy to fracture two long bones in the same extremity, then it can also damage the physis. So here there was a growth arrest, so we went ahead and took care of it, did a excision of the bony bar, and did guided growth, and the patient went on to have a neutral alignment at adolescence. But this is just to show the issues. Here is another example where the patient had elastic nailing, and not only the patient had valgus, but also had significant overgrowth of that leg. The right side is the one that had elastic nailing of both the femur and the tibia. So we first did a guided growth to correct the alignment, and once the alignment was neutral, we then went on to close the physis, did an epiphysiodesis, so that at final follow-up the patient has a neutral alignment and no limb length discrepancy. So we have, I've got another two examples of floating knees which had similar issues, either length issues or valgus issue. So be careful about floating knees, because they may end up with complications that you may not have initially thought of. As far as iatrogenic fracture is concerned, when you're inserting the nail, just be careful, because if you don't pay attention, you can have the fracture on the opposite side, opposite cortex. Here is an example of an entry side fracture of the humerus. Don't try to make too big of holes, and I prefer to use an awl. You can use a drill bit, but it's better to pay attention when you're putting the nail through. Here is an example of an 11-year-old female. And what happened, this is an unstable fracture pattern to begin with, and we tried to nail this patient in a retrograde fashion, but you can see how distal the fracture is coming. So we were not able to pass the nails in a good fashion. So we decided, okay, we'll come from the top, just like I was showing you the example of the supracondylar fractures of the humerus, that you can have antegrade nails coming from the top. We did that, and here is an iatrogenic combination. Now you have a distal fracture, unstable variety, with combination. The whole situation is unstable, and what to do now? So in this case, what we did, we gave up on nailing after about 1 hour of trying to pass the nail, and we went on to fix it with regular plates. We put interflex screws, and we used a plate. The patient did fine. But what I wanted to show here is that you may plan for elastic nailing, especially for unstable fractures. You need to have a backup plan. Plates and IFICS are easily available, so I would recommend that you always have something for backup fixation in case there is an issue intraoperatively. What next? Here is an X-ray of a patient who is undergoing elastic nailing, and everything looks okay here. One of the tip I would give everyone is to get orthogonal fluoroscopy. That means 90-degree fluoroscopy on AP and lateral view. Because when I did the lateral view for this patient, the nail was actually not in the distal fragment at all. It just was sliding onto the posterior cortex of the distal fragment and then went into the proximal fragment without any purchase in the distal fragment. And that brings us to the next point about orthogonal fluoroscopy. And it is also very important at the femur. You need to check the lateral view. Here is a case of the nail going out on the posterior aspect, and the patient had sciatic nerve symptoms because of irritation from the tip of the nail. So this is something that on an AP view it looked fine, but it was not checked at the end where the nail is going in the lateral view, and actually it was going out. Nail prominence is a big issue. It is one of the commonest complications of elastic nailing. Not only can it lead to irritation, skin sloughing, infection, osteomyelitis, stiffness, joint swelling, but it can also lead to significant scarring around the nail and arthrofibrosis as well. Here is another example of irritation of the tibial nail poking through the skin. If you look at the literature, this is one of the commonest complications reported. Entry site irritation in this report in 2004, 41 out of 79 patients had entry site irritation with 8 requiring reoperation. So how can you prevent entry site problems? The reason there were entry site issues is because the original recommendation of the Nancy manual was to bend the nails at about 70 to 80 degrees and sometimes even 90 degrees so that it's easy to remove the nails. And this is what leads to most of the complication, is bending the nail at the end. So instead, the modification that is recommended is to not to bend the nail at all, but just keep it flush and cut it and impact it so that it lies flush to the metaphysis, just short of the physis, but not to bend the nail. How about the long nail? Now, this is a 14-year-old boy with an open fracture. I did elastic nailing, antegrade fashion. Everything looked fine on AP and lateral views, and I was happy. The patient then underwent removal of one nail, and I couldn't remove the other nail because it was a little bit further in the bone. But 6 months later, the patient came back because he had knee pain. Now, at the time of insertion, I did not realize, but if you look really closely and get a knee X-ray, you can see the nail is actually coming out in the trochlear area. And this patient had knee pain, but I could not remove this nail when I tried to remove the first nail because I couldn't see it from the greater trochanter. It was further in. So I did open up the knee joint a little bit and remove the nail in a retrograde fashion. So here is the example. Here is the nail was coming out right there just above the trochlea. I was able to grasp the nail and pull the entire nail out from distal end. But this is something that could have been avoided pretty easily. Here is another example, a 12-year-old boy who had a football injury, underwent nailing. This is the last X-ray, fluoro X-ray that we have. But when the patient came for post-op, this is where the nail was, and he was having pain with pronation and supination. It's not because of the collapse at the fracture site. It was because the nail was impacted after the last fluoro section. So when you think that everything is done, then you just cut the nail and you impact it a little bit. And here what happened when you impacted the nail actually went through the radial head and into the radiocapitular joint. So this patient underwent revision and the nail had to be backed out. This is his X-ray 2 months later. He did fine, but he underwent a revision surgery. And the last point is about removal of the nail. We do tend to remove these nails, especially around 6 months' time. Unless it's a pathologic fracture. If it's an OI kid or has a bone cyst, then we would leave the nails in to give protection. Here's an example of a 13-year-old male right-hand dominant who had injured his non-dominant side with fracture of the radius on the ulna, and this is how it was nailed. The patient did fine and the fracture went on to heal. But then the nail had kind of got buried in the bone at 4 months, and we did not remove the nail because it was difficult. It is difficult when you have a nail like this, and we could not remove the nail when we went to remove it. The patient came back 4 years later because he was snowboarding, and now he has this. He had a fracture at the tip of the nail. Now this fracture was not displaced, so we were okay, and we retained the nail and casted the patient, and he did well. Just last week I saw a patient who is about 3 years out from elastic nailing, and the tip of the nail, which was in the metaphysis, is now in the diaphysis. It is protruding and it is causing irritation. So I've booked the patient for removal of the nail, but it is difficult when you have to remove the nail after 3 years. So my recommendation is to remove the nails at around 6 months when it's easy. This patient, as I said, it was treated conservative and he did fine. One of the tips, when you can't see the entire tip of the nail, is to put a suction tip onto the tip of the nail, and you can then clear the tissues around the nail tip, and you can also bend it a little bit, which makes it easier to remove. So we use this suction tip to help us clear the nail tip and remove the nail. So in summary, the elastic nails or the titanium elastic nail system is based on sound biomechanical principles. Attention to details is important, and complications can happen to anyone. We need to recognize these complications, treat the complications, and learn from it. Thank you.
To a talk. Any questions from the audience or faculty? For Dr. Sheetal. You can, also speak from the mic, and I will repeat for Sheetal. Sheetal, as people are ready to ask questions, I have one question for you.
Yes.
In forearm nailing, especially in Asian countries like in India or Bangladesh, especially in female children, the canal sizes are very narrow, and you made mention about this. And one of the problems which we face is the bent tip of the nail, which actually helps us in reduction many times, but it makes the negotiation of the nail very difficult. What do you do, when you come across such a situation? What should we do?
You can actually take the bend out of the nail, like you can decrease the bend of the tip of the nail to make it easy to navigate it. You can also use, if the canal size is narrow, you can use a K-wire. You can, take down the sharp edge of the K-wire, like the trocar tip, and so that it doesn't. If you have a very sharp tip, then that's the other in the cortex. So you can cut the K-wire tip, and you can try to use the K-wire as a nail, and that is another option. But you're right. If the canal is small and the tip is bent, it's difficult to navigate.
Any other questions?
Thank you, sir.
Please ask.
For your nice presentation. My question is that when you make the operation for limb lengthening and shortening of the limb, after removal of the epiphyseal bar, you have shown that you have done the stapling of the opposite
to control limb length discrepancy, and once the discrepancy is corrected and when you remove the implant, will the growth resume back in those patients? How do you manage?
So if you're using an 8 plate, for example, then you're not violating the physis at all. So the chances of you having any significant disturbance of growth is much less. When you use the transphyseal screw, especially in younger patients, in theory you are putting a screw through the physis, so you can have a growth arrest or growth issues. The thing is that whatever you do, whether you use the plate or the screw, the follow-up is really important, because not only it's a growth disturbance, but it is known that you can get rebound deformities, or you can get overcorrection, which would keep on correcting even after you remove the growth modulation device. So it's a little bit unpredictable. I've not seen a complete growth arrest from using one of these implants, but I have seen after removing one of these implants, I've seen both rebound and I've seen overcorrection as well. So it is important that at least you observe this patient and you let them know about the potential for continuous deformity, either worsening of the deformity or deformity in another plane, and for which you need to follow these patients at least for 6 months after you take out the device.
Oh, thank you. So, it's better to do it around 2 years from the skeletal maturity and not too early, because sometimes this could be unpredictable. Any tips, Sheetal, about implant removal? Putting nails is easy sometimes. Removing is much more difficult. Are there any special devices you keep ready? What do you instruct your nurse to keep ready before planning for?
Yeah. So the most important thing is to when you're putting the nail in, you want to make sure you don't mallet it or impact it in all the way in the canal. You want to leave about 1 centimeter of the nail out of the bone when you are putting it in. So that's the most important tip, because that would make everything easy. The second thing is don't wait for too long. Once you see the healing, after 6 months you can remove the nail. If you wait for a couple of years, it's going to be difficult. As far as removing the nail, one tip I gave you was to use one of the suction tips. Now sometimes if the nail is further buried, you can use what is called a coring reamer. It's in a broken screw removal set. It's like a reaming device which has a hollow core, and you can put that on top of the nail and you can ream the bone, and then you get access. I hope that you never have to use it, but if you have to use it, then that's another device you can use as a coring reamer.
Yeah, so that's how we call it as hollow mill. And those who don't have access to the AO set, a simple hollow mill is also available on Amazon as a non-orthopedic instrument, but it's good to have various sizes of these which will go over the nail and core it. There are some more questions. I would request, please ask the question, say your name and ask the question. Yeah.
Thank you, sir. I am Dr. Arifur. I have 3 questions regarding the elastic nail.
Yes.
So sometimes in femur, when there is extended indication of fracture fixation with elastic nail, like more subtogatoric or more distal fracture, we cannot keep the spindle center in the fracture site. What is your recommendation regarding that, sir?
Okay, so we'll do one question at a time, so it's easier for Sheetal, because you don't want to have too many bouncers. We have already suffered against Bangladesh last night, and Sheetal wants to have a safe bet. So first question is, the fractures which are at proximal femur or distal femur, doctor is asking that it's difficult to get a spindle, and what's your strategy, in those cases? How do you manage with elastic?
So the nail contouring is important. When you contour the nail, the apex of the contour should be at the fracture site. So you can basically put the nail on top of the bone and kind of estimate where is going to be the fracture site on the nail, and that is where the apex should be when you contour the nail. So regular contour, you can just bend the nail and the center of the nail is going to be the apex, because most of your fractures are diaphyseal. But if you are doing nailing of say proximal or distal femur, then the apex of the contour should be at that level. It may not be exactly, your maximum spread of the spindle may not be exactly at the fracture site. It's fine if it's a little bit more proximal or distal, but it should be still, the nail should not be crossing at the fracture site, otherwise it behaves like one nail.
Right. Second question?
Yes, sir. My second question is that in your series I have seen that most of for radius ulnar fracture, your ulnar entry is proximal. But for myself, when I entry from the proximal side, my orientation of the fracture and reduction makes me difficult. What is your opinion regarding the distal ulnar entry?
So, did you hear that question? The question is for the ulnar nailing. You've shown proximal entry, but the question is, he says that my fracture orientations, because of the flexion of the elbow, gets into issue. So, the question is distal ulnar entry also feasible, or are there any advantages of one over the other? What do you prefer?
It is feasible. It has been reported. A lot of centers use a distal ulnar entry, and it makes it easy because you can keep the elbow extended during both the radius and the ulnar. The only thing is you need to open up a little bit on the ulnar side, because the distal ulna, there is a small branch there of the nerve, the dorsal sensory nerve there, so you make sure that you don't get the nerve in your way. But it can be done, we find it easier to come from the proximal side when you're doing the ulnar nail, but that's how, because we are trained that way. But if you are new in your practice, or you want to have a different approach, then and especially if you don't have assistance, then keeping having a distal ulnar entry is fine. It has been reported, it's been used pretty much in a lot of centers in Europe. So not a bad idea to get the nail from the ulna.
The only issue is distal ulna, the diameter is very narrow and proximal is wide. So it's easier to go from wider to narrower diameter. One of the tips, again, Sheetal, I want to share is if you use a regular elastic nail, the length is long, and with bent elbow it's difficult to pass that nail. So what I do is, I estimate the ulnar nail length and cut the nail around 6 to 7 centimeter longer than the length of the ulna, so that it's easier, a shorter nail is easier to maneuver from proximal to distal. And many times again with ulna the issue is because of the mismatch in the diameter, you will have a good hold distally but not so good hold proximally. So the cut nail sometimes you can stack in the proximal ulna to give more filling and more stability to the ulna fracture. What is the next
the other tip I would recommend is usually we do the radius nailing first, because it's a deeper bone, we don't have too much control. Right. So difficult bone needs to be nailed first.
Yes.
But what you do is when you pass the radius nail, don't pass it all the way through. Just pass it across the fracture, maybe about a centimeter, and then leave it there, and then do your ulnar nail, so that you can still have some flexibility at the fracture site. Because once you put your radius nail all the way through, then if you try to put your ulnar nail and you can't get reduction, it's very difficult to maneuver the fracture, because now one bone is fixed. So just pass the radius nail first, just cross the fracture and leave it there instead of inserting it all the way, and you would still be able to manipulate the fracture when you're putting the ulnar nail. So it will make it easier.
Thanks. What is the... Sir, next.
For nice tips. My last question is that sometimes for creating the rotational stability, we put external fixation for femur fracture with elastic nail. Do you think, what is your experience regarding, is there any increase of infection or osteomyelitis putting the external fixation with the elastic nail at the same time?
Right. So putting external fixator with elastic nail for length unstable fracture, does it lead to increase in the infection or stiffness at the knee joint?
It's used for temporary fixation, not for definitive fixation, just to maintain the length till the fracture is glued. So if you're using it for probably about, I would say 3 or 4 weeks, then the chances of infection and stiffness are less. Having said that, my preference, is to slide a plate. I showed you the first case.
Right.
And so that I don't have to worry about taking it out sooner. You can leave it as long as you want and it won't interfere. So I don't prefer an IFICS, but I don't think that if you just use it for 3 or 4 weeks, it's going to be that big of an issue, the infection or the stiffness.
Yeah. I think we'll have next 2 questions because it's 8:45 and one.
Sir, I am Dr. Bipram Majumdar, registered knee. My question is, we know that the diameter of the nail in case of front fracture, it should cover 40% of the diameter of the medullary cavity. Sometimes we face that the medullary cavity of the radius are not same. In that case, can we use different diameter nail in case of front fracture?
Yeah, so this question comes from a registrar at Nitor, and Nitor is one of the world's definitely Asia's largest orthopedic hospital. How many beds do you have here? 1,300 beds. And that's it's a trauma and orthopedic hospital.
1,000 beds.
1,000 beds, yeah. And the question is also, very magnanimous and very interesting to match the bed strength. And he says that many times the diameter of radius and ulna are different. They are not same. And is it okay to use different nail sizes of nails in radius and ulna in that case?
Yeah. The radius ulnar nail is not balanced nailing. So your diameter of the radius of the ulnar nail is based on the diameter of the radius of the ulna. It's 2/3 of the size of the diameter. It could be different. So it's only when you're using two nails in the same bone that is when the diameter have to be the same. Not for radius and ulna. It could be different. It's fine.
So I think with this we end this session. Sheetal, thank you very much for
great question.
I know that it's late on Friday night for you, but being awake and having this important lecture, and there is an invitation now, not for a web lecture, but to come to Bangladesh for the next IFICS, and with a trip to Sundarbans to see the man-eating tiger of Bengal. So most welcome to travel to Bangladesh the next time. There is one more question. Yeah, we will take it.
Thank you, sir. I am Dr. Yunus Ali. I am Assistant Professor of Orthopedic Surgery in Rampur Medical College Hospital. My question is, sometimes it's difficult to put a titanium elastic nail in radius or in ulna due to its less size. It is less stiffer. Sir, advised to use K-wire. May I use rush nail of titanium instead of a K-wire?
The question is again, in forearm nails, if 10 nails are unavailable or they are difficult to put, so you suggested use of K-wire. Can people also use rush nail, titanium or stainless steel rush nails? Rush nails are like thick nails with a bent tip.
Yeah. I mean, as long as the nail is flexible, it's very difficult. So Steinman pin, for example, it's very difficult to use a Steinman pin unless you want to keep the, you're just doing the ulna. So I think the rush nail, I don't know about the elasticity, but K-wire certainly you can use. There have been a lot of, I've used K-wire myself, if needed, like it's really small diameter. So K-wire is not an issue, and same with, rush nail if they're elastic. I don't know about how rigid they are.
So
you may have more experience there.
Yeah, so there is a difference in the metallurgy between flexible devices and rigid devices. Devices such as shank screws and Steinman pin, they are manufactured using cold forging technology. So they are rigid. It's the same metal, but the forging is different. And when you use a metal with a different forging, you get elasticity. And rush nail, even stainless steel rush nails are pretty elastic, and they have a beveled tip so that the entry is easy. It's not bent, but you will have to bend it on your, for negotiation, but it is flexible. So I think, Sarwar, any words to Sheetal here? Just speak to him, yeah.
Good morning. I think I should say good evening, Carol. Sheetal. Thank you very much. And let us get prepared for a Sundarban trip with this IFICS next year.
Sure, that will be fun.
And from Premal and Sandeep here as well, we can probably, yeah, just, okay. All right. Yeah, so I hand over mic to Sandeep and Premal to say hello to you, and then we'll wind up.
Hi. Hi, Sheetal.
Hello. Hi.
Hi Sheetal, how's Kshetrali doing?
Good, how are you?
All fine. I owe you a shirt, I just wanted to remind you.
Yeah, but I'll have to send you the size.
I underestimated the power of the common man.
You don't ask the size of the shirt to a fat man. Okay?
I assumed.
Just like you don't ask the age to a girl, you don't ask the size to a fat man. What size you wear?
Get the largest one available.
Yeah, get the largest one.
All right.
No, thank you.
Sure,
That's fine.
Thank you. All right.
Okay, bye-bye. Thank you.
So thanks Professor Sheetal Parikh sir and Professor Tarun Nagda and his team for a very nice moderation of the previous web lecture. Now I am requesting Professor Tarun Nagda and Dr. Kambuchaman Tushar sir to conduct today's session. This will be on femoral shaft fracture.
Hello.
till Tarun sets up, I have one question for the last gentleman who asked about the titanium rush pin. So why so fascination about titanium? Titanium is a good material, but I don't see much advantage of that except 10 nailing in pediatric, because I have seen people using titanium KYs which bend very commonly. People use titanium plates which just don't come out, locking plates, and they create a very big problem. So what is the advantage of titanium rush pin over stainless steel rush pin? If I'm little unable to understand. No sir, the thing is, if you read the original manual of Nancy nails, the first Nancy nail were stainless steel. That nails were then converted into titanium. I think rush pin was discovered in 1940s, and probably one of the implants which has stood the test of time for almost 60 or 70 years.
Also, is also the solution of putting the titanium nail or titanium plate over
So I think it's just extension of the AO principle in pediatric trauma.
I'll give you a little bit of background to that. I think as a third world country, India, Bangladesh, the AO has stopped manufacturing most of its implants in titanium because of the problems of removal and bone overgrowth. So all that unused material they are dumping on third world. Just listen to me, and they are selling it as a very highly new thing, whereas it is actually discarded material.
Femoral shaft fractures are common pediatric injury requiring hospitalizations. Among so many injuries, 5% of the total injuries occurring in the pediatric groups. Historically, treatment has relied on non-operative approaches due to the femoral pediatric group has more remodeling and healing power. And we use there are so many classifications. We use nowadays the AO classifications, which is diaphyseal fracture. We have to divide into two groups: complete transverse and complete oblique or spiral. And each of them are divided into again two groups: simple or multifragmentary. Before deciding treatment modality, we have to take some points in our that the age of the patient, the size of the child, the fracture location, condition of the soft tissue, configuration of the fracture, family support environment, and experience, skill, and the performance of the treating physician. The treatment protocol is divided according to age. 0 to 6 months of age, we can use pelvic harness, which can be applied easily, and the fracture only needs 5 weeks to heal. And also you can use spica cast. From 7 months to 5 years, we can use spica cast and also use intramedullary rods where it needed, and also internal fixation and external fixation in case of open fracture. From 6 years to 10 years, flexible intramedullary rods is the first choice, and if we cannot use that, we can use compression plate fixation, submuscular breathing plate, and also external fixation in case of open fracture. From 11 years to skeletal maturity, intramedullary rods and plate fixation. And each operation there are some complications, and among them the limb length incapability, unacceptable ankylation, rotational deformity, non-union, delusion, and others. And accelerated range of displacement, which you need to know, that is less than 2 cm of shortening and 20 to 30 degree of angulation according to age group. Thank you all.
So, as you see these slides, the word on the top is not a spelling mistake. It's not a typo error. Of course, this is pediatric femur fracture, but what we are going to discuss are tricks, pediatrics, so tricks of the pediatric fractures while treating femur fractures. So again, it's the third most common lower extremity fracture, but it's important because the other fractures are fractures of the foot and tibia. So this is the most commonly operated fracture, and that's why this is important. And there are some differences between pediatric femoral fractures and adult femur fractures. The first is in adult femur fractures, the type of intervention is not dependent on the age. Your tools are the same, but in pediatric fracture with different age, for the same fracture the treatment is different. For a 6-month-old child, 6-year-old child, 12-year-old child, the treatment is going to be completely different. The healing is very rapid here. Around in 4 to 6 weeks the fracture will heal, and that's why many of these children start weight bearing very early. If you give them a walker, they will hold walker in the hand and walk. The acceptability criteria, Zaman has told us that 2 centimeter shortening in pediatric femur fracture in a child less than 10 years you can accept. In an adult, you will never accept a 2 centimeter shortening at end of your fixation. Okay? Around 20 degrees of angulation is also acceptable. A lot of rotation also get accepted in femur fracture because hip is a 360 degree joint. If you had an angular deformity in tibia, it would be very obvious. But the rotational deformity in tibia would be obvious, but rotational deformities in femur are not very easily obvious. Okay? Muscle forces are important to understand because in neonates the hip flexors are very tight, and your treatment method has to adjust to the muscle forces rather than muscle forces having adjust to your treatment methods. Remodeling happens, overgrowth happens. Many times you will see that fractures which are reduced anatomically, the limb actually becomes longer than the other side over a period of time, and this also should be taken into consideration. And alignment and rotational matches are important. So, if you really see this becomes trauma and trauma of femur fracture when we are dealing with. Professor Stiley just, said that what is the treatment method you will use? There are multiple treatment methods available. So one which controls alignment and length, the one which is comfortable to the child, which is convenient for the family and causes the least negative psychological impact possible to the family and the child and also to the doctor. That is the method which we should choose. Now, in terms of making it simple, there are 3 things which are important, and these are L, S and D. The L is for length. You should have a length maintained, not more than 2 centimeter shortening. It should be a stable fixation. It should not, if unstable fixation will go for a non-union. In fact, Sarovar just sent me a case on WhatsApp. Elastic nail done in a child and fracture is still not united after 3 months because the nails are very thin. So it should be a stable fixation. It need not be a rigid fixation, but definitely a stable fixation. And you should not have deformity more than the acceptable limits. And these are the limits of acceptability, and you would realize that Zaman, it's not one figure. With every age, the figure keeps on changing. For example, AP angulation in a child less than 2 years, 30 degrees acceptable, but in a 12-year-old child, only 10 degrees acceptable. So you must realize the acceptability criteria change with the age. So these are the weapons we have available to treat these fractures. This is not working, is it? I think batteries now. Just please check. And let's start with the cases. So this is a neonate with a femur fracture, and this is how the child has presented to you. There is deformity, the child is not moving limb. So I want to know from the audience, how would you treat this? What are your options? The first option is Gallows or Bryan's fraction. How many of you would prefer that? Raise your hands. Okay. Hip spica. Paulic harness. Many people Paulic harness. Strapping of thigh to the abdomen. A very simple way to treat this. So I want to ask the Paulic harness, how easily is it to get in Bangladesh? Not so easy. But still it is the preferred method. And how soon you can get? If you order a Paulic harness today, how long will it take? 10 days, but by that time a neonatal fracture will heal. So how do you manage the child till then, till the time you get Paulic harness? So you have to have some alternate methods. Now this child, I'll tell you, it was the surgeon chose method B and he applied a spica like this. So I want to know from Premal, if a neonate is treated like this, what are the issues in this treatment? What is incorrect? How if the neonate is treated like this?
Because I think sometimes for even neonate we overrate the ability to have a remodeling. Because this is almost a 90-degree deformity. The proximal fragment is grossly flexed because the psoas is always contracted, because neonate's position, unborn child is grossly flexed in the mother's womb, and that flexion deformity after birth does not go immediately. So if you want to match the proximal fragment with the distal fragment has to be grossly flexed, and that cannot be done by hip spica at all.
Absolutely. So this is a child which of course healed in spica. Mother had a tough time managing, with regular potties, to managing hygiene and comfort and feeding the child. Okay. And at the end of 1 year, this is how the child is. The limb is short, he is having some limb. And if you take X-rays, you can see there is a 90-degree deformity in lateral plane. AP looks okay, but laterally there is so much deformity. And this deformity has come because simple reason that when a neonate has a fracture, the psoas is very tight. It pulls the proximal fragment proximally into flexion. And you need a method which will put the hip in 90-degree flexion. And that's why people use methods like this. Bryan's traction, which puts the hip in 90-degree flexion. But what are the problems with this Bryan's traction? Sandeep, what do you feel? Do you still use it? I think all of us have used this in KM and SIAM during our residency, but we don't use it any longer.
Yeah, for small children this becomes a little uncomfortable for the mother to feed, nurse, carry, as well as the problem is that there are literature reports of compartment syndrome because of tight bandages.
Right.
So better avoided.
Server, do you still have them at Nitor? Bryan's traction, where is server? Professor Query, do you still use it? Is it still used? Because you have seen the different treatment method over ages.
Yes, not now in neonates, but I still use in 1 year, 2 years old child.
Okay.
For 6 months, 6 months to 1 year. After 1 month, yeah.
Right. So an alternate treatment, if you don't have this Bryan's splint available, or if you feel it's uncomfortable or dangerous sometimes, is just to put them in a poly.
Put them over a pillow for a few days and
excellent. To keep the hip in flexion, you can use a pillow, you can use a strapping, you can use a splint.
Within 5-6 days it becomes sticky.
So nowadays we have ready-made poly harness available in Bombay. You can order it on Amazon and you can apply it. The only issue with this is child doesn't have complete immobilization, and the child is irritated for 3 to 4 days and it cries. You can see from this picture that child is not very comfortable, and what you can do is tie a cardboard on the lateral side to support the thigh, and I found that a useful trip if I have to manage them in poly harness. The whole learning from this case is that if you maintain the hip in 90 degrees flexion, these fractures will heal well. This overlap, shortening, everything will get corrected, and you will not have a deformity which you have to otherwise can be really ghastly if you treat them with a traction or a plaster in extension. That is something which we don't want. And poly harness, I am sure it is here also. You can order it over the counter, and you should be able to get it.
Yeah. One question to Taral in between. When the subject of neonatal orthopedics association will come?
Neonatal Orthopedic Association. I think from adult orthopedics we have graduated to pediatric orthopedics. Soon it will be neonatal and then intrauterine orthopedics. So that will also come. But I think by that time we all would have retired and probably
not in my lifetime.
Yeah, absolutely. So when it comes to children, up to 6 years. I think if you have a child like this, 4-year-old child, what would be the treatment option? Again, I want to give choices to people. Would you manage it in a traction, just a Buck's traction or a Thomas's splint? How many of you still do that? Okay. How many of you do a traction for few days followed by spica? Yeah, many of them. And what kind of traction is it? Is it Thomas's splint or a simple Buck's traction? Skin traction, right. How many of you do immediate hip spica on day 1? Some of you. And is it under anesthesia or without anesthesia? Under anesthesia. Under anesthesia or sedation. Anybody wants to do elastic nail? Somebody in 4-year-old child, people are doing? No. Should not do. External fixator? And since Dr. Bari is here, I have not given the option of Elizarao. Okay. So this was treated in Thomas's splint. The problem with Thomas's splint is, with time it becomes loose, and if it's not cared for, it gives rise to angulation. And this is a significant angulation at 2 months, and this could have been avoided if the patient was either converted to spica early or treated with immediate hip spica. And of course this is coming down after 2 years. From 45 it has come to 30, but if there is a bump, child doesn't have any other issues, and we hope that this will remodel over a period of time. But imagine that this child becomes an adult and has femur shaft fracture. It will be very difficult to nail this patient, and it's important that we avoid such kind of deformities. So this is another 3-year-old child, and this was treated with immediate hip spica. Okay, so we have given the spica in almost 50 degrees of flexion, 45 to 50 degree of flexion, and you realize that there is an overlap. It's not perfect reduction, and also there is recurvatum because of overflexion. I've given more flexion than what it was required. Okay, so this is the situation. How do I manage this? Premal, in this situation, at 1 week or 2 weeks, should I change the spica, or this, you think this overlap is okay, this angulation is okay? What would you do?
I think sometimes it is very difficult to take a lateral X-ray with hip spica on.
Yes.
But if you feel that is not a acceptable angulation, I think rather than repeating spica again, which requires GA, you can always wedge it.
Wedge it. So we did that. So you do wedging. You cut 2/3 of the plaster from anterior side, and as you can see this gap, and I use a syringe which is cut. You put it in the gap. So syringe has a flange, and the advantage of using the flange is that this syringe will not go inside and poke, and you don't have to have wooden boards or wooden wedges. So this is something which can be cut to the size. It's readily available. It is cheap, and it is from a discarded material. So the angulation is corrected, but the shortening is not corrected. And so 90-90 spica I don't use nowadays. Initially I used to use, but I feel it gives rise to over reduction. With 90-90 spica, there is also a chance of vascular compromise because the knee is at 90 degrees, and popliteal artery sometimes can be at a problem, especially if you're molded too deeply into the popliteal crease. So this is how I manage my femur shaft fracture. The proximal femur shaft fractures, subtrochanteric or high fractures, I give 45 degree flexion. In mid shaft fractures I give 30 degree flexion, and distal femur fractures I give 20 degree flexions when I am giving my spica. So what happened to this child? Over the period of time, you can see that the fracture heals and it remodels. He is able to sit cross-legged, doing everything, and in 2 years time the length also comes back. So there is over lengthening, so you should not worry about limb length discrepancy. And you can see that the femoral shortening can be accepted in femur shaft fractures up to almost 10 years age. After that, the amount of shortening can be accepted becomes problematic. The frontal plane angulation can be accepted almost from 30 to 20 degrees up to 10 years. but after that the acceptability limit becomes low and low as you reach the maturity. So this is a femur fracture in a 6-year-old child. Again, choices here: immediate hip spica, nobody; Thomas's splint, traction followed by spica; elastic nail, okay, alright, elastic nail and external fixator. So this patient, I'll tell you, I give you a now little twist to the story. This patient had come during COVID time, and during that time we did not have anesthesia available. All the beds were full, no anesthesia happening. How would you treat this patient? If elastic nails you cannot do without anesthesia, a spica you cannot apply without anesthesia. So in this child, what we did was put this patient in a Thomas's splint. The date is wrong here, and after 2 weeks we converted that splint into a single leg spica. Okay, so this is a single leg spica which allows the child to walk, allows the child to sit in a car, rickshaw, in a public transport, and be mobile, and that's how she healed up, with lengths absolutely fine, rotations correct. So this is a method of choice for me now in children less than 6 years. I don't put elastic nail, I don't put immediate hip spica, I don't even admit them or take them through anesthesia. We just apply Thomas's splint in the OPD, okay, and give all the instructions and send the child home. I see them every 3rd day, and at 2 weeks in the OPD we give a single leg spica and send the child home. So for length stable fractures, or where shortening is less than an inch, where there is not comminution, where the fractures are stable, this treatment works very well. It saves you admission, saves you anesthesia. I know that even at Nitor, the OT time and anesthesia times are a problem, and this method can help you to reduce the number of your admissions. So this is a 7.5-year-old child. Now somewhere this was managed in spica. And what are the issues here? Premal, this patient was managed in spica, 7.5-year-old child. This is how it was managed.
I think this angulation will have some issues. The second thing is I'm not very comfortable with the rotation here. So
how do you assess rotation on this X-ray? How do you come to know? Of course we can see there is a shortening. Everyone can see that. Everyone can see there is an angulation, varus angulation, which is quite a bit and causing a limp. But how do you assess rotations on this?
Radiologically, it may become a little difficult. The best way to judge would be clinical,
Yeah, clinical. But radiologically also, if you see AP of the knee and if you see prominence of the lesser trochanter, you know that there is a rotational problem, but you don't know how much it is. But if you see clinically, now you see that this child has almost 50 degree of internal rotation deformity. Okay, this child cannot sit cross-legged, because cross-legged sitting involves external rotation, and there is a significant deformity, and the child is walking with toes pointing inside. So how do we manage this, Premal? Should we just observe and see, will this correct? What will happen over a period of time? This is at 6 months following the fracture.
Rotation and angulation are less likely to correct because it's a mid shaft.
And length?
Length is sometimes you may get about a centimeter or so because of the overgrowth.
So would you advise surgery to this child?
So I would just wait for about a year or so, and if that is not giving me enough correction, I think the best will be to...
Why wait for a year? Meaning, why not now? Why not the fracture is healed, you know that there is shortening, angulation, rotational problems.
So maximum hyperemia which happens is in the first year of post-injury.
Absolutely.
So whatever natural recovery has to happen would happen at about 1 year. After that, less likely to happen.
Yeah. So we waited not just a year, 2 years. The reason is that lot of length issues will get corrected by that time. Lot of angular issues also will get corrected, so that your treatment becomes easier. You don't have to deal with too many issues. So at end of 2.5 years, this child had rotational problem, 3 centimeter shortening, and this child had a varus deformity. So how do you deal with all these 3 things together? Okay, so what we did is we passed a rush nail, a stainless steel primer, stainless steel rush nail, and we went till the fracture site, and at that time we did a osteotomy, percutaneous osteotomy at the fracture site, corrected the angulation acutely, passed the nail through and through, and applied a simple monolateral fixator for this child. So you can see this is the patient at end of the surgery. Now you can see with AP of the knee, the hips also look normal. The hip rotation is corrected, the varus angle is corrected, alignment is maintained, and you have fixator in place. Now you can distract, and distraction osteogenesis will work here to give you the length, and once the limb length is equalized, again I remember Professor Bari's words that comfort is in hand of the surgeon. So you can see this child is very comfortable with a monolateral fixator with an intramedullary device, and then he healed well, and we maintain this IM nail because there is a high rate of refracture after femoral lengthening. So whichever method of lengthening you are using for femur, may it be Elizarov, may it be monolateral fixator, always maintain an intramedullary nail inside to prevent the refracture in these children. So now you can see the rotation.
Just to add to the question which somebody asked about infection with external fixator temporary.
Right.
And you have used an intramedullary nail and lengthened, so you must have kept fixator for almost 3 to 4 months.
Right.
So what is your experience with?
No, nothing. If you are the direction of the nail is always anterior because the bow of the femur. So if your shank screws are going in the posterior half, and if you take care of the pin tracks, I don't think there is any issue in children. Most of the time we don't get pin track infections. Yes, that point is. So this is a 7.8-year-old child with femur fracture. So this is a femur fracture. Again, what is the choice of method? Yeah. I think how many for A quickly? B, how many for C, immediate spica? D, elastic nail. Most of us want to do elastic nail. And this mother told me that, doctor, I want the treatment. My child is a tennis player. I want perfect limb lengths. I don't want any change. So what would you prefer, a nail or a plate? Age of the child is 7.8 years. Plate or nail? How many for nail? How many for nail? How many for plate? Yeah. So plating we hardly do in femur fracture, and I did this nailing. I thought I did a reasonable job. Of course, there is a good spindle formation. I had read all the books, and I did by the books a good nailing. You can see that proximally the tips are in opposite directions. On a lateral view also, one tip is facing anterior, the second is posterior. So I maintain the bow of the femur. There is the lateral nail is little bit protruding, but otherwise this child was very well managed, and he healed well. You can see within 4 weeks he started walking, and he started growing well, and the nails slowly kept away from the growth plate as the child was growing, and we were all very happy. Every time his mother would come and she would have smiled and was very happy, and we also removed the implant. But when we removed the implant, the mother said, sir, there is some problem with this child's walking. And I examined the child, there was no genu valgum, Sheetal showed some cases, no genu valgum, rotations were perfect, there was no problem. But when I measured the length, this child had a length longer by 2 centimeters. Okay, longer by 2 centimeters. The premal, is this, what is happening here? Why? I gave a good length to the child. I have not distracted it. Why did the length?
So over lengthening of the femur is described, but it is more
not very common.
Not very common. So there is a large meta study in which over lengthening was studied. More than 1 centimeter limb length discrepancy was found to be extremely rare. So you are one of the not so lucky guy for this
the
case.
patient.
For this case.
And how do we manage this child? Is now 9-year-old. Should we manage it?
Again, you should wait for 2 years, and if it's symptomatic, you can just put temporary 8-plate or screws to shorten the same side.
Right. So what we did is, in this case, we put 2 8-plates side by side to control the length. So patient had third surgery. First surgery was nailing, second was implant removal. The third surgery was putting these 8 plates, and he completely corrected. We removed the 8-plate, and now this child is 19-year-old. He plays in India's ATP circuits, and he is not required any other surgery after that. So finally I was able to give equal leg length to the mother, satisfaction, but after 4 surgeries for this child. So this is a 6-year-old child, and this is lower femur fracture. Okay, so how do we manage this? How do we manage? Doctor, how do you manage? What is your option? 8-year-old child. Monolateral from antegrade. So what is the option the audience has? Any other option? How would somebody plate this 8-year-old child? It is an option in lower femur fracture. Plating is also an option, but nailing can also be done. And how do we do nailing is little different here. So you bend the nails, as Sheetal showed you. You bend in such a way on patient's leg so that the maximum separation is at the fracture site. Of course, it's not going to give you spindle, and you pass this nail from the trochanter antegrade. You make a window of around 1 centimeter below the trochanteric apophysis, and put one nail as C shape and the other nail as S shape. Okay, so one nail goes as a C shape and other nail goes in S shape fashion, and you will have this Y configuration. So you will not be able to get a separation at the fracture site. Sometimes you get even crossing over at fracture site, and many times you see that the distal fragment goes in little recurvatum, and a simple bracing would help these children, but ultimately this heals well. It's possible to maintain length and treat this child. So the strategy is different when you have lower femoral fractures. Now this is a femur fracture. I'm going to show you this video. So this is this femur shaft fracture, compound femur shaft fracture in a child who is 10-year-old. And again the problem here is, what do we do? Should we do plating or nailing? And we decided to do nailing for this child because this child had multiple other injuries. He had also a lot of degloving along the pelvis, and you can see there is a combination. So some of the tricks of this fixation I am going to show you. So this is the child on traction, and we planned for 2 nails because it was not possible to do this as antegrade nailing. We decided we'll do a retrograde nailing for this child. So the way we do it is, we put the child on fraction table, we measure the nail lengths, and this is where the apex is going to be. You measure the least canal diameter, and 40% of this is going to be your nail size. So this is all calculated because the canal diameter was 8 and 40% is 3.2. We decided to use a number 3 millimeter nail, and we bend these nails. So this is my entry point. Entry point is 1 finger breadth above the level of the top of the patella, which roughly corresponds to 5 centimeters from the growth plane. Okay, so this is how roughly you will do a measurement for the entry point. I generally pass a K wire through and through, and this K wire should be passed not in the center of the shaft, little posterior. If you go anterior to the midline, then you will come across suprapatellar pouch and your knee will become stiff. So you go little posterior and then pass a cannulated drill, and over that you pass a cannulated owl. So now you have two entry points, one medial and one lateral, and these are in the midline or posterior to it. And then you pass your curved owls and make your tracks, and then pass your nails. Okay, so nails are then passed in this manner. You always pass the nail facing down and then turn it 180 degrees to then face it up. So that is how the nail entry should go. both the nails should be passed, simultaneously, one after another. It's not that you pass one nail and pass the second nail. And some of the tricks here, because the nails were going out and we could not get a good access, what we did is we used a K-wire intramedullary to align the fragments. You put the K-wire inside the medulla of the proximal fragment and align the fragment so that the nails can go inside one after the other. And then we control the rotations by putting 2 3mm K-wires. So you put 2 wires. This was a comminuted fracture, unstable. So you put these wires, and once the nails are inside and cut, these you pass additional wires and connect them with a Jess fixator or a 3.5 fixator. So shank screws are difficult to pass. They can get caught in the nail. They will have higher chance of infection. They are difficult to remove, because to remove shank screw you need to unscrew, and it's a painful process. K-wires are easy to remove, and in children they work as well. So I use K-wires as means of holding the external fixator. You see the rotations and cut the nail, and before cutting the nail I'll make serrations so that the removal is easy. Small tips here. And then at end of the surgery, always take your knee through range of motion so that there is no sticking of the fascia either to the nail tips or to the K-wires, which are part of the external fixator. So this will maintain your knee range of movement. So this is post-op X-ray. You know that there is a lateral gap, but over a period of time, in a month's time, this lateral gap fills up. That's the time you can remove the external fixator. So in a month's time, the X-fix comes out. This is a knee range of movement, and around 8 months post surgery, we even removed the implant, and this child did well. So never delay your implant removal more than 1 year, because then the implant removal becomes difficult in these cases. Some more cases. This is an 11-year-old child, and this is something which is challenging. What injury is this? Dr. Mehndi, any comments? How would you manage this? This is a 10-year-old child. There is a tibia fracture. There is a upper femoral fracture, and there is fracture neck femur. How would you manage this? Can you give him a mic?
The pediatric DHS.
Pediatric DHS. Any other options? Sandeep, can this still be managed with elastic nails? Pediatric DHS in an 8 or 10-year-old child will be too big an implant, even in 8 or 10-year-old child.
Yeah, with a little innovation, you can do this elastic nail. You will have to put a K-wire in the middle fragment to control the rotation, and then make a regular entry, and then reduce it, and then put screws.
So this is how it was managed, using 2 elastic nails. One went into the neck, and one went straight up, and there were 2 additional cancel screws to manage the neck of the femur, and the tibia also was managed with an elastic nail. So this we managed, and it healed quite well. So different techniques you will have to evolve to manage femur shaft fracture. So this is a comminuted femur shaft fracture, I think, and when this occurred, we were at a meeting, me and Sandeep, together, and patient was in Bombay. We were at a meeting in Andhra Pradesh, and I asked him, Sandeep, what should I do? How should I manage this fracture? So this was, patient was put in traction, and then when I asked him, about the fracture, he said use a lateral entry nail. I inquired about the lateral entry nail, but it was not available in Bombay. Is it available here in Bangladesh, the AO or Smith & Nephew lateral entry nail? Okay, so we are in a plans to manufacture a pediatric lateral entry nail, which would be used for treatment of so many problems, for managing fracture shaft femur in adolescents, for correcting rotational problems of femur in children. So we are planning to do that, but till that time it is available, we couldn't wait. And this is how we went on to do the procedure here. We took the patient on a fracture table, and we did elastic nail first, and got stability to the fracture, and then we added a plate to give rotational stability and length stability. So a combination of elastic nail and a plate was used here. The reason was this patient also had a valvular heart disease, and because of chances of infective endocarditis, external fixator was not a choice. So that's why we put a plate through 2 small incisions. It got done, and I found that when we did this patient actually did very well. Functionally did much better than children where we put elastic nail and external fixator, because the range of movement is immediate and you don't have to worry about the pin track infection or the dressing. And once this healed, what we did was we removed the plate and 1 nail, and we have still kept 1 nail inside because he's a soccer player and I don't want any refractures in this child. The last case here, this is a 10-year-old child with lower femoral fracture. So any pathology here, anything which is problematic, is this a normal fracture, doctor, or pathological fracture? So this was enchondroma with a lower femoral fracture. How will you manage this? Can this be managed with elastic nail or no? So this is it is going to take time to heal, and elastic nails probably will not be length stable. So this was managed with a plate and fibula grafting. Plate and a fibula grafting, and it healed well. So this is 1.5 years post surgery. And what are the problems which can come up after plating in a child? The problem is not with healing, problem is not with the tumor, problem is not with this enchondroma. The issue is that you can see that as the child was growing, there was a genu valgum which was developing, the knock knee. Okay, you can see that the line joining the center of the hip of femur and ankle, it goes away from the knee joint, and this was managed using an 8 plate on the medial side. This is described, the lateral plate or a femur plate has a higher risk of post-operatively having genu valgum, and that's why nowadays we remove it early. Now when we did that, this completely corrected, the valgus completely corrected. The second problem started. Can anyone tell me what is the second problem? This patient had pain in the thigh and there was difficulty in movement of the thigh. He could not sit for namaz. What would be the reason for that? Anybody? So if you see these screws here, they have become prominent. So did I put longer screws to start with, doctor? Did I make a mistake? There was no pain till now, but the pain has only come up in last 2 to 3 months. Yeah, but they are prominent. There is a prominence of screw on the medial side, and they are rubbing against the quadriceps vastus medialis. So if you see, when the screws were put, they were of good size for the metaphysis. Because the children grow, these metaphyseal screws later on become diaphyseal, and diaphyseal diameter is smaller, so they become big for the diaphysis. One more issue you see here, of course we have to remove the screw, but why didn't I remove the plate? So when we plate children, many times there is hourglass constriction of the shaft, which we never see in elastic nailing. And if I remove the plate, there will be a chance with the previous pathology being there of a refracture. So we didn't remove the plate, we just removed few of the screws and the 8 plate, and this child went on to do well. So this teaches us that plating long bones in children is not simple. There are more issues than adults. Of course there are indications where you have to use a plate, but you cannot use it for all the indications. So what we learned from this session, the take-home message, is that fractures in children are different. Femur fractures are really different because at different age groups you will have different treatments. You have to select a treatment which suits your pocket and availability of the implant and what the patient would prefer. What is right for that age and for that pathology, the fracture level. So this is again showing in Bombay's local trains. I don't know, those who have come to Bombay would realize But in Bombay's local train also you can have a sleeper class if you do some modifications. And we should always keep modifying ourselves, innovating ourselves in local situations. And remember LSD, as long as you maintain the length, stability and deformity, the results from fracture shaft femur in a child will always be good. So with this we end this session. And if there are questions, we still have around 10 minutes for discussion before we break for the tea. With the chemical process, it's an add-on thing. And if the color comes out, it has no problem at all.
I think it is a beautification made to lure people to use it more compared to stainless steel.
Sir, last question. Nail and you use a locally made nail, you will find a difference in the resilience, because pure titanium is a scrap material which should not be used. When you bend it, it remains bent and it does not have the recoil. So the actual alloy is titanium vanadium alloy, TIVA. So that alloy has got the resilient properties, like Premal was saying. People have started copying elastic nails made locally, and they are actually pure titanium because it's very cheap to purchase. From all the scrap titanium they make those nails, and you bend it, it remains bent. When you bend the nail and release, it has to have a springy action. You can feel it when you do the synthesis and the non-synthesis nail. So typically what happens is that rather than doing a very bad elastic nailing and thinking that you are doing titanium, you would rather put a stainless steel nail. If you are going to do elastic nail, make sure that the right alloy nail is used for the principle for what it was made.
Yes. But if you bend your nails, stainless steel nails well, or a rush nail well, that's also equally easy to pass.
I think, Taral, I think he showed a case in which there was a third fragment with stainless steel which it came off. I think there are many types of subtle fracture lines, and when you hammer the separator, I don't think it is.
So whichever nail you use,
I don't think the material matters. I have never created a fracture with a stainless steel. I have been using this for 25 years. I have hardly used titanium nails.
Right.
I haven't had a fracture with insertion, except in OI.
The coating of the K-wire or the elastic nail, any hydroxyapatite or any comfortable coating, do you think is there any advantage?
Not at all. The only where it is used in shank screws to have a better hold in Australia does not have a scientific basis. Because these are for temporary fixation. You don't want the hydroxyapatite to, really bind it and make the removal difficult. Okay?
Thank you, sir.
Those nails are very commonly used in Gujarat for even
before year of 5.
Pardon?
Before 5 years.
If you don't need to. You don't need to. A plaster can give a good result. Why will you put a nail? Because putting a nail also means that you have to have a surgery to remove it.
And the role of blood around the age of 12, blood transfusion.
For femur fractures, blood transfusion.
And say a few words regarding the hardware removal in case of children.
In case of?
Children.
So I'll ask Sandeep to talk about this. He has a paper, how to remove elastic nails and when do you want to remove it.
So normally if you heard Sheetal in the morning, earlier better than later. The purpose of the nail is to give immediate elastic stability till you get callus. And once the callus matures, the nail is really has no role. So typically what we do is in our country we have two major vacations. One is Diwali vacation and one is summer vacation. So anybody whom I operate before Diwali vacation, I remove in the summer vacation. Anybody whom I operate between Diwali and summer vacation, I remove in Diwali vacation.
And he gives 10% discount.
So that is 6 months. Because the more you wait, the more there is bone formation at the tip, as Sheetal showed. The more the nail seems to migrate inside, because actually the nail is not migrating, child is growing. So bone is added distally. So your entry point, which was supracondylar, becomes mid shaft. Because now the child has grown and the nail has moved up. Okay, it has not gone into canal, it is there. But bone has been added. But there will be bone formation around it, there is chance of fracture and it becomes difficult to remove. Regarding removal, what we have published is that, like Sheetal said, he uses a suction cannula.
what we do is that we use a hollow mill. So when you expose, your incision may be higher. Okay? Which is why again when Taral and I we talk on elastic nailing, we always tell that when you make a primary elastic nailing, make an adequate incision. Don't do percutaneous nailing. Because what happens is that primary surgery incision is 1 centimeter, removal incision is 3 centimeters. Right? So parents are unhappy. In urban situation, people are very worried about the scar also. So if you make a percutaneous entry, you can do it, but removal ke time your incision becomes bigger. So better that you make an adequate incision to begin with, so that you don't injure the physis also, identify the blood vessels there, and leave 1 centimeter nail outside and flush to the cortex. Don't bend it right angle, or as Taral has his trick, make some half notches so that you can grip it easily. While removal, if it is not easy to remove, you have to get a periosteum elevator and get under the nail. Once you get under the nail, you have a hollow mill which is used for removing broken screws. So you pass that hollow mill around the nail and bend it acutely to 90 degrees. Then you can easily hold a nail with a plier and backhammer. That is the easiest way to remove a nail. We've never had problem removing a nail if you follow all these principles. Use something like a lock plate. Removing a lock plate is terrible. But luckily for us, our children cannot, at least my children cannot afford the original Synthes lock plates, which cost too much in titanium, right? So Indian stainless steel plate, lock plate, it doesn't really lock, so you can remove anything.
So Taral, regarding trochanteric child's trochanter that had a fracture at 7.5 years, is that the safe age, 9.5 years, going through the trochanter?
No, we don't go through the trochanter. I said we go 1 centimeter below the trochanter.
So that rationale you give below the trochanter?
Not rationale, for the lengthening.
Yeah, that's 7.5 years.
Yeah, yeah. So we operated that child at around 10 years age. It doesn't grow after that. So different bones fuse at different ages. That's why if you are doing a trochanteric epiphysiodesis after 10 years, it's not going to work for paralysis. You have to do before that. So 10 years is a limit. And you can go even for children, for say short femurs, when we lengthen them, we put a rush nail through the trochanter. It doesn't, not a problem.
So I've been very fond of doing lengthening over nail. We just published this paper in last Cosicon. I have about 20 cases of femoral lengthening over a humerus or even interlock nail. And the youngest patient is 8 years. And we have found that there is no problem with the articular trochanteric distance. And there is a very nice paper where they have calculated that if you want to do growth arrest of the greater trochanter, you have to do it before 7 years. After 7 years, this does not work well. So that means that if you are putting a nail and if you keep it for a longer period of time, nothing is going to happen, because this is not an epiphysis. This is an apophysis. Apophysis, the growth is appositional and not from the germinal matrix as it is in the epiphysis. So there is a big difference. And as Taral said, I have always done a nailing in a child beyond 3 years. I don't do any femoral lengthening without putting an intramedullary brush tube or an ender nail, whatever it is handy which is available. And I haven't found ever a growth arrest of greater trochanter or altered articular trochanteric distance, and I must have done about 40 to 50 femoral lengthenings.
So these patients don't have a problem with neck shaft angle or undergrowth of trochanter giving rise to abduction deformity. We will not observe.
Thank you.
You have put intramedullary in nail and as well as external muscular plating.
Yeah.
Why not you have put the only plating?
Yeah, why not?
Can you rely on the plate unless you depend
I'll
on
answer
nail
that.
as well? Yeah.
So many people, and there are a lot of papers where they use an elastic nail to align the fracture, then they put a plate and remove the nail many times, even in adults. So these techniques have been described. So we put the nail and then we put the plate. If you remove the nail and use only a plate, I will have to use at least 3 screws above and below. Okay? With the nail in place, I am happy to put only 2 screws above and 2 screws below and use that. So sliding of the plate is easy, the reduction is easy, and you can remove the plate early, keeping nail inside. So these are the advantages of doing a dual fixation or a combi fixation, or just doing a plating.
One of your case, you have shown the ipsilateral neck fracture and shaft fracture, nail and hip screw.
Yes.
So, is the principle in that case, is the principle same as adult, or in that case, which one you fix first?
So what we did is and then one wire in the neck segment, I reduced it close by a joystick maneuver, and we fixed it provisionally with 2K wires. After that I pass the elastic nails, and after that I pass the screws. So if you pass screws, then it may hamper the passage of the elastic nails. Passage of the elastic nail may displace your neck fragment. So your question is very relevant, and we had to plan this. So this is the way we did it for that case. It's a very unusual fracture in children. We generally don't see, so that was the first time for me as well, and that's how we at rest. We allow knee bending on the bed. By around 4 or 5 days, once they go home, that they are able to bend a little more on their own. There is no physiotherapy, and I feel by the time they come for suture remote, most of the children will have 90-degree knee flexion. They are already walking with a walker, and when they come around 4 weeks later, they come with walker in hand, which means the fracture is already sufficiently healed up. So that's the post-op regime. I don't send them to school like how they do it in Western countries. We have the patients with the parents for at least 4 weeks, and then they will go to school.
He has been on PTB brace for now 10 months with the nails in. What do you do now? 1 year follow-up of the simple fracture treated with beautiful nailing.
Here I can do some osteotomy and then, get compression over the nail.
Yeah. You tell me, what will you do? 4 options. Yes, Dr. Shyamal, you are one of the senior most members here. What would you do?
I think I will remove the nail, and I'll go for fibular shortening or fibular osteotomy and put a plaster again.
Okay. Any different? Want to do plating, bone grafting? Remove the nail. Why? That's what you ask him. Why you remove the nail, sir?
Nail is not doing anything. 1 year has passed. Healing is slow.
Okay, 15-month follow-up now. Still not joining. Sandeep, you want to do something? The child is slight, is a subtle limp in walking.
Premal, the behavior of a tibia at this age like this is highly unusual. You can't put the entire blame on the nail. Okay, at 3 years normally you wouldn't treat surgically at all. That's a given. But even in spite of nailing or whatever, if there is no infection and no primary pathology like OGI or CPD, it should heal in any case.
But have you seen a delayed union in a plaster treated child ever? Except it was a CPT.
So you want to say that the delayed healing is because of the nail?
Most likely. I cannot find any other thing. So this is 16-month follow-up, and that's a 2-year follow-up. And this is a 28-month follow-up. We didn't do anything because child was not very much.
But I was talking to Taral, the fibula looks unusually dysplastic to me.
Yes, but if you look at
I have no idea why it looks that way. Maybe there is some pathology.
You look at the first it was not like
that. This is different patient.
Sorry.
Yeah. It is, you see the fibula is looking dysplastic from beginning. I don't know whether there is some pre-existing pathology there which is...
If you look at this fibula...
You look at the neck area on the lateral view also.
So child...
I agree, I am not contesting the 3 years you should not be operating at all. But there is a biological failure for which I don't know why.
Okay. So I think the toddler nailing has its own issues. I have seen delayed union in ulnar nailings, femoral nailings and tibial nailings. Unfortunately this was a close, so I was also baffled. But just to show you that simple things can lead to complicated things if you are bent upon doing surgeries. So whether this is surgery related or not is a doubtful thing, but the blame is always taken by the surgeon once you put a knife. That is a bottom line. So had you treated it, plaster had gone for deformity or anything, now blame would have come to you. But since you have used a knife and gone to heal only almost after 2.5 years, all the blame is taken by you.
Sir, one question, sir.
Please.
You have followed up for more than 2 years in this patient. How long should I wait in this scenario? And because they are blaming me as a surgeon, there is.
Sir, once I had asked them to go for surgery, but parents were not keen on surgery. Sometimes you are lucky that they don't agree for surgery.
How did you console the parents that you are taking 3 years for healing?
No, then in between for 1 year they didn't come only. So they came back only because the implant was hurting. So that's the end of the story. I mean, I asked them that we need to remove part of fibula and then make you walk with a PTV. That would compress. That was my thought. But fortunately, they didn't come, and this was a surprise. Okay. So 4-year female, and unfortunately, I don't have a preoperative X-ray. She was treated. She had an isolated tibia fracture. I had given anesthesia and then put her straightened it and put her in a plaster. This is an X-ray with plaster, and it's an acceptable treatment. The only thing happened is she fell again at the age of 14 years, and because I treated her with plaster when she was 4, after 10 years she came back to me. So now what should be the treatment? Yes, Dr. Shyamal, first you now. 14-year-old.
The baby is adolescent. I think I will go for nailing, titanium elastic nail.
Titanium elastic nailing. Yes, Dr. Mehdi, you are a first bencher, so again eligible to answer this question. One option is 10 nailing. Plate is another option. Anybody for plaster? Okay. I don't think we should have come here. You all know everything. Okay. So this was AP and this was the lateral. I'm just trying to show you that sometimes you may not be able to balance the reduction in both the views simultaneously. So what do is you accept the reduction in one plane and other reduction, malreduction you can accept, and you can do on-table wedging. That's an on-table wedging. Taral showed you wedging post-operatively. I am showing you on-table wedging. Because sometimes you may not be able to get 100% reduction in both because it will displace in one. So that's a 1 week post-op. That's at the plaster removal. That's a 1 year follow-up. These are the movements, and this is at the end of 2 years. So conservative treatment is a gold standard. One of my colleagues, when I was doing a residency, had a dissertation on fracture shaft tibia treated with a plaster in adults. I am sure those days are gone, but I am sure you can treat pediatric shaft tibia fracture in majority of the cases in conservative. Don't go away with an idea that I am the one who does. I'm an don't IFICS person. We recommended that we can get away majority of the times without fixing, even though the acronym for our conference is IFICS. Okay, this is an autistic 14-year-old boy who fell from the terrace and had a closed fracture, multifragmental fracture with significant soft tissue injury, and he also had an undisplaced calcaneum fracture. Yeah, what to do? Yes, Dr. Bobby, you are quietly sitting behind on the computer, so you have to answer. No, this is the 40-year-old boy who fell from the first floor, autistic child, so special child. Autistic child, post-operatively you won't be able to you contain them very well. Sorry? Plaster. 14-year-old with a significant. Yes, Sandeep. So Sandeep, your take on this. 14-year autistic.
So autism is a very important history because these children are extremely unpredictable and they have attention deficit, so they may be unable to comply with plaster.
That's a very important statement.
So secondly, they might be on drugs and there may be osteoporosis in addition. So these two factors would push me towards more surgical treatment rather than just a plaster in this patient. How to do it? Well, I can consider plating the fibula and doing some sort of a Can you go back to the X-ray? Maybe a MIPO type of a tibial plating, because it's too distal and too comminuted for any elastic nail.
Any other? Okay. Elizarov. Sir, he just told that these children are extremely difficult to manage post-operatively, and Elizarov does require some cooperation from the patient. I do fair number of Elizarovs. I am not an Elizarov surgeon, but I know that it's not a very comfortable way. Whatever best surgeon does, patient is not comfortable. Your pins are out, your clothes get in, your chadar gets in, and lot of things happen, because that I don't think any surgeon can prevent, and that's a day-to-day thing. So this is the bone age estimation. His olecranon is fused, not much growth coming from the distal tibia, so we decided to do open fibular nailing because it was 10. We got the fibular length and then treated this child with and that's a 1 year follow-up, nice ankle alignment, and this is the functional result. Okay. 10-year male, moving to the distal most end of the leg, 10-year-old male, how should this be treated? These are the options. Yes, sir, you are intentively looking at the options. Please tell me, what will you do for this child? Plaster? Okay, how many for plaster? How many would you like to go for plaster? Okay. How many you for open deduction, tension bend wire fibula? 1. How many for open reduction intraphyseal screw for medial malleolus and K-wire for fibula? Majority. I think that's a very wise say. Let us see what happened. This child came to me with a deformity, was treated with a plaster, and this child unfortunately had a growth physeal bar excision also, but I don't know who did it. The records were very poor, so I will not put that. And this child was treated with plating, and fibula had already gone for pseudoarthrosis. I didn't touch the fibula. That's a 1 year follow-up. That is how his functional result was, and that is a follow-up his last week, about 7 years following the surgery. So medial malleolus is a physeal injury, and it has to be fixed, whether it is with a K-wire or a screw. It is up to you, because as Sandeep pointed out in the last case where intra-articular step was there, intra-articular step in type 3-4 means there is a step at the physeal site also, and that does not allow proper healing, and that is where there is a chances of physeal bar formation that will lead to. So how do you do medial malleolus surgery? This is a 6-year male, was advised plaster, came to me. This is a percutaneous reduction attempt. You can press it with your thumb. If you get a good reduction, put a K-wire, and then you always do an arthrogram and check that you got a, because even if you open ankle, you will not be able to check intra-articular congruity of a medial malleolus fragment. So after arthrographic then you can replace, put a 1 K-wire, remove that 2.5 K-wire and put a 4 mm cannulated cancellous screw over that, and it is going to be a 2-stitch surgery, and that is the X-ray at the union. Okay, so 12-year-old female, tell me what is happening here. If you look at this X-ray, on the left side you find that this is a type 3 injury, and on the right side you find that this is a type 2 injury. So how can this be possible? Yes? Yes, Dr. Shyamal, what is happening here? In one view we have got a type 3 injury, and one view it is a type 2 injury.
I think this is a supination plantarflexion injury.
So what is the common name for this fracture?
It is like this. And
no sir, what is the common name for this fracture? Yes. Okay, who said triplane? Yes, please get up. Now you tell me, you have diagnosed it well, how will you treat this? Sorry? Open reduction. Which approach will you take? Metaphyseal is always posterior in triplane.
metaphyseal fragment from anterior to posterior screw.
Then you will not get a compression.
Yes, sir.
Because fracture is posterior, if you use an antero-posterior screw, you may not get good compression. This is posterior fragment, right?
Yes, sir.
If you look at here, this is a posterior fragment and a very small fragment. If you put a screw, you won't get much compression, and you got an intra-articular fracture here.
Yes.
So, it may be a good idea to plan where is your fragment. You see, this is your fragment and which is the direction of the fragment. That will help you decide from where the screw to pass from which side to which side. This is the fragment, so you'll have to start the screw from here and go on this side because there is no other fracture there. Right? So you will start from here and your screw will go in this trajectory. Right? So triplane, it is always good to do a CT scan, confirm what is the amount of displacement. It will give you another indication also that which type of screw you will use. This is the 3D reconstruction, and this is the triplane fracture. First the fracture travels vertically in the physis, then it travels horizontally in the physis, and then it travels vertically in the metaphysis. So this is, why does this happen? Because the growth plate of the tibia fuses from anteromedial and goes to the posteromedial, and then the last part to fuse is anterolateral. That is why this fracture happens. This is called a transition fracture when there is a transition from adolescent age to maturity. This is the fracture which takes place, and that is why we call it as a transitional fracture. So you can treat it with a very simple surgery. You can put a small stab incision, identify the fragment and compress it with percutaneous clamp by putting small incision posteriorly also, and then once you get that, put a K-wire from anterolateral to posteromedial in this case, replace that with a screw, and then once you got a compression here, you can put an anteroposterior screw, and always do an arthrogram to check articular surface before you close, and that's a 3-month follow-up, and that is after removal of implant with a normal ankle movement. Thank you, doctor. So what is the recommendation for distal femur from our side? Close reduction and fixation is mandatory in distal femur, but we must discuss with the parents. 80% should be your attraction and only 20% manipulation in all physeal injury fractures, and always add prayer to it because you don't know what is going to happen. Discuss high possibility of growth arrest with the parents, which I have been reiterating multiple times, because if you forget that, the onus will come to you, and follow up at least for 2 years, because most of the time growth aberration is evident within 2 years. Tibia fractures, majority can be managed in plasters, very few indications for surgery, which has been already narrated by Taral. Avoid nailing in younger children because it is not necessary, and as you can see that there may be something there and you may be blamed for it, as I have shown. Adolescent fractures can also be treated conservatively if you know the art of plastering and wedging. You can use interlock nails in adolescents who are closing to growth maturity, but don't remove that nail till the physis has fused in, and in those cases there has already been a paper out for interlocking nail in adolescent patients, but the recommendation is you don't remove the nail out. If you remove the nail earlier before the fusion, in that case the growth bar can take place. And for the fracture of the distal tibia, majority can be managed with the plaster if it is not an intra-articular. Very few indications for surgery. Sorry, I think this I have copied the slide again. Intra-articular fracture has to be managed as an intra-articular fracture because this is a two fractures, this intra-articular fracture as well as physeal injury. So anatomical reduction and stabilization till good union takes place is one of the most important thing in distal tibia fractures. And whenever you are in doubt in distal tibia, rather than only X-ray, you would like to get a CT scan done also. Thank you very much.
Assalamu alaikum. Respected teachers and my dear colleague, I am now going to deliver my topics on ABCD of femur neck fracture. Though it is a rare fracture Among them, less than 1% of all fractures in pediatric patients and less than 1% of all hip fractures. Those are less than 1% all pediatric fractures, but we are very worried about them because they have bad actors and cause trouble like coxa vara, avascular necrosis of neck, non-union or malunion. Femur neck are usually caused by high energy trauma such as motor vehicle accidents, fall from height or penetration struck by vehicles. It also caused by abuse. They are high energy injuries because the femoral neck is thick, strong bone. The hip is protected by a very strong ligamentous system. The amount of energy absorbed correlates with the potential bad outcomes. There is a classification called Delbert classification. There are 4 types: type 1 transepiphyseal, type 2 transcervical, type 3 cervical trochanter, and type 4 intertrochanteric fractures. These are the pictures of the Delbert classification. There is a blood supply of proximal femur. Pathology. After H3, the physis blocks transmetaphyseal circulation, and this circulation returns after physeal closure. Main artery supply in lateral epiphyseal artery, a branch of the medial circumflex femoral artery. So, femoral neck fractures are vascular emergencies. When we started the treatment, we should fully access the child, reduce the fracture if there is going to be a delay. This emergent surgery sometimes include decompression. Most of these kids need internal fixation, some need open reduction. Totally undisplaced fractures may need only casting with very little ones. Pathological fractures should all be fixed. Pre-fracture should be treated. There are some complications like avascular nexus of neck, malunion, non-union, infection, etc. Avascular nexus occurred after femoral fracture. Some meta-analysis found rate of 38% AVN for type 1 fractures, 28% for type 2 fractures, 18% for type 3 fractures, and 5% AVN occurred in type 4 fractures. Femoral neck fractures are rare but tricky fractures. Do them as emergencies. Solid fixation and cast. Do not worry about crossing the physis. Watch carefully for complication. Thank you.
So, good morning, and we'll go through fracture neck femur case-based discussions in the next 45 minutes or so. And so a very nice talk which summarized all the main features of fracture neck femur, and I'll just reiterate a lot of those concepts through cases, so that, and I must thank Maulin and Sarwar and Sandeep Vaidya, a few cases which we had done in 2020. IFICS have been incorporated here, so thanks for that, and you will be seeing your own patients in this. Right. So this was Maulin's case. This was a 2.5-year-old child who was struck by a car. Now, looking at this X-ray, he came with limp and inability to bear weight. Right? This is what was the X-ray. So, what do you think is the injury? Is it a normal X-ray? How many people feel this is normal? Look at the X-ray closely. Is it normal? These were the X-rays available. Okay, is it lower femur fracture? How many for that? Can you raise your hand? Do you think this is just a thigh contusion? No. Or is it a fracture neck femur? Nobody is raising hand for anything. Okay. So you think it's a fracture through the physis? Correct. So typically, as rightly pointed out, a X-ray which is a true lateral is not a very good X-ray. But the minute you take a frog leg lateral, you will see that this was indeed a transphyseal separation or a Delbert type 1. And 2 weeks later, this is the situation with the fracture. Now this particular case was treated by Maulin by gentle close reduction. Sometimes, like we have said, after 10 days it is difficult to get any kind of reduction because the physis gums up very fast. So a spica had to be given because he came to the patient came to him limping, not able to bear weight and with pain. So a spica was to be given. So he took the child under anesthesia, and when he examined, he found that he could get some kind of reduction. So he put a couple of smooth pins to hold the fragments together, and then a hip spica was given. And this later on went on to a good healing, and this is a 2-year follow-up. Now the question I wanted to ask was type 1 Delbit. One, your mind should know when a small child comes with history of fall and unable to bear weight. In a seemingly normal X-ray, take a frog leg lateral. The frog leg lateral will tell you whether there is a transfacial hip separation. Second, Maulin was very happy that this is 2-year follow-up and everything looks nice. And he doesn't have a longer follow-up, but I have long follow-ups of such cases being treated. Do you think everything will be alright? Sarwar, what do you think? What could be the problem?
So, still we can see in the physis there is some changes.
Yes.
Yeah, so we have to keep on watch.
Correct.
Even if it is 2 years.
Correct. So you have to watch every fascial injury for a longer period of time. Whether it needs any treatment or not, you must observe, because in the long term you will end up having some kind of growth disturbance. Now whether this is clinically, functionally relevant or no remains to be seen, because right now at 8 years child is completely normal, running, jumping, walking. There is no limb-length discrepancy and there is no fatigue pain. But this is not a normal hip morphologically. Right? There is coxa vara, there is coxa breva. The neck is short, and this can affect the abductor function or lead to later on fatigue pain, limp, and may require some kind of hip reconstruction. So always remember that Delbit type 1 injuries may be missed. One, they can be missed. Second, if you treat them, make sure that you have a long follow-up. There is always an implant issue in a pediatric fracture neck femur. You are always worried as to what implants can be used and at what age, because of the size of the femoral neck and the propensity of complications. Right? It was already pointed out, neck femur fractures in children are not very common fractures. You will hardly see 1 in a year or maybe 2 in a year. But it is unlikely that they will have no complications, because 50% of those fractures have some kind of complication or the other. Yeah, it's okay. So 50% of the patients, especially the displaced ones, will have complications. So it's very important to understand what implants should you use. Now this is a 7-year-old female presented on 3rd day after injury. Okay, what will be your choice of implant? How many of you want to do 4 mm cannulated screws? Raise your hands. Okay, not many. Austin Moore pins, AM pins, smooth pins. I think half the crowd from behind have never seen them in their life. So they can't use them. Okay, only the senior people in front may have seen AM pins. Mini DHS. A few hands for mini DHS. 6.5 mm screws. 1 or 2 people. And AO proximal locked femur plate. All the AO people who have done AO courses, yeah, I can see few youngsters, yeah, raising their hand. So size of the screw is important. Okay, 4 mm screw done for a 7-year-old child, and in a few months the screw has broken and everything has fallen apart. Okay, so is the screw enough? And the answer to that is that it depends on the size of the neck. So less than 8 years, you need to put couple of screws which are 4 mm for reduction and stabilization and compression. But what is mandatory is a hip spica. Remember that they are not standalone implants, and a spica is absolutely mandatory. Now this is an older child, above 8 or 9 years, with this fracture, and a 6.5 mm screw has been put. Okay, So 6.5 mm screw has been put for this child. Is this okay? Looks okay? Okay, Kaisur is not happy. Why? What's wrong with it? It looks pretty good.
Looks good, but the fracture configuration and the screw placement is not correct.
How would you have placed the screw?
In these cases, I would add something new.
What would you do?
Like valgus osteotomy, then put
Primary valgus osteotomy? You would do primary valgus osteotomy? How many of you do primary valgus osteotomy in fracture femur, neck femur?
It looks old. How many?
No, it's fresh fracture.
Fresh fracture. Then if I put a screw there, I put a. How is the age of the child?
9 years.
9 years.
This thing is broken. It keeps on falling off. Okay.
So, what is important here? Powell, somebody said Powell's, yeah. It's the vertical fracture line, yeah? So, yes.
The screws were not placed 90 degrees to the fracture line.
Okay, so
that could help.
Correct. The placement of screws also matters. It's not only the size of the screw, where you place them, and the nature of the fracture pattern, the verticality of the fracture line, and the size of the neck. All three things matter when you decide what implant you want to put.
Sandeep, I don't think I'll put a screw in this patient. I don't think I'll put any screw in this patient because I have not achieved the reduction only.
Okay, so Premal Bhai has got a very valid point. He feels reduction is not adequate. First aim is to get a perfect reduction. So many important points have been brought out. One is you will not put a screw unless the reduction is adequate or perfect. And a perfect reduction is you must have the Lowell's S curves on EP and lateral perfectly contoured, and there should be no acute kink.
There should be no acute kink at the site of the reduction. So no retroversion or excessive anteversion or slip. Now this doesn't seem to be perfectly reduced. Second, when you have problems of stability and you feel that the proximal fragment is too small, you must cross the physeal line. Crossing the physeal line is not a taboo at all. So this is what happened, which was to be expected. Yeah. So it doesn't matter what the size of the screw is. The size of the screw is determined by the amount of bone in the neck. How wide is the neck? Can you put a 4 mm or a 6.5 mm? But whatever you put, you cannot take it for granted that this is stable fixation. A lot of you will say, "Do screw maar diya, 3 screw maar diya." That is what they say in India. अरे इसको 3 screw मार दो. Okay, 3 screw मार दो, लेकिन आगे क्या होता है? Okay, ठीक है? So this is what happens. Now this is a type 2 displaced fracture. Again, displaced fracture, fixed with cannulated screws, couple of screws. AP looks very good. Again, on lateral one screw was cut out, but fortunately the surgeon had put spica. So again, to reiterate, if you are using screws in isolation, which means stand alone, you have to give a hip spica. A Thomas splint or a long leg knee brace is not acceptable. And this healed fortunately in 3 months time. Screws were removed. So stability issues, you can avoid the screws if you make a small jugaad. As Taral was telling, what can you do? I use a side plate. So if you can see this, one screw is outside the plate. You put a cannulated guide wire after reduction and put one screw to achieve primary stability. And the second screw that you put it through a DCP or a recon plate on the upper proximal femur. And the second screw is then fixed to the shaft with couple of screws, so that there is greater bending moment resistance and it doesn't collapse or break out. So with this construct, you can give a long leg knee brace or a cylinder spike slab for additional immobilization. You can eliminate the hip spica part so that it's more comfortable for patient, especially older patient. And I have found, I've been doing this for nearly 15-17 years now, and it does really well. We haven't had problems. So whatever the size of your screw, it may be 6.5, it may be 4 mm, addition of a small side plate increases stability of your fixation by a great deal. Okay, so stability is important. First thing is reduction, second is stability. Stability depends on what implant you use. You cannot use too thin an implant or too thick an implant. Either ways there can be a problem. It must be an appropriate implant. You can't put a pediatric DHS in a 3-year-old, right? Just because you feel it is stronger, but the neck is so small you can't put a DHS in that. So small screw if you use, you can add a spica or add a side plate. These are the two things. And lastly, please cross the physial line. The proximal femur contributes to only 25% of growth. So reduction followed by stability, followed by whether you're using a pin or a screw, followed by whether you have to cross the growth plate. Okay, so sequentially when you are making your decision of treating a fracture neck femur, remember all these points so that you don't end up having a complication, because as you know, rate of complications is as it is very high. We should not add to it as surgeons. Okay, even old type implants, half of you may not have seen this. This is a Smith-Peterson pin and a side plate, SP pin and plate. Okay, pediatric SP pin and plate has been used with a Austin Moore pin. This is an AM pin, a smooth pin. Even that works. So it is not the implant, it is how you use it, right? Don't blame the implants, right? So this is what happens. Adolescent age group, when you have adequate neck, big neck, then you can treat it like adult. Okay, use the Powell's classification and use a pediatric DHS. Right? So what we have learnt is, one, we must have good reduction. Second, we must have good stability. Stability involves addition of a spica, addition of a side plate, or then you must have something which will protect it from breaking out. It doesn't matter whether it is 4 mm screw or 6.5 mm. That depends on size of the neck. Today we have this fancy implant again, a pediatric AO hip plate. At least in India it costs 40,000 rupees. So I don't know, maybe 50,000 Bangladeshi taka. If it is available to you, you can use that. That is the current thing. So implant options, as I said, cannulated screws will allow you compression. The sliding hip screw allows you sliding. Locking side plate doesn't give compression, but it limits the varus collapse. So we have already shown you that addition of a simple DCP can prevent or limit the varus collapse. Even though you don't have the AO side plate, doesn't matter. We have been doing it even before the AO plate was invented. Screw placement, Sarwar said, he made a very important point. What has been recommended in children is that your screw placement, if you do screws, has to be posterior and inferior towards the calcar, within 3 millimeters of the calcar. So central placement is not a very ideal placement. What you should have is a posterior inferior placement, okay, towards the calcar when you are putting the screws. So implant depends on age, as I said, less than 3 years, smooth pins, 3 to 8, 4 mm screws, and 8 plus 6.5 screw, pediatric hip screw or AO plate, depending on what is available, and you can use some innovative places. So this is the next case, a delayed presentation now. Now this child has got a fall from a tree. This was a young girl who came from interiors of Maharashtra to me. Fell from a tree, went to local bone setter, massage was done, she was put in some sort of a bandage. After 5 months she was not able to bear weight and she came. So what is your option? Fixation in situ with DHS? How many for that? Big neck, older girl, 11, 12, DHS fixation? Kaisur, this is your case. 5-month-old delayed fixation. What will you do? Delayed presentation. Fix in situ, fix with CCS, primary valgus osteotomy or a pedicle graft.
Any other view available?
No, this is the view available. Comminuted neck, 5 months old injury. Now this is a delayed presentation. This is not a primary fresh fracture.
I'd go for fibular stud graft and then fix it with cannulated cancellous screw.
Okay.
And delay weight bearing as much as possible.
So the principle is, one, stabilization with cannulated screw. Second, you want to add a bone graft. Okay. Let's see what was done. So this was treated by an in situ screw, as you said, 6.5. Okay. But because it was a delayed presentation with comminution in a adolescent girl, we added a valgus osteotomy. Okay. When you have adequate neck and adequate bone stock, you need not do a fibula grafting because there is no resorption of the neck. When there is good bone stock, stabilization in situ, no opening was done. What you should remember is no open reduction. Delayed presentations, you don't need accurate open reduction. You stabilize the fragments in situ, and after you stabilize them, then you will do a primary valgus osteotomy. And this was a small plate which was available to us, a 140 valgus plate, lock plate, and we did a valgus plate fixation, and that healed up in the next 4 to 6 months very nicely. No bone graft. The valgus added to the length, so the limb length discrepancy was also taken care of, and overall a satisfactory outcome. So the message is in situ screw with a valgus osteotomy, no AVN, good range of motion, don't do open reduction when the patient comes to you more than 3 months delayed presentations. Okay, but bone grafting is not needed, especially when there is adequate neck and adequate bone stock. Now this is Sandeep's case. Again, this is a non-union fracture neck femur, failure of fixation. So non-unions happen because of 2 reasons. One, late presentation. They come late and they have not healed. Or second, badly done surgery or broken implants. In the Western world, it is the second one, broken implants. In our country, it is delayed presentation. Massage, Kabiraj, all the standard local treatments are done, and then they come to you with non-unions. Now this particular case which Sandeep showed us was treated with 2 screws. As I said, people think like adults, you put 2 screws, that's the end of it, or 3 screws and that's the end of it. They forget the spica part. Okay, so this cutout, there was loss of fixation, there is non-union. So that was treated by him with a pediatric DHS with a subtrochanteric valgus osteotomy. Okay, and this again correction of biomechanics and adequate stability to the primary fracture fragments, and this went on to good healing and again no avascular necrosis. So delayed presentations, there is some revascularization that already happens. The body is always trying to heal. The vascular event has happened and gone. Now you need to put the bone fragments together to get them to heal and change the biomechanics, and that works. Okay, muscle pedicle grafting, open reductions are really not required in non-unions or delayed fracture neck femur, and that girl had excellent outcome. Now this is a further extension. This is what we see. This is again, like Taral said, Ganga operative course. They give all the dirty cases to Taral and me. So this is I think 2016, where Venkat Das comes and tells us, will you do this 16-year-old boy? Kya hai? 18 months old untreated fracture neck femur, no neck, and the head shows sclerotic changes of avascular necrosis. Okay, so options that were again theoretical options considered were open reduction with bone grafting, closed reduction with fibula, fibula with valgus, and vascular pedicle grafts like have been described by Bakshi et al. So that is Taral, our photo from then, when we were more handsome and had more black hair. Okay, so we
This is it. Good head coverage.
Good head coverage. Okay. So this is what we did then. We did in situ stabilization, valgus osteotomy, and we used a fibula. So Taral demonstrated his percutaneous method of removing the fibula with 2 small cuts, and then we split that fibula. We made a track. Inferomedially you can see their fibula, and then there is a superior screw. First thing is put the fragments together. So one guide wire, one cannulated screw. Below that, where there is bone deficiency, that is calcareria bone graft. Fibula gives you good biology and good stability because it's cortical, and more BMP is there in cortical grafts than cancellous graft. Please go back and read your textbooks. BMP is more in cortical bone than cancellous bone, right? Only thing is it is replaced very slowly, so it becomes weak at a later date. You should remember that. And then a valgus osteotomy. So this is 2014, sorry, not 16. So this is what Venkat Das sent us very kindly, all the follow-up, and this is how it healed, and this is how the head revascularized, and this boy is now quite well and functioning nicely. And last follow-up he told me was he had some cam, residual cam because of the AVN healing up. So that bump he removed arthroscopically, and the child is doing well. So this is a paper which we recommend that you read, not because I have written it. It is because it covers all the articles, and it's a review article of non-union in pediatric fracture neck femur, JBJS current concepts review in 2020. So we have tried to look at all the papers and tried to analyze what causes AVN or what causes non-union, and how to treat it, and made some recommendations. So I won't go into details here, but it's good to read this paper before you treat non-unions, because these are very common in our part of the country. This is Server's case. Server, you want to say? I'll just put up the slides. You can talk from your mic. So this is what Server had showed. This was a 13-year-old girl from Chittagong.
Yeah. There was a fall. She had pain, and she was treated for knee pain. 3 months after the initial fall, she also had hip pain. So she went to another orthopedic surgeon, our late friend Shomerul Islam, and he sent it from Chittagong to me, and he sent with the X-ray. He did a hip X-ray, and this was the X-ray. So you can see it is it is Delbert 2. Even we can say this is shoulder head is 3, because head is also fractured.
Yeah. So there is a lot of resorption of the superolateral part of the neck.
Exactly.
It's like there's a pseudoarthrosis forming there.
So what to do? Actually, let them.
Yeah.
say.
So this was the additional imaging. So how will you manage it now?
3-month-old neglected proximal femoral fracture, Delbert 2 or shoulder head is 3. What to do?
Yeah. Somebody, Mehdi, you want to add?
Anyone?
Something?
From our PEDORTHO group, Bangladesh, we work together. Around 20 people work together. Someone? Yes, Biplab.
Yeah.
Biplab is my registrar in Nitor.
Okay.
He's a promising pediatric orthopedic surgeon.
Wonderful.
Works good.
So what will your
Biplab
thought
Majumdar,
process? How will you analyze
come
this fracture?
forward.
Tell me what are the points that you will analyze in this fracture?
This is a power type 3 fracture, and
type 2. Oh, you are
delicate
talking
type 2 and power type 3 fracture, because the angle is very high.
So again, a small tip, technical tip. Powell's fracture is classified not for delayed presentations. It's for fresh fractures. So I don't think we can comment when there is a delay and the neck has got eroded off. Maybe it was type 2 or type 1, and now because she's walking on it, the neck got eroded.
And Powell's classification is after the reduction.
And in a fresh fracture. So the angle has to be measured after reduction in a fresh fracture.
Yes, sir. Sir, in this case, I will do open reduction. Then I will fix the fracture by DSS or cumulative screw associated with fibula, and then I will give fibula, and then I will do valgus osteotomy.
Okay, but why do you want to do open reduction?
Because
what will you reduce?
Because reduction is not acceptable.
No, but there is no reduction. There is no neck to reduce. When the neck is resolved, what are you reducing against what? And will open reduction of that area give you anatomic reduction?
No, sir. I will not give anatomic reduction, but it is not acceptable at now.
So this is a delayed presentation. You don't talk of what is acceptable in a fresh fracture.
Sir.
Here what the principles that we are trying to teach you or change are that what you need is bone to bone contact, stability, change in biomechanics, and not adding to the insult. So open reduction, doing a capsulotomy may disturb the vascularity of that head fragment more. So what you do is in situ. What was done, Server? I think.
Actually, we did open reduction. It was very unstable type. We went for open reduction.
Okay.
We did fibular grafting. We did cannulated screws and valgus subtrochanteric valgus osteotomy.
Okay. So open reduction is what was done. We don't do it. We don't recommend it. What you have done, you will show. So open reduction was done. Fibular stud grafting was done. Subtrochanteric valgus 3 months after trauma.
Right.
Okay. So this looks good. There's a nice calcar screw. There's a fibula there. What do you think will be the outcome?
I think.
No, I'm asking you.
I think outcome is good, maybe.
You think it is good? Okay. So, 3 months post-op.
That's 6 months.
That's 6 months post-op. Is it good? What's happening? Your primary problem was a non-union. That has healed.
Then AVN.
But what is the secondary problem that has happened?
The AVN of the
AVN of the head. So that is what I was trying to tell you. An open reduction may increase the risk of causing avascular necrosis because you are going and dissecting the revascularizing head. Whatever little retinacular blood supply is there with your handling and trying to achieve a normal reduction, you may damage vascularity further. And whatever cases we have shown is in situ, no opening of capsule, just a guide wire, get the piece stabilized and then change the biomechanics by 130 degrees, valgus osteotomy, or 135. You understand? So screw may be right angle 90 degrees when you put it, and the bone graft goes indirectly fibula by a reamer. We are not opening at all anywhere. Okay. So this is 6 months post-op. This is, I think, a video of this girl. She was doing okay for 13 months. Yeah, and 18 months post-op there was AVN and no pain, and patient was advised a little rest, and 22 months now, and now she has problem, right? So this is a very good case to demonstrate or illustrate how things. So you did your job for getting the non-union healed really well. It healed. But what happened was vascular damage. Okay, and now we are ending up with a AVN problem which has made the patient very painful and stiff. Okay, so now it is 25 months. What do we do? Remove the hardware, wait and observe any role of bisphosphonates, and future plan. That is what he had presented at that time, at 2020. I don't know the follow-up. Do you have? What happened?
Actually, we removed the screws.
Okay.
And she improved.
Okay.
And I have the video, but I'm not finding it. Now, now she is painless.
Okay. So you removed the hardware and the AVN has slowly revascularized.
Slowly revascularized.
And how is the range?
Range of movement is of course
surprisingly
restricted, but she doesn't have that much of pain.
Okay, so the pain is less after implant removal, but range of motion is not very good. Okay, so this is the whole bugbear. Somebody in the first talk itself it was mentioned. It is like a heart attack. Fracture neck femur in a child is an acute vascular event. You have lost blood supply to the head. Question is, how will you allow it to restore itself without causing more damage? One is inherent to the nature of the disease, second is iatrogen, what we do. And what can we do to avoid AVN is very important, and the overall incidence has been published as 30% and more from as you are closer to the head to away from the head. Right? So these are the percentages that you see. And there were contrasting reports. Okay, so one thought process was we should decompress the hematoma every time. Decompression of the fracture hematoma will reduce the chance of AVN, and few papers substantiated that if you decompress it, it's an act of commission and you are decompressing and reducing the tamponade on the remaining vessels, which is logical, but the papers have not shown that way. The papers have shown that in spite of decompression of hematoma, 20% people can still get AVN. So it is not a mandatory requirement. It is a good thing to do.
How many days?
So yeah, so I'll go to the next one. This is from Sheetal's center. Charles Mellman, his boss, has published this meta-analysis, and they studied nearly 25 cases, and they did a meta-analysis, and they said that the only predictors of AVN were the age of the child. Older children had more AVN, younger children had less AVN, and second was the stability of the fracture, the type of the fracture. Okay, fracture type and fracture age are the only determinants. Now these two things, age and type, are beyond your control. Okay, so that is what they said. So type 1 to type 3 were 15, 6 and 4 times more likely to develop AVN. And these were the types of AVN. So treatment options that have been described are core decompression, fibula graft, either vascular or non-vascular, bisphosphonates, and today what we are doing for AVN is intraosseous bisphosphonate. Okay, best treatment may be unknown and sometimes you get lucky. Now this child had an avascular necrosis which completely restored over a period of time. Okay, and it remodeled very. So this again bears out younger children will revascularize better, older children will revascularize poorer. So the tolerance to accept reduction has to be very low in older children. Okay, age is not in your hand, type is not in your hand. What is in your hand is perfect reduction and stable fixation. These two things without adding to damage. For a perfect reduction, if you cannot get a close reduction, a gentle small open reduction is permitted. But you must have a perfect reduction for revascularization of the head, and you must have a stable fixation so that you don't end up with AVN. So this is Binotti's case, a 14-year-old male with a type 3. Now this was fixed with 3 cancellous screws and developed AVN. Okay, so this is a healed fracture with which is still round, and you can see that there is a large area which is osteolytic and there is some sclerosis around it. Till the cartilage cap is intact and there is no collapse, the head may still revascularize nicely and you will get a good result. So at 18 months, yeah, sorry.
So there is a valgus reduction.
Yeah.
And a valgus reduction.
Yeah. So this was like a, if you see Taral, originally this was like this.
Yeah, it was in varus and it was over.
So valgus reduction also can kink the lateral ascending epiphyseal artery and contribute to AVN, which is why it's not a very good thing to have a valgus reduction. Over valgus is definitely not acceptable. And this has healed nicely with AVN. So at 18 months this was the situation. They removed the implants, okay, and then they gave oral bisphosphonates. I think that is what they did. This is the MRI which showed a good cartilage cap. Okay, so this is another example of an 11-year-old girl who after fixation had AVN, and today what we do is when we remove the implant, we inject intraosseous zolandric acid. Okay, zolandric acid injection which is given in osteogenesis imperfecta, the bisphosphonate, but you cannot give it because you have to push it in bone, and it binds to the bone, prevents osteoclasis and prevents collapse. What we are interested in is do not let the bone collapse and the cartilage sink and get arthritic. If you can prevent collapse, the head will revascularize because these are all children who have good healing capabilities. Okay, so how to prevent collapse? When you give oral bisphosphonate, because it is avascular, it will never reach. How will it reach an area which doesn't have blood supply? So the logical thing is to inject directly into the lesion. So implant removal followed by a cannula in the tract and then connect it to a syringe pump. And then you take 20 cc and over 20 minutes the syringe pump will push the drug in. It takes about 20 minutes for about 2 to 3 cc to go. That syringe is 20 because you need pressure. And a 2 cc syringe can't be fitted onto a syringe pump. Okay, but actually what you can put into the head is just 2-3 cc. But it has to be done under pressure. So this is the way you do it. You put a syringe pump, 20 cc zolandric acid, connect it to a cannula which has been put into the screw tract, right, to deliver the bisphosphonate. And from the hole, so that it does not come back, you put some kind of a plug. You hold your thumb there or you put a gauze so that everything doesn't come out. And go slow, half an hour, 20 minutes to half an hour, let it all bathe that area so that zolandric acid binds to the dead bone there. And that prevents osteonecrosis collapse by inhibiting the osteoclastic activity.
So the dose in injectable thing is 0.05 milligram per kg body weight.
Yeah, same thing.
So 20 cc, we have a presentation in Bangladesh, 5 milligram in 100 cc.
Okay.
So you said 20 cc?
No, we just take, there's a infusion bottle that you get of zolandric acid. So
yeah, that bottle, we have two presentations, 3 milligram in 5 ml and 5 milligram in 100 ml.
Okay.
So that 100 ml thing, 20 cc?
No, you can't use 100 ml in the neck of the femur.
3 milligram in 5 ml.
And then dilute it in.
Oh.
Okay.
5 milligram in 100 ml, two companies, and one company 3 milligram in 5 ml.
No, we get a pre-filled 100 cc bottle, no? That we use.
That has 5 milligram. 5 milligram in
I use that. I just order the bottle.
No, it's too less a dose to be used intraosseous. So always you should use a 5 ml, 3 milligram
right.
in 5 ml, and then you dilute it to 10 ml, and then use 1 or 2 cc from that.
But if you are diluting it thorough, then it is not 3 milligram per ml.
No. So then it becomes
half.
1.5 milligram.
But it is still less diluted than 5 milligram in 100 ml.
Right.
Okay. And yeah, I've been using this. I just order the bottle. I take 20 cc, put it in a syringe and put it on the syringe pump, because this is what Prasad taught us.
No, but he's also using
ready-made, whatever is ready-made.
5 ml, not 100 ml. 100 ml is for IV infusion.
Okay.
It is not
I
for
use the same
intraosseous.
bottle and I just push it so that it binds there.
So it's a homeopathy dose.
Huh? So we don't know really. Okay. Yeah. I put it on a syringe pump and push it under pressure with that in the tract using a needle, large bore needle, cannula. That's what I said. Because there may be backflow, you put gauze pieces or gel foam and prevent that backflow and do it over 20 minutes. So out of that 20 cc, hardly 1 or 2 cc actually binds to the bone there. And whatever that binds to the bone there should prevent collapse by inhibiting osteoclastic activity. That is all that we can offer right now. And wait till revascularization. So this, I'll show you an example. This is an example which I did recently. This was again neck femur treated somewhere else, cannulated screws, avascular necrosis. This is how she came to me. Okay, so we removed the screws and put zolantric acid in the tract and then just waited for 1 year. So this is the tract and this is the necrotic area. Now this area we waited for this to heal up. And actually if you see over a period of time, you can see that the bone has revascularized. There is a nice bump here and this part is the one where impingement is happening. There is hinged abduction. Okay, so what we did is second step, after a year or so, we went ahead and did a safe surgical dislocation. And then I removed that bump, trimmed that neck area and transferred the trochanter distally. And this has given her a very good outcome from a painful stiff hip. She became relatively pain-free and she got decent range of motion over the next 3 to 4 months. And this is a video she sent to me from her home. And in India, we all want to sit cross-legged and sit on the floor for toilet purposes. So that is the requirement that she had and she could get that. And in another few years, she has got, now a year has passed, she has got excellent range of motion. So the head heals and it remodels and you have a second chance of reshaping the head. After the AVN process is over, so you wait for 2 years till the whole thing settles down. And you can help it by using bisphosphonate, letting it heal, letting it revascularize. Meanwhile, you do physiotherapy and prevent further collapse. If it doesn't collapse in 2 years, you don't need to do anything other than doing a head reconstruction. If it is not spherical. If it is spherical, you don't need to do anything. But AVN ho gaya hai, it's not end of the world. There's something that you can do. Yeah.
Sandeep, see, I have also tried zoledronic acid, and as Taral said that we are not sure how much quantity the head absorbs. So why not give oral alendronate and keep them non-weight bearing for a while? Because I have now somewhat
experience. See, if you are going to remove the screw, suppose you are not doing anything, you are going to give oral alendronate or an infusion like you do for OGI and hope that it reaches there. Logically, it makes sense that dead bone, how will it reach there if there is no circulation? So we don't know, really speaking. But what we know is bisphosphonate inhibits osteoclasis, and that can help. If we can deliver it to that spot, whether oral or intravenous. If you are doing an implant removal, I would suggest put zolantric acid there. That is all that I am saying.
You can use bone marrow. This is helpful.
Sir, bone marrow is already there in the neck. The neck has marrow. So what additional marrow can you put? If you take from this pocket and put into this pocket, it is still the same money. So that's why I don't like bone marrow so much.
Give a drill.
So when we drill, there is bone marrow.
Bone marrow not sufficient in this area.
How do you define when it is sufficient? We don't know. That's what I'm saying. What we are looking at is, can we modify biological behavior of the bone which is trying to revascularize? It is trying to heal. So you give it some support, wait, like Premal said, range of motion, cycling, non-weight bearing, wait long enough. When the bone quality improves, the sclerotic areas goes away, new bone is formed, then you assess what is the shape. Now if it is round, you don't need to do anything. If the cartilage is good and there is impingement, you treat the impingement.
Sir, we are using zoledronic acid in many cases, like extensively in osteogenesis imperfecta. There is zoledronic clinic in Dhaka Medical College Hospital and in Nitor. Routinely it is given in Nitor by Biplab. We are using it in pseudoarthrosis of tibia. Results are good, sir. And two companies in Bangladesh, they produce that zoledronic acid 5 milligram in 100 ml, and one company 3 milligram in 5, and they're cheap, sir, around 5,000-6,000. No, sir.
We'll not talk of Perthes now. Let's finish this, because we have only 15 minutes.
I think the whole idea which Sandeep has said is that when you diagnose AVN, the best idea is to prevent collapse of the head.
Correct.
Right? So it is going to heal. This is not going to give you healing. It's not going to help in revascularization. But till, as in Perthes, the revascularization process is over, we want to prevent collapse. And that is what is done by inhibiting osteoclasts by zoledronic acid, orally, IV, or intraosseous. We don't know how much it reaches in the head by all these forms.
Correct. It sounds logical, and this is a biological agent which is expected to help. There are some promising results. There is no big series that I can quote for this. Okay. So the second complication is, so like I said, AVN is the biggest dreaded. So what you have to do is correct reduction, good stability. Age is not in your hand, and your fracture pattern not in your hand. What is in your hand? Good reduction. Decompress hematoma if you want to, may help, may not help, and stable fixation and support the fixation. That is very important. And even if there is AVN, don't lose heart. There is something you can do, and that can be done. Coxa vara, this is usually when you have inadequate implant but healing happens, or implant cuts out but healing happens, then you can just do a subtrochanteric osteotomy. So this was coxa vara after neck femur. Fibrous union was there, partial. So we just changed the biomechanics. Again, no bone grafting is needed here. So every time you don't need bone graft, you have to understand where you need to put the bone. Okay, and that heals up without any. Again, delayed presentation, late presentation, no open reduction is required. Please treat it close, don't add to the insult. This is again Moulin's case, fracture, screws broke, size of screw was not correct, he revised it to bigger screws. So again to highlight, it's not the size of the screws. After 6.5, complete AVN. Okay, so it's not the screw which is to be blamed. Okay, and this ultimately ended up with girdle stone. Now when you have a complete collapse and the head is non-reconstructable, what works is excision arthroplasty. So you do girdle stone, and that child can now move around with decent function and ability to squat. But the limp is not going to go away. Okay, there will be some limp. Pathological fractures, some pathological fractures, again this was a case with infection. A lot of us will see septic arthritis, and post-infection and drainage, part of the head is destroyed. Sometimes you can end up with coxa vara or non-unions, and the issues are shortening, lurch. Once the infection is completely settled, again the same thing. When you have a fracture, let the primary disease burn itself out. Or if there is AVN, let it revascularize. Then you make one more attempt. The second chance is always there to reconstruct. So reconstruction was done in the form of valgus osteotomy. Again, they have used a DHS, a fibula graft, and they used a DHS reamer to put the fibula graft, and then they did a valgus osteotomy. And this is what was done, and this is how it healed over a period of time. And now you have a healed neck, okay, with a short neck. So the neck has healed, there is a head, there is good range of motion, but now you have bad biomechanics. You can do one more surgery to change that by relative neck lengthening. Okay. This is my case, again post-septic osteomyelitis, fracture neck femur. Primarily I did a valgus osteotomy. You can see that the head went into AVN. Okay, so the process was still going on. Then I waited till everything healed up. I removed the hardware and then I did a distalization of trochanter. Again we waited for the head to revascularize completely, and see, this is how the head has finally healed up. At maturity you can see good cartilage gap. Okay, it's important to see this. A good cartilage gap tells you there is healthy cartilage on top of that necrotic head. And if the head revascularizes and is reasonably round, okay, you will get excellent function. Okay, so now is okay. It doesn't matter how the X-ray looks like. Okay, pathological fracture neck femur, again cyst. Again tomorrow I will talk to you about bone cyst fractures. Now this was treated again by our friend Sandeep Vaidya. He sent this case. He did curettage and then he put fibula and he put a lock plate. But in spite of all this fixation, slowly what happened was the neck collapsed and the screw penetrated. Okay, so he had to revise it, and then he did a repeat valgus osteotomy and used a DHS this time and with some bone grafts, and then eventually it healed up. Okay, so neck femur area with a bone cyst is a little tricky area where the neck reconstruction may not work immediately because of weak bone there, and you may need more than one episode of bone grafting, and eventually that has healed. So last 10 minutes, so 5 minutes I'll just wind up. So again IFICS recommends, this is an acute vascular event where your ascending ring is disrupted. AVN is related to choice of implant and stability and accuracy of reduction. Timing should be urgent, not emergent. Operating at 2 AM in the night with no staff is not a good idea. You do it first thing in the morning on your first list on an urgent basis, but it is not an emergency as you think. If you don't do it in 4 hours, it will become AVN. No. The single most important determinant of AVN is age, fracture pattern, quality of reduction and implant, stability. 2 things in your hand, 2 things out of your hand. Okay. Choice of implant we spoke about, smooth pins less than 3, 3 to 8, 4 mm screws, 8 plus 6.5 or pediatric hip. You can always cross the physis, not a problem. Side plate can help to reduce or avoid a spica. Adolescent fractures use Powell's classification and a mini DHS. Delayed presentation, coxa vara, you can do valgus osteotomy and fixation. Long standing non-union with resorption of neck, fibula grafting with valgus osteotomy, open reduction not recommended. AVN can be treated, you need to be patient. Thank you.
Any question? Dr. Kamruzzaman Tushar, he is Associate Professor Pediatric Orthopedics, NITOR.
Sir, in case of valgus osteotomy by DHS, so distal fragment needs lateralization.
Correct.
So it's very difficult, sir.
No, sir, it's very easy.
How?
Taral Bhai has made a jig now. You can use his jig. It's a 3D printed jig. Otherwise, what happens is our concept of lateralization should slightly change. Just imagine that you are going to unite the lateral shaft to the distal shaft.
Yes, sir.
So you adduct the fragment completely and it is an end to side healing.
Yes.
So your medullary canal is not lined up to the shaft. So what happens is that you put in situ guide wire, you put in situ screw, then you put DHS guide wire, and then you put DHS screw of appropriate length. Then you choose a plate which is off the shaft. So you choose 135 or 140 or 125 depending on what you want to achieve. When you put that implant on top, the plate remains off. Once the plate remains off, you want to bring shaft to plate. So you make a cut and take the shaft, lateralize it and make it heal to the lateral aspect of the proximal fragments.
Yes. Sandeep, just to add, if you make...
Which will give you where to make the cut, from where the guide wire goes, and this is what it is.
pictorially. End to side. Okay, this is the shaft. Actually, the medullary canal, the pyriform fossa is lined up here, but this is how you heal it. So that depends on how you place your implant.
So just just go one slide back, no? So the technique, one forward. So the technical tip is you have to keep your DHS screw 2 centimeter longer than the lateral shaft. Okay. So once your DHS screw which is longer, then your plate will also sit more lateral. Okay. And don't use the outer cortex reamer. If you use outer cortex reamer, your DHS plate will slide over the screw. You don't want it to slide over the screw. So if you put a longer DHS screw and if you put a long barrel plate without outer cortex reamer, you will get this construct. And then what you have to do is get the shaft to the plate. Automatically it will get lateralized.
Okay. Any last question?
Sir, my question is, sir, is there any role of PRP therapy in case of avian or femoral head in children?
No.
Thank you.
Simple answer.
Sir, my question is that in case of fresh cases or fracture neck of femur, so you are recommending every time you have to do the reduction closely.
Yes,
so
as far as possible.
So
but if you are not getting a perfect reduction, open it.
So
either Smith Peterson.
How many attempts that you will be?
2 to 3, not more. Don't keep on playing around with it for 1 hour.
Okay, so that you.
So remember, it is a vascular event. There is a retinacular vessel which is going along the neck from front and back. When there is a fracture which is displaced, it's all disrupted. You cannot keep on playing around too much. Whatever intact little vessels are there, don't damage them. And get the best reduction. Why? Because we want the best contact area, not only for healing, for revascularization. And don't kick the vessel which is ascending on the lateral side, that is in the pyriform fossa. So no excessively valgus reduction. A good reduction with smooth curves and a stable fixation so it doesn't collapse.
Second thing is that you have delayed cases. So what is the definition of the, how do you define these delayed cases? How many days?
And 3 months and above, 12 weeks and above, anybody who comes late I define as a delayed. But it is variable. Depends on which part of the country you come from or the world. For Americans, 10 days may be delayed.
So
in ours, this is routine.
So in case of delayed cases, you are recommending to do the reduction will be closed method, right?
It's close, always as far as possible close. But delayed when you, as in 4 months, 5 months, 6 months. Okay, I am not a big fan of trying to doing an open reduction because there is already attempt at healing and revascularization because of some channels, some synovial folds which is happening. There is no point in disturbing them. And when you do that in situ, you have to add a valgus osteotomy.
Thank you. So if there's no more question, we can end here. This has been, oh sir, yeah, please. Professor Shamol Chandra Devnan.
Simple question, sir.
Yes.
In cases of delayed presentation with varus non-union or fracture neck femur, lateral closing with osteotomy, medial opening with osteotomy, which one do you prefer for healing advantage?
So since we are going to do a valgus osteotomy to change biomechanics, it's easier to close a wedge. But like I said, if you are doing end to side, see, I don't know, this is my personal opinion, I have no reference for it. I do not understand the concept of open wedge and closed wedge. An osteotomy is an osteotomy. What do you want to achieve with it? You cut the bone, that is osteotomy.
Yeah.
When you lateralize the shaft, like Taral showed, you lateralize the shaft and it is end to side healing.
You don't need a wedge.
There is no wedge, there is no open, there is no close.
Okay.
You cut the bone and put it together.
It's a translation.
It's a translation. You want to call it something, you call it translation.
It's angulation translation.
So just cut the bone, angulate it and translate it.
The way it is done is you put your screw at 120 and your...
I think that we are discussing maximum over the fracture, which is one of the most uncommon fracture of the lower limb. Because it has highest amount of complication. Okay, so what I have chosen in the next talk of infection is there are going to be 4 different regions and 4 different type of problems and solutions. So yesterday, after Dr. Bari's presentation, there were a lot of questions and answers regarding post-infective non-unions. So I'll show different methods of doing it, and I'll show different methods failing also. This is going to be our area of discussion. So let's start with a simple pathological fracture. This was a 9-year-old girl presented to me and 7-18, and this was her function at the time of presentation. But if you look at there, something is happening there, and this is the MRI of this girl. So what do you think should we do here? Are you sure that this is an infection because this girl has no pain? This is how our MRI picture is there. What should you do? Yes, Kausar?
The marrow looks sedimentous along with soft tissue swellings and collections is also there. So if you want to plan something, I think marrow decompression will be one of the options. You have to decompress the marrow along with your soft tissue, the soft tissue collection or collection around the bone. You have to decompress that also. Along with that, if you need any stabilization, just put some.
So I was not very sure about the pus. So first time, and child didn't have any antibiotics also, and she was very less symptomatic. So whenever there is a subacute osteomyelitis, the recommendation is you do a biopsy first, prove it that it's an osteomyelitis. So biopsy was done, which turned out to be without any simple osteomyelitis. So I went ahead and did the clearing, but post-operatively I had a fracture. That fracture, because the fracture was, it happened in the plaster which I had given, but the infection was taken care of. It went on to heal like this. But should you accept this? Sandeep, suppose this heals like this. Sandeep, if osteomyelitis heals like this, would you accept this or would you correct it?
What is the age?
She is about 9 years old now.
Yeah, I'll accept it for present because there will be hyperemia and that can cause spontaneous correction.
So I waited for this, and unfortunately she fell again and had a fracture at the apex of that. And at that point of time also the relatives came to me with an X-ray which was already in plaster, and I said it is a good time that we can correct the deformity. I don't know, this something comes up down there. Can we end this? How can we end this?
So what is the situation now?
So now she was not happy for surgery. So we just plastered it, was healing was done. So what happened, I don't know. But every time when you get a pathological fracture, it's not necessary that you need a surgery. It can heal conservative occasionally if you are sure that the infection was taken care of there. Okay. So now let's go to a longer story. Because something is happening there. Whatever I am speaking, it is translating there. हाँ, वो कैसे आ गया मेरे को मालूम नहीं है, और कैसे बंद करना वो भी नहीं मालूम. एकदम एविडेंस बेस है, वो रिकॉर्डिंग हो रहा है मेरा. Okay. So 5-year female, fell and developed swelling, fever, 2018 story, and as usual you can see that there is a progression of osteomyelitis. One most important fact which I would like to show you here is that whenever you have two-level fractures, one here there is one fracture, another fracture is here. You can see one fracture is here. Whenever there is a segmental fracture, there is a high chance that the in-between fragment will get absorbed. Now you can see in this, there is a big sequestrum starting from here to here, and there is an attempt of revascularization. If somebody had done something at this stage, probably some better outcome would have come. More progressively, you can see that there is a migration, and at the time when she came to my hospital, there was a frank sequestrum formation, and unfortunately it was coming out from the posterior side, very dangerous area. So it took me a long pain to dissect that out and sequestromy with vancomycin impregnated cement spacer. As Taral said, how do you make a cement spacer? So if it is ulna, you can take 5 cc syringe. If it is femur, you can take a 20 cc syringe, cut it in the half, put one half on the other side, put a cement which is about to solidify, which is still like a dough. Put a second half of your 20 cc cut syringe on the outer side, and it will make a perfect smooth surface. This is the cement, as you can see. This is the cement. This is the cement on this side. So with this cement spacer and IV antibiotics, we got a healing of fibula grafting with. The second stage was a famous surgery which we all learn is Elizarov. So in this Elizarov, IM nailing was done with fibula grafting, and I took a graft from iliac crest also. 2 months, 4 months, not much things were happening. The patient was very unhappy, so I removed it and put a walking spica. Right? So walking spica is possible. Taral also showed you a patient walking. I am showing you a video of the patient walking with the spica. But after the spica was removed, this was the condition, and this was the movement. Movement was very less at that point of time. And after some time, she fractured, and she had distal non-union. If you see here, this part has failed to unite. Proximally, everything is good, but here, and that's why there's a. So the surgery 3 was done, in which a locking plate was applied. Intermedullary nail was kept, and iliac bone grafting was done. And in some time, there was some movement, but gradually that movement also went, and in few months, 8 months later, I am back to square one. Elizarov has failed, Elizarov with nail has failed, nail with plate has failed, and now I want you to help me with this case. Who is ready to help me with this case? What should be done? And if you realize by that now, if you look down, the knee is also fused. So there is a knee fusion, so the distal fragment has a long liver arm now. I have already done 3 to 4 surgeries. I have done 2 times bone grafting. So what should be next? Elizarov already tried, plating also already tried. So now what? You all are laughing at me. Sorry? So I told them again Elizarov, but they said no Elizarov, everything. I am not a very good Elizarov surgeon, let me tell you. There is no infection. There was not a single time infection after the first surgery.
Telescopic nail with.
So this time I revised the plating. I used more non-locking screws this time than the locking screws. Repeated the bone grafting, and this is the serial follow-up. 2 months, 4 months, and this is 1 year follow-up. She has a significant limb length discrepancy, good union, and her knee is unfortunately fused, and she will require significant lengthening because both upper tibia and proximal distal femur and proximal tibia probably both are involved in her growth. So the best thing you can avoid is pathological fracture at double level. One fracture, if patient comes with one fracture, you must treat as early as possible before the child develops a second fracture. This is how she is functionally walking. There is no movement at the knee joint, and parents are absolutely tired of surgery and they don't want anything. They said she will walk with shoe raise, but I'm sure, I don't know how long that will compensate because they're not ready for doing shortening on the other side as well. So let us look at the another region and another problem. So this child came to me with a pathological fracture at both ends. If you can see, pathological fracture is here and pathological fracture is here. So I did a debridement and I put this boy into chest fixator, biplanar fixator. But that does not always mean that I will be successful. If you look at the follow-up X-ray, gradually the in-between fragments started disappearing. And this is how the child's happened over a period of time, right? So now what? Fibula transfer, how many of you have done fibula transfer? 1, 2, 3, 4, 5. So how do you do it? Single stage you do it or double stage? One you transfer the proximal and second you transfer distal. How do you do it? Yes. With Elizarov? You all are very champion of Elizarov. I am not so champion. Any other thoughts? I agree that such a big gap. Sandeep, you are a champion of fibula. Which fibula will you take? Opposite side or this side?
Opposite side. Because this like no one bone is intact which adds to stability. So when my healing is being done, I would like this to be there.
Okay. How many for the same fibula? Everybody was saying fibula now, but nobody is raising hand after Sandeep spoke. Sandeep has a great command over audience. Everybody was raising their hand for Huntington, and now since you said opposite fibula, nobody is raising their hand.
So Huntington has a big morbidity. Huntington's procedure is big morbidity, and if you lose that fibula, then the leg becomes very unstable. So you should take fibula from the other side.
Okay. So this is the child took another year to decide whether they want to do anything or not, and that is how is the situation. That fibula is also causing a problem. So I decided to do Huntington's procedure. It was done single stage, intermedullary nail from inside or was used from bottom, and at both the places additional fixation was done, and this is the gradual follow-up, and at this point of time the child was lost to follow-up. What do you think will happen? Somebody said they have tried.
Proximal fracture fragment. The proximal fragment will, I think, eventually fail.
Yes, proximal fragment is. I mean, there is an attempt to unite, but it is not united. But at this point of time, the child decided that I had had enough, and went away. And came back after 8 years. This is the alignment of that child. This is the limb length discrepancy. This is the function, and there is a shortening of about 4 centimeters. And you can see all the KYs which I had put have migrated. It has broken because the distal tip here. You can see that distal tip. This was somewhere here. It has gone up, this intermedullary KY has gone up, and that KY has become almost straight, and there is about 4 centimeters of shortening. So there are more than one ways of doing it. Sandeep said different, I did different, and probably somebody would have done a fragment transport also. So there is all the way you like, you can deal with it. I am just trying to show you different options adopted by me at different times. You can see this is how the comparative tibia look at the final follow-up at near skeletal maturity. I wouldn't say at the skeletal maturity. Okay.
And losing follow-up is also good, right?
Sometimes you go away. I think today I showed 2 times that doctor advised surgery and patient decided not to do anything, and nature helped the patient. It's not always the case. I think you will have to advise. That doesn't mean that it should always be a good result. Okay. So patient similar to the case shown yesterday, X-ray first time. Again I am trying to show you. Look at this. One fracture here and impending fracture here. Once you have 2 fractures, the in-between blood supply is cut off, then you get a sequestrum like this. And child presented to me with this type of previous surgery and this type of movement. Currently she has significant pus which was drained from the old incision, sequestrectomy was done, and after wound healing she had somewhat improved abduction. She was then treated with second surgery in this form. Plating and bone grafting, but unfortunately within 3 months she developed this type of radiological picture and small infection. So I want to know what should be done now. Are you happy with the union? There is now recurrence of infection. Every few days there is small swelling, I give antibiotic, it subsides. Should I continue this way or should I intervene? Yes sir, you said something. Sir, you said something?
I will remove the implant first. Then I will make an osteotomy just at the fracture site, at the non-immune site.
Sir, there is an infection. If you remove the implant, will you do additional surgery except
Yes,
external fixator?
yes. Additional surgery, just make the curatives or debridement, and then some with bone cement, make bone cement with antibiotic beads. Then I will do surgery with tubular graft, then later on, after 3 months easily.
So I also said that it is a good idea that we can retain the implant, but we have to put a cement there. Patient again refused. So she had about 10 episodes of infection, then it will subside with antibiotic. But fortunately she united. I was lucky and the implants were removed, and this is how she ended in a function. And she has a significant shortening, but they don't want surgery. Upper limb shortening is not a problem. As yesterday it was discussed that there was shortening of this much. Upper limb shortening has no functional consequences, majority of the times. Okay, coming back to the last region and the last treatment modality, I urge you that so many difficult surgeries were shown by Taral, Sandeep, and 1 or 2 by me as well. Don't try everything once you go back home. I am telling you a story of a junior enthusiastic pediatric orthopedic surgeon who had who got a 2-year-old female and had this type of pathological fracture, and when she presented to him, this was the situation. Yes, Kausar, this young orthopedic surgeon was as young as you. He had attended a Asami meeting and decided to do some fancy things. But suppose this child comes to you with no infection at this stage, what will you do?
I wait.
Do you think it will unite? This is already 6 months down the line. I don't think it will unite. Taral, your take on this? Sterile lesion 6 months old from the original infection. This was how it was initially. Again, I am showing you fracture here and somewhere fracture here also. And then there is a disappearance of in-between fragment and a pathological fracture. The canal is closed here, canal is closed here, and this is the situation.
Wait for some more time, let the bone mature a bit, and do a plating and bone grafting.
So waited for a while, 3 months in spleens.
Still works.
Still wait. How long? Is there a cut-off time which we will say?
Is she having any problems? Like,
yes, she's not using that arm that much, and there is a deformity there. And she's not using
there is
that.
no infection. If
there is no
infection period of 6 months, I will do plating and grafting.
Plating and grafting. So this young
or nailing and grafting.
Yeah. So this young gentleman had attended Assam meeting and decided to do a fragment transport. There was a just fixator with intermedullary nail and fragment transport.
That's a bad choice of implant. The reason is this fixator, it's using K wires. You cannot do bone transport over K wires.
Yes.
You need chance.
The child is now only 3 years.
So there are so bad choice of procedure.
Yes.
And bad choice of implant for the procedure.
Yeah.
And just fixator, it revolves around. It's not stable to rotation. So this is bound to fail.
Yeah. So in one fine morning, everything came in the hand, and now there was a segment. This was a fragment which was transported, had no union on this side, had no union on that side. And story doesn't end there. The child was then immobilized in a brace, and she developed radial head dislocation. Okay. So she came to me last year with this type of function, and this were her X-rays. So now this is a very simple case of Miss Montegia with a non-union of ulna. So Taral, now what do you think should be done?
So Linden ulna.
Linden ulna.
Along with that Linden radius, get radius in place, and that gap.
So the ulna is very, very osteoporotic. It has come out of.
No, so distracted. Get radius in place, you will have even bigger gap in ulna, which you will have to graft with a fibula graft.
Yeah. Any other opinion? Single bone forearm. Single bone forearm, Tarun, your opinion for that?
This is not for this. You need for much more.
It's too young. I agree that. So you cannot do a salvage surgery without trying at least once or twice. So,
it is using AK-47 to kill a mosquito.
Okay, so this is the comparative X-ray. I took the length of the opposite side, and this is how this side was. So as Taral described, I put a chest fixator with K-wire, distracted it, but in some, when I negotiated a nail, but at the end of it, that came out, and I could not get the radial head close reduced, and I couldn't stretch the soft tissue there. So I ended up doing a fibula grafting and did a somewhat bone grafting as well. So 3 months down the line, this was the situation. So what next? What do you think will happen? Wait. Waited. Now what? Radial head is out, K-wire is broken, and your fibula is now going for non-union.
You get ulna to unite first.
Yeah. So he's laughing. I want to ask him, why you are laughing? You are laughing at my plight?
No sir, removal of implants and take a graft from the radial shortening and shortened portion grafted to the ulna.
So radial shortening. Yeah, that's very well. So this is the deformity. So what we did was, first I removed the implant, put a new ulna nail, then I put a plate on it, then as you advised, I did distal radial shortening. That was, I had kept a plate, but the bone was so thin, I ended up fixing just with K-wires, and whatever that bone graft was there, I put it at the ulna, and I tried to pull the radius and tried to put a K-wire, but I was 100% sure that it is not a reduced. But the prominence was gone. I was not ready to do anything. So 6 months later, it is very, very gradually uniting, but then I felt that this is not uniting very well. So recently what I did was, just last week, I removed the implant and I did a stack nailing, as I think Taral suggested that in the morning after the nail, 10 nailing, that proximally you can put more wires. And I am hoping that this ulna will solidly unite, and I will keep the K-wires for at least 2 to 3 years before I attempt any surgery for the dislocated radial head. Taral, your comments on this?
Yeah, so that's fine. There are multiple problems, and when there are multiple problems, wisdom lies in solving one at a time. Yeah. Simplify the more complex problems. You got a union now, and then in future you can always do ulna lengthening and get radius.
Of course. So that's, I think you should not have a very big ego that you are a big senior pediatric orthopedic surgeon. And in Ahmedabad there is a senior cardiothoracic surgeon. I am probably the senior most, I have not written anywhere, because I know that senior or junior problems are problems. Nobody can tackle every problem simultaneously. There are some heroes, and we learn from the experience that one problem at a time, as well said. So you get the ulna to unite first, give some breather time to the family to enjoy their child's childhood, and you can always come back and do the radial. So learning point is avoid pathological fracture, protect the pathological fracture, avoid a segmental fracture, as I told you multiple times. Closely follow a segmental fracture, because mostly you will get a gap non-union. Control infection and stabilize first. Final surgery is only after you get rid of infection. Use a stable fixation, use judicious bone grafting, watch for recurrence of infection, and discuss with the family that multiple surgeries will be there, and
Once you get a union, there may be multiple later on surgeries for the lengthening. Thank you very much.
We are going to discuss fractures in OI, and it's important to realize that type 2 OIs, they generally don't survive, so you will never see a fracture in them. Type 3 are the ones which fracture very often, they have deformed bones. So diagnosis of OI is not difficult. Type 4 will fracture again 2 to 3 times in a year. They have dental problems, eye issues, very easy to diagnose. Type 1 are very difficult to diagnose because type 1 may present to you for the first time with one fracture, and that time generally it is in tibia or it can be in the lower end of femur. And it's very important to recognize, looking at the eye of the patient, if there is a blue sclera, you will be able to diagnose. So the bones are thin in those patients, and that's what tells you that this could be OI, and it's a trivial form. But type 2, 3 and 4 are not an issue. So osteogenesis imperfecta is a case where there are multiple fractures throughout the lifespan, and a girl like that who had developmental delay and some bowing and suddenly fell one morning and developed this fracture. And it's important to see fracture in both planes. What looks simple, moderately simple in AP, suddenly when you see a lateral, this is a difficult proposition altogether. Okay? So it's important to realize that children with OI get repeated fractures, not because there is something wrong with the osteocytes. The problem is there is something wrong with the matrix. So here this is a building problem where the bricks are normal but there is a bad cement. So either the quantity of cement is less or the quality of cement is bad. So that is what happens. So why this happens is because what is the ingredient of the cement, which is the collagen, is a problem. There is nothing wrong with the calcium, there is nothing wrong with vitamin D here. There are two places where the collagen comes from, chromosome 7 or 17. So either in one of these chromosomes or the cross link, there is an issue, and what that causes the bone to become brittle. Now in type 1 OI, which have very few fractures, the quality of the cement is good, but the quantity of cement is bad. And that's why they get osteogenesis imperfecta and frequent fractures. And that is, there is abnormal bone fragility, there is a blue sclera, and it is an autosomal dominant condition. So this is one of such patients. This girl had tibia fracture, and when I looked at the fracture, I realized this child also had blue sclera. So that one of our residents diagnosed it, and then because this was the condition, the treatment was not just plaster. We treated her with nail because this takes time to heal. We gave her bisphosphonates, and then we also did growth modulation to treat her genu valgum. So the treatment in normal tibia fracture and an OI tibia fracture is going to be different. Type 2, 3 and 4, the problem is not just quantity but also quality of cement, and this is because one of the collagen is of bad quality. In type 2, most of the children will not even survive. They have multiple rib fractures, intrauterine or after birth, and they will generally die of asphyxia. Type 3 are the ones which will have multiple fractures, severe bone fragility. They have blue sclera at birth and severe growth retardation. Okay, so type 4 is the one which are children will walk, but they have multiple fractures. So our child is type 4 osteogenesis imperfecta. The treatment here is not just surgery. The treatment here is a combination of medical management and surgical management. Medical management is giving calcium, vitamin D and bisphosphonates. Bisphosphonates, what they do is they will limit the osteoclastic activity and retain the phosphate within the bone and make the bone more sclerotic. Surgical management is in form of telescoping nails, and the dose of zoledronic acid here is 0.05 milligram per kg body weight, which can be given once in 6 months. And indications for giving them are if you have more than 3 fractures per year, or significant vertebral compression. So that's the reason to give bisphosphonates. Coming back to the orthopedic aspects, here in this patient, the way we manage this child is did a fracture healing first on the left side, and you will realize that this is not just open reduction and internal fixation. You have to shorten the bone, correct the deformity. You sometimes end up making multiple pieces of the bone, doing what is known as sheikh kebab operation, and this is how this patient was fixed using a telescoping nail, a miniature version of telescoping nail. Then once this healed, we did the same procedure on the other side because that femur was also bowed. You can see that this patient has now received some dosage of zoledronic acid because you see those zebra lines, and each zebra line corresponds to one dose of bisphosphonates. And this is how she grew up now. She is able to walk, go to school, and maintain good alignment of her femur. And as she grows, the telescoping is happening, but at some point in time, your telescoping nails will give way, and that's the time you may have to change. So at present, because she doesn't have any symptoms, she doesn't have any bowing, we are maintaining with this. She underwent the change of the nails in 2020, and again she is doing well. So that was the treatment. This is again a more challenging problem here, a fracture in a child with osteogenesis imperfecta. So on the left side you have a subtrochanteric fracture. On the right side you have a segmental fracture. There are and this needs to be managed. And this patient again was managed using telescoping nails, single sitting bilaterally, and you can see that the AP looks not good. But I am showing the mistakes I have done on the lateral. The left side looks fine, but if you see the right side, this nail is way posterior. Ideally, I should have done one more osteotomy here so that the nail would have gone in the center. It's very important to keep all the nails in center if you want telescoping to happen. Okay, so this patient healed well, started walking well, but as you can see over a period of time, on the right side especially, there is no telescoping happening, and there is a segment of bone which is unsupported now. So the moment you have segment of bone which is unsupported, it is prone to bending and breaking again. So this is working like a simple rush nail. It is not working like a telescopic nail. So there is no doubt that at the junction of the female and male rod, she had a fracture again after a fall, and then we had to revise this. And at the time of revision, in addition to putting a telescoping nail, we also put an external fixator to control rotation for a short time, and this healed well, and she's gone on to do well in life after this. This is still more severe form of osteogenesis imperfecta. You have bowing of the femur, tibia, and forearm, multiple fractures where nothing has been done. And in this patient, right femur is the only bone which is intact. All other bones have severe form of bowing. And what we did here, we started with the femur, straightened it. The next stage, we did tibia. You have to do again shortening of tibia. And in tibia, we were not able to pass a telescoping nail, so we had to do with rush rods. And you can see what is happening to the fibula, the zigzag fibula. And this is over a period of time. He healed well. Then we did forearm fixation with K-wire, multiple osteotomies and K-wire fixation. And by this time, his rush nail, which is a non-telescopic nail, became short, and there was bowing again at where the nail ended. So the journey continues. We had to put a telescoping nail again. By the time the child was old enough that we could put telescoping nails. And now, child started going to school, and the only femur which was not bowed, it fractured. Okay, so there are multiple events which keep on happening in these children, and we have to be ready for multiple surgeries. So we put a telescoping nail there. These should not be treated by elastic nails. Now, a lot of time I see femur fractures in children with OI are treated with elastic nail. The problem is there will be stress riser at the entry point. And secondly, the elastic nails will outgrow, the femur will outgrow the nails and at end of the nails again you can have bowing or fractures. So this child, from there to here, we've been able to treat him well. He's an active, player now. He goes to school and is managing well because of his medical and surgical treatment. Showing you some more complicated cases, wafer thin bones here, popcorn calcification at end of the bones. So some more severe forms of osteogenesis imperfecta. You get scoliosis, you have rib anomalies, and in this child, again, a sheath kebab osteotomy. We could just pass the K-wires in this child. No scope for passing telescoping nails. So you can see, wherever there is a deformity, there is a fracture. Moment you straighten the bones and treat them medically, their fracture rate reduces and they become more comfortable. You can see here the femur is looking like a rib almost. One more thing to realize is that the bones in OI are not circular, they are flat like a ribbon, and putting any kind of circular nail is a big issue in these patients. So with all these difficulties, we could manage. Anesthesia is a problem, and managing these patients post-op is also a problem, but we could get her to be straight and walk. And from there to there, this is a girl who now is going to second year of BCom and is a very avid blogger and dealing with her life well. This is a child who had a fracture of proximal femur with OI and shortening, and the question was, can we lengthen in OI? So of course we can lengthen in OI. The regenerate formation is good, so we put a telescoping nail. The difference here, you have to put a telescoping nail, a simple rush rod won't do, and do a monopolar polar fixator and lengthen. And this girl we could lengthen well, but you can see that there is also varus of the proximal femur. So at end of the lengthening, we did a valgus osteotomy of proximal femur, and then got her to doing well. So on the right side you can see a femur which is bent and is short, and on the left side, on the right side, she's got almost equal leg lengths now, with the proximal femur also corrected, and that has improved her walking. So the question is, you may do all these things, you may do surgeries, medical treatment, but will they live happily ever after? The answer is really no, because the moment you treat these and they become young adults and adults, they have cardiorespiratory problems, they develop scoliosis, they develop muscle weakness. Remember, OI is a collagen problem, and muscles are also made up of collagen. It's not that the bone is made up of collagen. These children have hearing problems and deafness, they have renal issues, and many of them have a short lifespan. So what I want to say is, it's a spectrum of disorder. It's not one condition, it's a spectrum of disorder. We have some medical treatment, we have some surgical treatment, we have answers to a lot of questions, but there are still a lot of questions in osteogenesis imperfecta which are unanswered. Thank you.
So, coming to difficult fractures, Premal Bhai and Taral have already showed you two difficult fractures. And the third one that we commonly see and all of you will be treating is probably a fracture through a bone cyst. So I'll just highlight a few points about bone cysts for you, which we see commonly. Now the questions that you have to ask yourself when you see a bone cyst is that, one, does it heal? Because for long we've been taught that the treatment of a bone cyst is fracture. Once it fractures, it will heal automatically. Okay, so that is one. Second is, does it need investigations? In today's era, when you say that it's a tumor or something, does it really need investigations? Third is, does it need treatment at all? Fourth is, does it need bone grafting if you are going to treat? Because conventional treatment is open, curettage, bone graft. Okay? What is the best way to treat it, and does it recur? Okay? So I am going to try to answer these few questions for you in the next 10 minutes or so. Conservative treatment of pathological fracture through a bone cyst results in resolution in only 25% cases. Okay, so what happens is that when you have a fracture from a bone cyst, the fracture heals, but the cyst does not. 25% of the time the cyst may also heal because there has been a fracture. But 75% of the times you get a fracture like this from a bone cyst, the fracture heals, but the cyst does not. Okay? So cyst remains. It's like a biologically active synovial tissue there, and fracture may not always result in resolution of the cyst. So that is the first thing. So don't be under the impression that a simple bone cyst will heal on its own. It does not heal 75% time. That means 3 out of 4 will not heal. What about the diagnosis? A plain X-ray is usually sufficient for a perfect clinical and radiological diagnosis. What will you see? You will see a centric. Okay, that means the bone anatomy is not disturbed. In an aneurysmal bone cyst, which is the closest differential of a simple bone cyst, an aneurysmal bone cyst is always eccentric and expansile. Okay, so epimetaphyseal, eccentric and expansile and rapidly destructive or rapidly growing is usually aneurysmal. Whereas a simple bone cyst will be centric, metaphyseal, marginated, lytic lesion. There is endosteal erosion without cortical break unless there is a fracture. If there is a fracture, you get what is typically known as a fallen leaf sign, which means a broken bit of cortex lies within the cyst. So the fallen leaf sign, which is seen in 20% cases, which is classic of a simple bone cyst. So an MRI, a CT scan or a biopsy are indicated only when there is atypical cyst, expansile cyst, progressive cyst, or a cyst which is there or appears after treatment. Okay, so which means that the behavior, the biological behavior of that cyst is not normal. There is something happening which is making that cyst persist. Unless these indications are there, an X-ray is good enough to diagnose a bone cyst, because I tell you, you try to do a biopsy, nothing comes out of it. There is nothing. When you try to do biopsy, there is only marrow or bone or some red fluid or something, or sometimes serous fluid. So your histologist will also not know what he has said and what to report. So a lot of confusion and additional treatment, these procedures may have to be done, which is not really required. So typically you can aspirate the cyst. You can see when you aspirate the cyst, you get something like this, a small yellowish colored fluid which can come out through the cyst. Now if you are treating this cyst with anti-inflammatory agents like steroids, this is the first step. You aspirate the cyst, you wash it under pressure, and then you can inject methylprednisolone. That is one of the ways of treating bone cysts. So this is just to show you how the aspirate looks like when there is no fracture. If there is a fracture, you will get blood, red fluid. Otherwise you get synovial-like fluid. When does treatment become necessary? When there is a higher fracture rate, when there is cortical thinning, and a child who is very, very highly sporty or aggressive or active, which most children are. So if they have a weak area in the bone and they are playing football or basketball, they are likely to get a fracture. Okay, and if the bone cortex has thinned out, then you will obviously need to treat it. But most of the times these cysts are latent in the sense that they will not come to you till there is a fracture. Very few times you will get an innocuous latent cyst which is not seen at all, and you take X-ray for something else and you see the cyst. Something like that. So that is very rare. Inherent pain is very little. Now this is a useful index which has been published. It's called the McEwen and Kaelin's index. The area of the UBC, unicameral bone cyst, measured at its widest dimension divided by diameter of the bone. Okay, so this is, say, the cyst, and say this is the diameter of the bone. So if the index in humerus exceeds 4, it will need treatment. If it exceeds more than 3.5 in a femur, it will need treatment. Otherwise you can continue to treat it by watchful observation. If there is any change in the behavior or pain, or there is a fracture, or if the cyst index is high, then you will treat it prophylactically, because there is a very high risk that this will fracture. Coming to management traditionally has been described as open curettage and bone grafting, but that is strictly not needed with the advent of percutaneous techniques, It has larger morbidity and morbidity and infection rates. Second treatment is aspiration and injection, and third is decompression and implantation. So there are three types of treatment available. Conventional open curettage, bone graft, some areas you will need to do it. Aspiration and injection methods, and decompression and implantation. So what are these? Open techniques involved curettage and bone grafting with subtotal resection using allograft or then fibula or bone graft. And Faber and Stanton had a 45-year retrospective analysis and have reported a 53% healing. So even with this open curettage procedures, only half the cysts have healed. Okay, and in JBGS 73, O'Brien and Fay reported 95% healing, but there was, both the papers said higher surgical morbidity. Volume of bone graft required may be inadequate, so you may need allograft, maternal graft or bone substitute. There may be resorption of the graft after the procedure, and from where you take the graft there is always chance of infection and bleeding. Okay, so these complications are completely avoided if you go for minimally invasive techniques, okay, where there is no invasion done at all. So the second method which the Italians popularized, Cagliati in 74, aspirate the cysts, wash it out and give steroid injections. And modifications, they did a cystogram, they put some dye, see if there are septae, break the septae, or inject separately in each loculation. So they had a 55% healing rate and 45% of them the cortical thickness improved. So again Faber and Stanton in their analysis said this has a 70% healing rate, which is good. Okay, non-invasive, just a needle, aspiration and steroid injection. Okay, and very low morbidity, but you may require multiple injections. Okay, 25% require, 76% people require multiple injections. One injection is not enough. So you may keep on doing it and still the risk of fracture doesn't go away. Okay, it heals the cyst, but you can still break from there. Marrow injection, somebody was talking about marrow. So autologous bone marrow injections have also been tried for this. Lokik, Yando, 95% healing. 5 of 12 only responded and 6 recurrences in courses series. Okay, so again marrow is not a guarantee of healing, but people have, instead of putting steroid, tried bone marrow implantation. Okay. Other bone substitutes have been tried, alpha BSM, Kronos or calcium sulfate pellets. A lot of papers in recent times which have talked about percutaneous methods where you curettage, refine, decompress and put some medical grade calcium sulfate pellets, and you can use that as a healing method. Although these are increasingly reported, there are concerns about systemic effects of these bone substitutes, and there can be embolization which has been reported with these methods, and the cost is upwards of $150 per supplement or substitute that you use. So it becomes a very expensive alternative for our situation. Then decompression implantation, you have the Japanese who are doing aspiration till venous hemorrhage happens, perfuse it with saline and just use a K-wire to drill the proximal and distal metaphysis. So what they are doing is decompress the cyst and encourage local bone marrow to come in by making drill holes. You are allowing bleeding to happen. And that itself will help because it's the same marrow. Rather than taking it from iliac crest, you are putting marrow from the same bone into that cyst and breaking the septae. Okay, the people have also said you can put a nail or a cannulated screw which will allow continuous decompression like this. So a screw which has a cannulation which allows that fluid to drain and slowly it ossifies. You can use bone pellets also with that. Question is, bone grafting, is it really needed? Can we avoid these open procedures? Can we combine these procedures along with decompression and the healing of the cyst? So this is a very, very old and cost, of course, in our country cost. So 2011 I had started a study, this is 13 years ago, and our initial cases, we studied them whether, how they are behaving when we put elastic intramedullary nail for UBC. So we decided we'll do the decompression method where you allow drainage and break the septae and stabilize the cyst with a nail and prevent fracture and see how it heals. So we had these patients, 15 in between 6 and 9, 8 were between 9 and 12, and 14 male, 9 female. All the demographics are here. And we did some presentations and we tried to study, and we used the NIRS criteria for healing. Excellent is complete obliteration of cyst. Residual defects, 1 or 2 static cyst-like areas are there, but bone strength improves, cortical thickness improves. And recurrence when the whole cyst comes back or actually increases, and additional operations are needed. Okay, so the first cases, we saw that all cases with elastic nailing showed improved consolidation. Near excellent was in 15, residual cysts with improved thickness in about 3, and about 11 months were needed to see consolidation. Okay, so we'll show you a few examples. This was the, so in our population, 65% were classified as healed and 34% with radiolucency. Okay, and we thought that there are no recurrences. That is what we thought was happening there. But as you, like it's all in orthopedics, the longer you become and maintain follow-up, the more complications you will see and more recurrences you will see. So over a period of time, as you get more senior, you see your own recurrences, and then you realize that there is nothing 100%. Okay, nothing in the world is foolproof. So this is what happened. A bone cyst in the diaphysis of an ulna of a young girl. Again, we have put in a simple nail there, and you can see over a period of time the whole cyst has disappeared and consolidated with excellent function for her. A fracture through a cyst in a femur. What we did was, again, this was Ender's nails. We put Ender nails, stainless steel nails, and the fracture healed and the cyst also healed.
So that is, what was the cyst? ABC or UBC?
UBC. These are all UBCs. This was a UBC. So this is how it was healed. Again, this was a 6-year-old male with a trivial injury. Pain was there pre-op, and you can see the fragment there inside the cyst, which is a fallen leaf sign. Now, neck femur is a very special area where, again, like I said, calcar area. I showed you earlier in the neck femur series. This is really tricky. So this, today you can do an MRI and make sure there are no solid areas and confirm that this is nothing but a bone cyst. In additional, if you need an additional investigation, you can see that black line is the broken cortex. Otherwise, the rest of the fluid-filled cyst is with thin septate and well marginated. There is no solid area which you need to biopsy. So this was treated by percutaneous trephination or aspiration. It was decompressed and an elastic nail was placed. So again, initially you can see that there is not much change, but over a period of time, slowly there is increased consolidation and cortical thickness is improving, and you have protection in that area, and slowly at 2016, you see that that cyst is gradually becoming consolidated. So particle thickness increases slowly, especially in weight bearing areas, and that is how it is in 2018, and after that I have not seen. So this is how the cyst can consolidate with good function. So there is a small classification published by Dormans where they have said that the neck femur area can be classified depending on where the cyst is, how large it is, and you treat it with implant and some kind of trephination with or without bone grafting. So this is another cyst which was pre-fracture. Now this was a large cyst with a KLN and McEwan's index of more than 3.5. So I just used 2 elastic nails, and you can see within a year the cyst has disappeared. So the bone marrow from the local area is going it. Once you stabilize the cyst, it just goes away. Now this cyst with a pathological fracture of the neck of the femur, again this was a large cyst in an adolescent. Okay, and initially what we thought is just stabilizing this should heal the cyst. Okay, but we were mistaken, it did not, and in fact there was AVN. Okay, you can see there was avascular necrosis of the head, and one of the screws then started hitting the acetabulum and irritating, so I had to remove it. So when we removed it, I put a fibula, and now I treated with a valgus osteotomy. So screw, fibula and plate with a valgus osteotomy, and then over a period of time the neck femur healed, and the AVN is also revascularizing nicely. Some small areas are remaining which slowly are getting consolidated, and he has got good range of motion. So that is at final follow-up. So he's done well after that. But A neck femur large cyst, no, don't assume it will heal, and it may need more than one operation, and bone grafting may be very much mandatory. So this is one area where bone graft is needed, okay, and a particle graft. So neck area needs reconstruction. You put a guide wire, 2 guide wires, then you use the DHS, mini DHS reamer, curate out the cyst, you put a fibula, and then you put the locking plate to stabilize, and this is how we treat it nowadays. Humerus is another common area where you get this cyst, and typically you put couple of nails from the lateral cortex, lateral column, and they heal very well with minimal scars, and they do very well with hardly any kind of morbidity. This is a long follow-up of another cyst which was treated with nails, and you can see that as the child has grown, the nails seem to have migrated lower, and we keep the nails unless they are bothering, we don't remove them. This is an example where there was a large cyst. Again, you can see 80% of the cyst has healed. Small lytic areas are there which we are just observing, nothing is being done. But as I said, as you get older and you see longer follow-ups, you see your recurrences. So this does happen. You have this cyst, you put a nail, you are very happy that this is a very small procedure, but after some time the cyst enlarges. So biologically the cyst is still active. Your nail is just preventing a fracture, but the cyst has not healed. So some investigations done, and then to heal the cyst we use the calcium sulfate pellets and use a thicker nail and revise that nail. Pathological fracture femur, sometimes you will get a cyst with a supracondylar spiral fracture like this, and this we have used antegrade elastic nailing, and you can see that over a period of time the cyst as well as the fracture both have healed nicely. So to summarize, is this a new concept? It's not really my invention or anybody's invention. This has been described long ago. Okay, 1968 Imhauser wrote about elastic nailing. Cartier and Santori have also written in 81 and 88. Recent papers by Saraf and Linhart from Germany, 94% good response to flexible nailing. In JBJS American, complete healing with minor loosened areas in about 3 years time. So long-term follow-up, again this is Andershew's series. So what does this rod do? Actually, when you break all the septae, you are decompressing the cyst, you are breaking the fibrous septae, you are maintaining a continuous vascular channel to allow bone marrow to flow into that area, support the cyst mechanically while it is healing following its natural course, and you are aligning a fracture. So it's a minimally invasive technique which gives you the benefits of all these combined techniques. So it's a good first modality of treatment, it's very cost effective, and it doesn't have a very big learning curve because all of you do elastic nails. Thank you very much.
Thank you, sir, for being with us.
The ending words are just thank you very much, and thank you very much.
Arterial repair. How many of you have seen arterial repair being done? 1, 2, 3, 4. Okay, so let us start. And yes, Kausar, how long did you follow up that child? A child with a vascular repair which you said you have seen, how long have you followed up?
I have followed up like 8 weeks only.
8 weeks only, okay. So let's see what can happen. So I failed and I learned. I had some twist, I saw it failed and I learned that, so this 6-year male came to me with stiffness of elbow and not able to extend the fingers. Okay, what is this known as? But what is this sign known as? Yes, this is a workman sign. That means, what does that mean? So that means that there is a contracture of volar compartment because of the fibrosis secondary to, and this was his elbow function. The story started that 5-year-old male with a
had a fell from height, had a supracondylar fracture, had close reduction and K wiring, and from a center which is about 120 kilometers from my city, that patient was transferred to Ahmedabad for vascular repair after Doppler examination. So I don't know whether it was pink pulseless hand or an absent pulse, but the interval between injury and the surgery was 24 hours. Okay, I think this is a small video which showed that there was a vascular repair, how the vascular repair was done. After the vascular repair, child was sent back to an orthopedic surgeon and he missed the compartment syndrome. And due to that compartment syndrome, that child is the one which you saw. There was some mild issues with the distal humerus articular surface. There were some issues with finger flexion extension, and there were some issues with finger flexion and extension as well. So after that, I have learned that just by doing vascular repair is not the end. There is something called a reperfusion injury as well. So when there is a child with a pink pulseless hand, and in the gathering of more than 150 people, only 3 people have witnessed vascular repair. So how should we make a decision making? And what are the current views regarding decision making, and how people agree with each other is something which I want to share with one of my cases which happened very recently. In December 22, I got a patient who presented to me 10 hours after injury with a back slab given at the referral center. Clinically, he had absent radial pulse. There was a mild delay in a capillary refill, and all the nerves were normal. Okay, you can see all nerves are normal, and if you see, it will be a little difficult, but if you see the capillary circulation is refill is slightly delayed, and there is no problem with the warmth. So what do you do first? What is the first investigation you do? Pulses are absent. Capillary delay, there is a mild delay in capillary refill. What is the next investigation you do? Sorry? So plaster is loose, sir. If you can see, there is a back slab only, and back slab is absolutely loose, and it is only in 45 degree of, and child was shifted with a knowledge that this child has a pink pulseless hand. By that time he came to me, even the capillary circulation became sluggish. So what is the second investigation? Would you like to document something before you take the child in the anesthesia? Color Doppler. How many of you have access to color Doppler at 10 o'clock at night? Sorry? I think we should talk about things which are handy to us. Even at 10 o'clock in my city, with about 60 or plus radiologists doing vascular Doppler, I will not get it. Right? So whenever you apply a pulse oximeter, after a few seconds, there is no pulse. Signal drops to 77, then signal becomes absent. So after that, what do you do now? You want to do any more investigation, or you want to just take the child for close reduction and pinning? Okay. What would you keep any vascular surgeon standby? Anybody from Chittagong here? Yeah. How many vascular surgeons do you have in Chittagong? 4. Okay. And how many of them are ready to come at 10 o'clock at night to help you? Okay. So one more investigation which I learned from my initial mistakes is do a Doppler. So this is a handheld Doppler. Unfortunately, I don't think we'll get a sound, but there's no need. There was no sound. There was no signal on the Doppler thing. Right? So what we, as sir said, you remove the plaster, and I did again Doppler assessment. Right? So on the Doppler assessment, I did not find any pulse. except here in this region. If sound was there, you would have appreciated this more. Again, after extension, we applied pulse oximeter there, and you can see there is no reading in any of the fingers of that side. That means this is not an absolutely pink pulseless hand. In pink pulseless hand, you should have near normal. So as sir said, what you do is first close reduction and pinning. This was the close reduction, and this was the pinning. Acceptable, Kausa?
Quality improved?
No, is the reduction acceptable?
There is some translation, but I will still accept it.
So do you think arteries in between?
That's what I asked, whether the perfusion improved or not.
No, that I'll tell you again, because that you will not immediately realize, right?
Right.
Do you think artery can get caught up in this type of reduction?
Yes.
Where is the gap? There will be some gap, there will be some bushiness. Less likely. If you do not get good reduction, that means there is something which is happening. I think except somewhat little bit of transmission, which was actually a fragment. Actually, that fragment was slightly broken from there. Anyway, there was an easy reduction. When immediate post-op, when I applied, there was marginal improvement. Okay, but then again it will disappear. So now what to do? No improvement. No sir, compartment syndrome will take a while to come because there is no circulation here, and this is just about 6-7 hours post injury. Right, so it is picking up some signals, it is losing the signals. We waited for 10 minutes, and before shifting, this is the situation. But pulse is not there. So shifted the patient, informed a vascular surgeon who was standby that this is the situation. He said that we'll wait for a while and see. So next morning again I did a Doppler, but there was no signal. And then I did one mistake, that I posted this case on Pedipod group in India. Okay, so I put this thing, and the first reply came was, waveform present on pulse oximeter, what is the saturation? Is the hand perfused or not? Pulse is not so important. Have to watch for compartment syndrome. Doppler may slow arterial injury, but if collaterals are good and hand is perfused, no indication to explore. So this is a proximally lateral. If reduction is good with milking mid, whatever, that is not important. And suddenly I get an advice as an article that you go read this article and treat accordingly. So I gave answer that everything is okay, but occasionally saturation drops. And the second answer is, for me this is an indication of Doppler ultrasound study or a CT angio to document collateral circulation and reperfusion. And pinkish, sluggish, improved is not a subjective. Then the second answer is, if the nerves are okay, you just observe. So nobody is giving you proper answer. This is a group of pediatric orthopedic surgeons of India. The second answer is, spasm of the vessel is not uncommon. Study can potentially lead to over-exploration. If hand is well perfused with no disappropriate pain or no neurological deficit, I would do nothing. Then somebody says, I have a paper of disappearing pulse at the next meeting, and let us see what happens. And he feels that he has reviewed the literature, and American Academy of Orthopedic Surgeons guidelines are not very conclusive for a given case. It's a very general guideline, but for a given case you won't be able to make a decision as far as I know. So there is an article by Dr. Sabarwal that is being posted, then there is a pro forma which is being posted, and then somebody tells me that I would like to keep the child well hydrated and see, and if there is a lack of perfect correlation, I will do something else. So I had a discussion with vascular surgeon, he advised me to wait, so I waited. Meanwhile, I got an answer from one of the overseas friends that it's not uncommon to have an absent Doppler with a well perfused hand. The collaterals may be sufficient to perfuse. The hand does not imply that the perfusion to the deep compartment is normal. And if the deep compartment is normal, there can be missed compartment syndrome as we saw in the previous case. And the threshold to intervene should be low. Do you have post-op X-rays? Long-term follow-up of these patients have shown avascular changes in distal humerus, some changes in the sensation and pulsation in few. So outcome is based on viability of angiosome distribution. That means if you do not treat, both have some long-term problems. One's artery is injured. Then he again says that I've seen one patient recently, Doppler was absent, hand was well perfused and warm, the nerves were intact. We did a CT angio that showed an occlusion, so vascular surgeon got involved and they decided to explore. Just mark this word, when you involve vascular surgeon, majority of the times the child will end up in exploration. So another Indian colleague told me that saw one recently the same, except this time the vascular surgeon told that we can observe. The child did absolutely well with no significant issues with neurovascular texture. So there are a lot of confusion in the field, and I completely agree that there are a lot of confusion in the field. So somebody advised you should follow up. A vascular surgeon, another person said a vascular surgeon involved will always advise intervention. There are a lot of grey areas. They advise for every absent pulse is repair. So I said my vascular surgeon is advised to wait. Anatomical reduction was achieved, and long-term results of vascular repair are also not really very good, if you know. Then somebody asked, what are the clinical settings? Does the child have well perfused hand with no nerve involvement or no signs of compartment syndrome? In that case, a handheld Doppler finding may be disregarded, but if you are doubtful about vascularity, then further investigations are warranted. So I said vascular surgeon is coming. The function is normal. Child is absolutely painless, is not taking analgesic, there is a full movement, and I posted a video. So another orthopedic surgeon came out and told, okay, one of my vascular surgeon told the patient that the pulse is absent as my K-wire is going through the artery. And I had fixed the fracture with a 2 lateral K-wire. That surgeon is in our institute, but that's different. But rarely we see a vascular surgeon suggesting to wait and watch. They want CT angiogram for every case and intervention all the time. And this is the reference of my vascular surgeon. Advise conservative treatment, tablet called Sprin, and follow up after 7 days. And somebody again had another opinion, it's harmful to open elbow anteriorly due to and to do open reduction in such case. I recently did one case, pink pulseless hand, and a brachial artery was trapped between fracture fragment, careful separation under vision outcome, and I posted the X-ray, and I said that vessels is less likely to be there. I posted the pulse ox picture, I posted function. By doing, and it was Taral who said that by doing all this you are only causing tachycardia, leave the child alone. No, that was Sandeep. I think these comments come from Sandeep only. So I said vascular surgeon advised no intervention, my tachycardia subsided. Again the Sandeep wrote, bahut pyara na lagta hai. And then one more orthopedic surgeons from US came forward with his own experience. Sorry for the delay entry into pulseless supracondylar fracture discussion. I did about 50 supracondylar fractures per year over a decade in particular city. I have a very low threshold to open anteriorly. If good reduction does not come within 2 good attempts or in 5 minutes or any concern for any tissue entrapment, I open. Quick minimal blood loss, no tourniquet, less radiation, single sub-Q stitch to close. Pink pulseless hand required only an extra day of observation in my hospital. I don't do Doppler post-op. I use Dopplers intra-op. If they did not open because I got perfect close reduction with no chance of tethering of the vessel or nerve, they don't need to be entrapped in the fracture but can get tethered by other tissues that stays at the fracture site. Any fracture gap with any neurovascular concern gets open reduction. I am not aware of any damage I have caused by opening. Even the scar is barely noticeable in the cubitus ossa. We get vascular consult only in open vessel restoration or in an ischemic hand. So you can see that different parts of the world there are different opinions, there is no conclusion. This child had no problem. So after 4 days the child was discharged. He came back for follow-up at 1 week where there was no pulse palpable, normal function, but there was a good signal on handheld Doppler. and then he is staying far off, so he was not very keen on coming back. But then after about 2 months, he sent me a video with a reasonably good recovering function. This is about 1 month down the line. This is how he has improved, and there is no neurological deficit. So trying to say is that I have seen one vascular repair failing, so I am not always jumping to do a vascular surgery, because vascular surgery in a 6-year-old, not a lot of people are confident of that repair sustaining it. You may get the pulse back, but then the pulse may become absent also. That also I have seen. I am not saying that vascular surgery should not be involved if you are not comfortable, but if the function is normal, hand is warm, you are getting good pulse oximetry data, the second thing you should document is handheld Doppler. That instrument in India costs about 15,000. I would urge at least institutional level and people who are going good private practice and a children's practice to just invest that minuscule amount in, and that will add a lot of sanity to your practice. So with that, I will just show you what I did for the first case. The femoral movements were restricted, and this is what was the surgery done. Neurolysis of the median nerve. I am lengthening of the muscles and plaster stretching of the elbow, and this is the function at 6 months, and this is now negative Bachmann sign. So I would like to conclude that what is said in this recommendation of International Journal of Pediatric Orthopedics is very sane. Supracondylar fracture presenting without pulse, emergency close reduction and stabilization, as sir already mentioned. Return of the pulse, yes. Routine post-operative care, but I would like to keep that child day or at least day longer in my setup. If pulse does not appear, if it is a pink and perfused, if it is pale and perfused, immediate arterial exploration. I don't think we need to do either vascular Doppler or we need to do CT angiography, because in supracondylar fracture the site of the injury is always there, and when you are doing vascular repair you will have to trace that vessel proximally till the healthy end, distally and proximally. So wasting your money, resources and time for CT angio is just not. CT angio is done in cold cases, in when there is a thrombus, to find out where the thrombus is. Here we know where is the site of injury. So in my opinion CT angio has no role. If the hand remains pink and perfused, positive radial artery Doppler signal, good pulse oximetry, no median nerve injury, in that case patient is just observation. Absent radial nerve on Doppler signal, poor pulse oximetry and medial artery injury is an again indication of exploration. This is, you don't need to take the picture of this, it is easily available on net. I think with this two different scenarios I am trying to tell you that every individual case is a different, and by the general guideline you will not be able to arrive at proper decision, and where you work will matter a lot in such tricky cases. Thank you.
Listen to your fellow pediatric orthopedic surgeons. And one more thing I want to say is, again, don't blindly follow the methods others are doing. And this is what I want to convey through this case. Of course, I just want to narrate what's written here. This is something which has really I have followed throughout the life. And in Hindi it says, नामुमकिन है उस शख्स को गिराना जिसने चलना ही ठोकरों से सीखा हो. So one who has learned walking by falling, it's very difficult to make that guy to fall again, because he's learned through falling again and again. So every time he's fallen, he's gotten up because he's learning through his mistakes. And this is what this session is for. Everyone should learn through others' mistakes so that you don't commit those mistakes. So this is a 13-year-old child, tennis player, and he fell while playing basketball. Okay, and you can see on this is the first X-ray, and this first X-ray you see that the elbow is dislocated. This was at Delhi, this was not in Bombay, and this was reduced well, and you know that there is a fracture of the radial neck with an elbow dislocation. So he was put in a slab, and then this patient came to Bombay. In Bombay, his CT scan was done to note the condition of the radial head. So 14-year-old child, IFICS almost fusing now. So Premal, I want to ask you, 14-year-old child, this amount of angulation of radial neck, right-handed, playing tennis at national level, would you accept this reduction or would you correct this, and how would you do it? I'm asking people from Ahmedabad specifically.
I think it may be a bad idea to calculate angulation on CT scanning, because that is not how it has been described to take decisions on. So if the best idea will be to examine the child under IITV, if it's not very painful, and check it which is the highest level at rotation in which there is an angulation, and then you can measure. But 14 years with this fusion, and if this is there, I don't think I'll do anything. If I get this position, I don't think I'll do anything.
I think this is an osteochondral fracture of the radial head anterior part. And these kids sometimes know that head. If
no osteochondral fracture on CT scan.
So what was the injury?
Elbow dislocation.
Which was reduced.
Elbow dislocation with fracture neck of the radius, which was reduced, and it's incompletely reduced. You can see on this view, specifically here.
Okay. Show that CT, earlier CT. Can I see the earlier CT?
3D CT?
Yeah, no, this one. This is pre-reduction or post?
No, this was, so he was put in a slab, reduced, put in a slab, one minute. While doing CT scan, they removed the slab. So in the CT scan, it is
dislocated.
It is unstable, dislocated.
So now what is the situation?
So now the situation is.
So you showed some X-ray and asked.
Yeah. So we took him on table, and now this is the situation on table.
Okay.
On table, after reducing it well.
Did you get an arthrogram?
No, because this is almost fused now. This is 15-year-old child, and that there are no growing physis. Yeah.
Radial head, I would accept. If there is good stability, just a slab in flexion more than 90.
So this child, range of movement was full supination and mid-prone. We were not getting pronation.
Not getting pronation.
Under anesthesia, not getting pronation. It was getting blocked. From the audience, anyone wants to guide me, what should I do for this child? Should I accept, how many of you would accept this? In a 15-year-old child, it's not going to remodel itself. And there is restriction of pronation. How many of you would do something,
Under anesthesia, passive pronation you should get. If it is not coming, there is some problem.
See this. Pronation, this is all I am having.
When you rotated it, you saw on CM if the head is moving, or only shaft?
No, it was impacted in that position. No movement. It is mal.
So it's mal rotated.
Yeah.
And stable in mal rotation.
Yes.
You'll have to undo it.
How?
You can put a joystick, disimpact that area and supine it.
No, this is in flexion, sir. This is in almost 40-degree flexion. So we tried in various positions. We flexed the elbow, and then I'm just showing that this was happening. So then what we did is there is a published method where you give varus stress and then flex the elbow and pronate. And my partner that time said, let us try that method. And we tried that method, and suddenly there was a snap. And after the snap, this was the X-ray. So we did hypopronate, and in that process of pronating, this is what happened. Now what is the mistake I have done, and what should I do now?
Mistake is you listen to your partner. You should. The answer to that is you have to say who is senior.
No, but this patient had to be given pronation. And we tried a closed method, which is described.
Now the answer is you made it easier from making a decision. You have to operate now.
So can we get this closed, or I should open?
Whatever way you can.
Okay. So I'll show quickly. We tried all the methods to get it closed. Chopstick method, wire method, everything. It didn't come. We tried everything, milking, and then finally we passed a wire, K-wire through the radius, got it at the line of the neck. This is the best close reduction I could get. At that point, I opened up Okay, and you can see that this is a lateral approach going anterolaterally. You can see the radial head which is anterior. It was flipped over completely. So got it in position very gently. It was completely separate without any soft tissues. And got it in position. The best position I could, IM wire, some additional wires because there was no rotational stability, just with a Metasio's wire. And then checked on table, this looked good. I knew that this is completely avascular head, but this is how it was 1 month post-op, and this is when we removed the wire. And luckily now he has full range of movements. You know, things seem to be healing well. There is some anterior new bone formation, but it may be because of the initial injury. And in terms of pronosupination, he has full supination. We are still stuck where we started from, at mid-prone position. Okay, so there are times in life where, you know, the nature has decided something else for you. There are people who get away from a difficult situation and they are flying their kites high, and then there are people who are, you know, cursing their destiny as to, you know, why this happened to me. But it's important in difficult situations to keep your mind cool and come out from it, which is what I learned through this case. So, pardon, sir? No, why not, sir? It's a group. You know, we learn, we listen to each other. That's how we learn. There are sometimes people give advice and it works well, and sometimes it doesn't work well, and then I know what not to do next time. That's all. All right. So it's good to give advice. Let them fail, then you learn from their mistakes, so that you are not the culprit any longer. And it's like watching a horror movie. I just some time ago spoke to you about bone cysts, and this was a child which came to me long ago. Again, early in my practice, fracture neck femur through a bone cyst somewhere in the interiors of Maharashtra. He was operated, and that surgeon had done this fixation. Premal bhai, Saruche. He did stabilization, curettage, bone grafting, and did not cross the IFICS. Yeah, so bone cysts we just spoke about how they behave, what the biology is, and in all fairness, an adult orthopedic surgeon did what he thought was right, and that was conventional treatment. Open reduction, curettage, stabilization. Now this child in 3 months' time was in this situation. Now what? Yeah? So you have a slip. Okay, Premal bhai. You are the culprit now. Taral is in the phone.
I think this is very much possible. And now
Yeah. So now there is avian and a SCFE in addition to that bone cyst, which is not yet healed. So, एक complication पे एक free. Okay, so that is the situation, and then add infection to that. He came with a discharging sinus. So this is by far the most complicated case that came to me as a hip case. A bone cyst, operated, treated with an implant, with a slip, with infection, with loosening of implant, with discharging sinus, and really this was a bad situation. So what did I do? What I did was, first I removed that hardware from there, but I had to stabilize the slip. I couldn't let that slip progress. So I reduced that slip gently, whatever was possible, without opening it, and then I put a titanium screw. Okay, that time titanium is supposed to fight infection. In cases of infection, you don't put stainless steel, you put titanium. Okay, so we put titanium. Then we packed it with antibiotic impregnated bone substitute. Okay, and that discharge around that plate was sent for culture. That grew Staph aureus. So we gave him antibiotics. He was okay transiently, somewhat better, and we gave him a Thomas's splint. The minute I removed the Thomas's splint,
he had severe pain. He was not comfortable at all. This was his X-ray. So anything happening here, Premal Bhai or Taral?
You continue.
I'll continue. So what happened was, I saw the X-ray again critically. If you see, the medial joint space has increased. Okay, and I realized that this hip is subluxated. Yeah.
So infection.
Yeah. So what we did was, we drained from the tract of the implant, but there was septic arthritis proper intracapsular, which I had totally missed. And that prompted me to go back in, and then I had to go and do a medial approach. There was a significant pus collection. From the medial side we drained that pus. Then the hip came back to the socket and we immobilized him and continued with antibiotics with a now a molded abduction brace. And that abduction brace, we held on to it for at least 3 months. And over a period of time, after a long struggle, about 4.5 months, this is how he progressed. And he had some knee range of motion, but he was stiff. He was stiff in the knee because long time had gone, and so because of not being mobilized, he had stiffness in the knee. So in all my smartness, I decided I will do manipulation under GA, which I think all of us want to do when there is stiffness, and I created a supracondylar fracture. Okay, so from frying pan into fire, back into frying pan, back into fire. So because of so much long-standing disuse, the bones had become osteopenic. So please remember, a stiff knee in a long immobilized child, please don't manipulate the knee, because what happens is either a transfascial separation or a supracondylar fracture. Okay, manipulation of the knee in children is a very bad idea, especially long-term disuse. Okay, you will create more complications. So this is what happened. One things that went wrong, and after 1 year of long struggle, this child started walking finally. Somehow he was walking, and it was a fairly educated family, and he had active SLR, he could do SLR, and we just continued to observe him, and we took an X-ray. You see the head and neck has got resorbed, which was going to happen, the sequelae of AVN plus infection. So ultimately this worked like a girdle stone for him, and recently he passed his 12th standard, so he came and gave sweets. So somehow all these badly done cases, they are grateful whatever the outcome, and they still came and offered sweets because he passed. So I said, video leta hai, long term follow-up. Okay, so he is functioning decently well. We took an X-ray. He's got painless range of motion, he's got good ability to walk, and he may need THR somewhere in the future, but as of now, today, he's doing pretty okay. So you make all attempts to try to save the head, but sometimes the disease is so bad that with so many complications, it would have been a real miracle to save the head. Okay, infection, slip, cysts, and other things. And what we learn from this again is that I taught you earlier, that a simple thing like a benign cyst, which can be treated by aspiration and steroid injection or a closed nailing, does not need to be opened, grafted, curated, and major surgery with major morbidity is not really required. The primary first line of treatment can be just a simple elastic nail. If it increases in size or if it doesn't heal, you can add bone grafts. But very aggressive approach is not required for something as benign as a bone cyst which heals. Thank you. Thank you very much. So that was the first personal anecdote. The second thing which I, made a mistake, or I failed and I learned was in a case of a missed Montegia. So this was a young boy who had a missed Montegia with a radial head which was dislocated and flexion block and pain, and you saw yesterday's presentation. We do the osteotomy, we bring the head down. So typically, Taral, what happened was that we had recently got a very good and very popular anesthetist, and they were very keen on doing pediatric regional anesthesia. So this child, this is when Bansi was my resident.
And this young boy, 7 years old, lateral position, we did the head reduction, we did the osteotomy, surgery over in 30 minutes. We gave a cast. I give cast for all my patients, nothing unusual with that. And they gave a supraclavicular block for pain relief, which she wanted to do in children. And that night, that child had immense swelling in the hand and no pain. And nobody saw him. And my fellow didn't see him, my residents didn't see him. Next day morning, his hand was swollen, and we cut the plaster, and he ended up with bad compartment syndrome, the entire volar compartment necrosed, and we had to do a fasciotomy, then plastic surgery, skin grafting. After 3 months, we had to do muscle slide, then muscle transfers, neurolysis, and his hand is now reasonably functional, not normal. The growth is stunted, and after 2.5 years, and you know, typically Taral, this was in Pune. There is an area called Tadiwala Road. In that area, there is a little slum area and really poor people, but they have this. So every time that child used to come, there used to be 25 people with him. So it was not a direct failure of me, but as head of unit, it was my responsibility. My fellow should have seen, the block shouldn't have been given. Whenever there is a block given, you take away pain. You don't want pain to go away because it is your friend. I would rather have a patient waking up with pain, give analgesic and becoming pain-free by evening so he sleeps well. You give a block, you take away all the warning signs of a tight plaster or a compartment syndrome. And he developed that, and that is a lesson that I learned, which I will never forget, because 3 years down the line, every time you came to OPD, it felt like they are going to attack you. And what I learned from that is that you have to be patient and you have to accept the mistake. If you had tried to bhagav him and say, कुछ नहीं हो गया, तुम्हारा गलती है, मेरे resident का गलती है, मेरा fellow का गलती है, that wouldn't have worked. So I had to own up that there was a mistake, there is a complication. We will try to fix it to the best of our ability. Be patient. And they were very, very cooperative till 2-3 years, till all reconstruction was over. Once reconstruction was over, we said now no more surgery is required. We removed the implant. The montage I did fantastically well. Full range of motion, full elbow motion, wrist and hand screwed up. With a little contracture, few fingers not opening, but grip was good. He is functioning okay. But bad scar, then they wanted cosmesis, then uska future ka kya hoga? So ultimately they came with a lawyer. And they demanded money. So then the legal negotiations and then the hospital negotiations. Then every time the dialogue was, Dr. Patwardhan, you have been God, but my child is suffering. What do I do? You must compensate, and which is genuine. So ultimately we had to compensate him, and we paid up a large amount of money so that we got out of it. But the lesson where I failed was that I left it to the anesthetist to make that decision. Today, proactively, I will go and tell my anesthetist, upper limb surgery in a child, no block. Under no circumstances. तुम्हारा कुछ भी specialization हो. Second, whenever I give a plaster, evening round, I will take and inquire. उंगली हिल रहा है कि नहीं, pain है कि नहीं. Don't leave it to your fellow, however senior you are. Because the litigation will be on you. That fellow has gone away, he is practicing in Goa, enjoying, no problem. But as your chief and as head of department, and I must appreciate my boss Parag, every time he supported and protected the consultant, the hospital, and we made the payments and we settled the case. But these things happen if you don't pay attention, and it is very important to learn how to talk to people, how to admit your mistake, how to come out of it and face litigation. Because this is going to happen with you. So I just thought I should share this with you.
And then to patients and to your colleagues, it requires great amount of courage because this is a learning point for all of us. So 2 things again what we've learned from Sandeep is whenever you have a plaster in place, never have a block. You know, it's really not required, and we should not allow that to happen. And second is what we do nowadays is, of course, you will have good residents and fellows. But we make a WhatsApp group and we ask the patients to post the photographs of their hand or a small video of the finger moving so that we are sure that things are in place. And finally, its onus is ours. As you cannot shirk responsibility. Secondly, a child is unnecessarily crying. A crying and irritable and uncomfortable child is the first sign of something going wrong. Don't say ये ऐसा ही है, ये पागल है, ये चिल्लाते रहता है, कुछ नहीं होता है, एक झापड़ लगाएगा. No, don't call him psycho, don't call the mother psycho till you have ruled out each and every known complication. Nerve injury, vascular injury, compartment syndrome. And doesn't matter if you lose reduction, slit that plaster. It's better to be careful than sorry later. I just want to give plaster is fine. Would you slit the plaster now? Give a plaster to be sure that everything is okay. Just slitting the plaster. You have to cut the cotton also. To remove everything. It's not only the plaster. So asking whether you slit only the plaster. So because the plaster is the tough part. I am saying as a prophylactically you can slit the plaster. You don't have to go till the cotton. You will go till the cotton if there is swelling. No. So certain cases where you anticipate swelling, you do the casting that I need to allow. With the soft cast, I don't have to do it. It allows some expansion. Right. And lastly, if there is tightness or irritability and analgesia is increasing, anxiety, 3 A's are there. Everything including cotton has to be cut.
So now I would like to request all three of you to take a seat. Yes, for discussion. It's our case and their advice and what we have done. So all those who have submitted some cases here, like Dr. Shubha Prasad, Dr. Taposh, Dr. Ashfaq, and all others, please come forward so that I don't need to call each and every one of you separately, and you can easily come here and present your case. The first case is from Dr. Biplab Mazumdar. He is working as registered Dito.
Range of motion of the knee is normal, squatting full, gait also normal. This is the X-ray of the patient. In the right leg shows there is an outward emission of the tibia and left leg is normal. The angle in proximal tibial metaphyseal angle is 114 degree. It is the normal angle is 87 to 88 degree.
So anybody from audience, what is the cause of this post-traumatic valgus deformity?
So what is the diagnosis?
Yeah.
আপনারা কেউ একজন মাইক নিয়ে চলে আসেন, নইলে ওনারা হ্যান্ড পিক করলে তো।
Probably this was a incomplete fracture, a realistic type of fracture, which involved only the medial cortex and lateral cortex was intact. It's a causal phenomenon probably, and that gave rise to the excessive growth on the medial side, and that leads to the valgus of the knee.
So this is not malunion. It is a growth
disturbance. Yes.
And what will you do for this? What is the plan?
It's Cogen phenomenon. Proximal tibial metaphyseal fracture have tendency to develop late valgus deformity. There is a 50 to 90% chance of valgus deformity occur in this type of fracture. It is usually incomplete fracture. Sometimes we see this deformity also in complete fracture. The common age is 3 to 6 years of age. Etiology usually unknown, but there are some hypotheses. That is lateral tethering of iliotibial band, weight bearing prior to consolidation, interposition of soft tissue in flexor site, and another one is fascial injury in the lateral side. The actual mechanism is it is low energy valgus force, which usually occur in incomplete fracture and sometimes also seen in complete fracture. Now we can diagnose it by seeing X-ray. The treatment is usually it will resolve spontaneously. If it is not resolved spontaneously, the valgus angle is more than 15 to 20 degree, need to do surgery, either temporary hemiepiphysodesis or medial closure osteotomy.
What did you do in this patient? What have you done in this child?
Sir, we have done temporary hemiepiphysodesis, but I lost my follow-up.
Okay. Please keep a follow-up, because otherwise there will be rebound deformity. And so on day one, this plaster was done under anesthesia or without anesthesia?
Sir, on day one we have done plaster under anesthesia and we give varus molding also.
No,
This is the X-ray of my
I'm
patient.
asking you post-reduction X-ray.
So patient comes after 6 months.
So you are not treated it? No. Where's the injury film? You said you give a virus molding plaster, but you have not treated this patient only.
Sir, patient actually usually comes 6 months after 6 months after injury.
But you don't have
Initial
injury,
treatment,
you don't
initial
have injury films. Do you
No,
have?
sir, no, sir, no, sir.
Okay.
Patient usually take treatment from another orthopedic surgeon. Patient comes after 6 months of injury.
Yeah, so just put up that case, the first case. So how, it's not 100% that you can prevent, but there is one way of, at least you can try. And the most important thing is, whenever you have a patient like this, you should inform the parents to begin with. Otherwise, you will not be the second treating person, someone else will treat it. Usually your complications rarely come back to you.
Like X-ray is this one?
No, cases. It's in your pen drive.
Yeah. Got it.
It's named as cases.
This is?
Cases, yes. Yeah. So this was a girl, same age group, and pre-operative. This is an injury. So you can see there's a fibular neck fracture also.
Hello, sir. I have a question. So in case of Cogen phenomenon, we have to wait for spontaneous resolution.
Yes, sir. Yes.
So how many times I have to wait for this?
Minimum 2 years.
Minimum 2 years. Thank you, sir.
2 years. Next. So you have to give a plaster in such a sense that medially there is some opening. You see that varus molding there? My wrist is in the fracture side while applying a plaster, and you see a varus molding. And look at this healing. Still that I've explained to the parents that this will still can go for Cogen phenomenon. Next. That's 1 year follow-up. Next. That's 2 year follow-up. And I know this girl, happens to be my friend's daughter. She is 8 years from the injury and she has no problem. So this is one thing you can try. So I gave this child anesthesia to give varus molding. One of the pedipod group, you said that you don't take advice from your colleagues. So I had posted this case and somebody had come out with a brilliant idea that, sir, why not give this child a plaster on an OPD base and then do a wedging. That will save an anesthesia. So that's a brilliant idea. I think next time I get this acutely, that is something which is worth trying. Saving an anesthesia is after 3-4 days if you wait, pain ज़्यादा नहीं होता है. नहीं, we are doing wedging so often without it. Next thing.
Thank you.
Thank you, sir.
Dr. Viplav. So the next case is from Dr. Shubha Prasad.
Assalamu alaikum. Welcome to this discussion program. I am Dr. Muhammad Ghulam Farhad, presenting my case. A 9-year-old girl presented with pain and swelling and deformity in right thigh following trauma. Difficulty in walking since trauma. This is her X-ray. what should be our management plan?
Can I ask you one more thing?
Yes.
Are you happy with your investigation, pre-operative investigation?
No, sir. I have to a complete X-ray, including the neck, femur, and hip and knee.
Sometimes even after, if you have ordered like X-ray, right thigh, APN lateral view with hip and knee joints, অনেক সময় child অনেক লম্বা থাকে, they don't get those two joints in one slide because the highest number of slide is 14-17. If the child is above that 17-inch thigh with 17-inch thigh, then they can't get two joints in one plate.
Ravi, you can always take 2 X-rays. There's no problem. You don't have to fit the child to the plate. You can move the plate up and down and take 2 X-rays.
Agreed.
I think everyone of the in this session are agreed with me. We have to do close reduction by titanium elastic nail. Okay, we have done it.
Medial cortex continuity ছিল, কেউ কি অন্য কোনো কিছু প্র্যাকটিস করতে চান?
But purportedly we have noticed there is an incomplete fracture in the neck of the femur.
So you are happy with your nailing or you are not happy?
I think reduction is.
Did you realize this on a post-op X-ray or intraoperative?
Post-op X-ray.
Intraop also you didn't know neck femur is there.
Intraoperative we have no.
They realized that neck femur fracture is there, but as it was displaced and that tense nail
This is not
was not
displaced.
going through that sclerosed part. Yes, that's the old fracture rather than this one. To trauma.
Or this could be a metabolic problem, and that could be a pseudo fracture or a looser zone, not a true fracture. That is also possible. This child should be worked up for a metabolic problem. It could be vitamin D deficiency or some other form of metabolic issue. We had recently one such patient, and it turned out to be a renal osteodystrophy. A child had short stature and looser zone and a femur fracture with a trivial trauma.
As the primary X-ray was not noticing this. This was perioperative finding.
So at least now we'll keep the child non-weight bearing for some time.
Okay.
Yes, we
Till
have.
the time neck femur completely heals that. Would you fix this now at this stage? I think we can leave it since it's.
No, metabolic workup is necessary for healing. Since it's not displaced, you might choose to conserve it and keep non-weight bearing or give a spica or something. That is definitely, it will heal. My issue is that nail distally is on the facies. Both of the nails are on the facies. Right one is the lateral side is more. So don't assume that this will not cause a problem. It irritates the suprapatellar pouch. You will get effusions. You will get ligament irritation, and you will get valgus deformity because of growth inhibition. You have seen this happen quite often. Hope that you don't get growth arrest, permanent facial bar. I showed you yesterday that nails can cause that.
You used an implant, but you have chosen not to use the principal. Where is the separation here? The separation is at the distal end of your second circle, and your fracture is in the center of the circle. So the bending, that is what is the thing is. If you're using these nails as stacking nails, then use rush pin. Use stiffer nails. Use ender pin. You can use even thick K wires. But if you're using 10 nail, which is a costly thing, I'm sure it must be costly in Bangladesh also. But that means you are not matching the principle with the implant. Or either or implant with the principle. You have used a stacking nail technique for 10 nailing, and which is probably not done in a case which is probably well worked up. And you have missed a fracture. I think, as just Sandeep told, that good patients may remain good for a few years, and then somebody instigates them. I'm sure somebody would have instigated the patient which he talked about. चल तेरे को पैसा दिलाता हूँ. Then you had it.
in US, litigation works on percentage basis. They do your everything free, and whatever malpractice suit you get, you split it with your lawyer. And those days have come in India. I'm sure they will gradually cross the border.
At 6 weeks, there is a breathing callus in the fracture side, and after 6 months, there is callus, and already the neck fracture is already healed.
Again, are you happy with the bone density?
No, sir.
There seems to be a problem. Did you investigate for that or no? Not yet. Okay, what happened after 6 months? Hypertrophic non-Indian. Yeah? Yeah, and look at the distal femur, what is happening?
Everything is cool other than that hypertrophic non-Indian part.
Yeah. So again the thing, hypertrophic non-Indian means the ossification of callus is not happening. There is no mineralization. There is some problem with mineralization. Yeah, the implant must be poking and it's going into valgus. There is a flexion deformity in the knee because there is synovitis. How can I tell on X-ray flexion deformity? You can see it is overlapping. I can't see joint space. So this suggests that there is synovitis recurrent with a flexion deformity of at least 20 degrees. The nail is, as Taral said, anterior and irritating that synovial pouch. So, what next?
1 year and 6 months, and then 1 year and 10 months.
Have you got BN, creatinine and vitamin D done yet or no?
No, actually that was
Acha, so you have not yet treated him?
They were waiting 1.5 years just for IFICS to happen. Okay, and opinion to be given. So now we have given the opinion, things will be done. But it's a very good illustrated cases. And we have seen today that don't assume that the fracture is in a normal bone. It could be congenital pseudoarthrosis tibia, it could be OI, it could be osteomalacia, it could be a cyst. And you have to see the x-rays and examine the patient and make sure that you also look at the child as a whole, not just the initial x-ray.
So go to the cases. Yeah. Go to the cases. What you have done, you have.
No. What should we do?
Okay. So I'll show you a similar case and I'll show you what was done in that case.
Yeah.
In that cases only.
The last one.
Okay, so this is a long story. This is a long story. This is how a fracture happened, and this is how it was treated. Right? You look at the fracture. That fracture, does it look normal to you, Sandeep? Not. There is something happening which probably was missed.
Transverse subtrochanteric fracture is atypical.
Atypical, right? So this is how it was treated. Again, now there is a different principle. This is ender nail used as a elastic nail. He has used titanium nail as a ender nail. Okay. So this is how you can see now the eyes of the ender are there, and gradually child was not somehow walking well. So that orthopedic surgeon had this type of X-ray he had preserved, not given a single print. She fell again, and her gait deteriorated. And after that, the orthopedic surgeon, without investigating, did something. He removed the old implant, and he could now, because of some callus, he could negotiate only one ender nail. And then this time, then the parents got fed up, and this time he could not negotiate, so open nailing was done. This is the follow-up, and this is how that girl came to me. Not able to walk. You can see the genu valgum on left side. Please keep note of all these things, because if you do not examine the child wholly, you will never reach to the diagnosis. The cause of the non-union probably was open reduction or a metabolic, both could be there. Her movement was okay, and she had hypertrophic non-union. So, and when opened up, you can see there is amount of the callus. You can see that. So we just shaved the callus, collected it for bone grafting, and stabilized in situ with that nail with a simple plate. This is not a locking plate. Please note, this is not a locking plate. And in 2 months' time, that healed. Okay. Now look at her gait. I had never seen her walking because she was not walking. I was persistent regarding her. Her metabolic workup was absolutely normal, but she had excessive hyperligamentous laxity. So I could convince them, and she turned out to be Marfanoid syndrome. Right? So hypertrophic non-union, hyperligamentous laxity, abnormal gait. You have to be a little careful. So after that, I removed the plate and I did keep the nail. So any comments, Sandeep, on this? She has a nail all the way from up to down. Canal has formed.
This looks okay. Left side, I don't know.
So it looks okay, but then there's always a surprise.
So this is a different level.
Different level. But the pathology is not treatable.
Yeah.
I have no treatment for Marfan syndrome. Even if I kept this nail, she has problem. And then she was treated with trochanteric nailing, and she ultimately healed. And then she developed
scoliosis.
She was developing, and that became very aware. And she went to a junior spine surgeon. He was ready to operate. I said, you are planning for a disaster. She already has 4 or 5 surgeries from a simple trivial injury, and he had advised and given date also, but the child was so much confident in me. He said, if you say, we'll do the surgery. And now this is her, she's under continuous follow-up. She had psychiatric issues, she was on mood elevators, and this is how she walks now. Okay, so as already pointed out, when you see little bit abnormal, I think it's a good thing to investigate first, rather than keep on treating, waiting, and there's no end point here.
Thank you, sir.
Thank you.
Yeah. So if a bone is not behaving the way it should, look for neurofibromatosis, neuromuscular problems like spinal muscular atrophy or myopathy. Severe rickets can also cause myopathy. So vitamin D resistant or dependent rickets, renal osteodystrophy, primary or secondary hyperparathyroidism, all these things, metabolic bone diseases or neuromuscular diseases will not allow normal bone formation or consolidation.
Okay, now it's time for Dr. Mohammad Mahbubul Hossain for genu varum deformity following septic arthritis, septic knee. Yeah, Ashok bhai. I've just left it.
So what? So child is very small. There is no hurry to correct the virus at present. I think what I would do is just put a brace, observe the child, and there are many incidences in which the medial condyle reossifies. You have growth plate already there, and many times it overgrows and will correct. If it doesn't correct within a year's time, or if the deformity keeps on increasing, then you can put a 8 plate and try and correct it. And if that doesn't work, then you will do an osteotomy. Yeah, Premal, over to you.
Okay, so this girl presented with this type of deformity. Oh, sorry, I think there is some jumble in the. Some. No, just minimize this some jumble of the slides. I have not copied the slides for that.
So this is missing lateral physis, right?
Yeah, so this is a missing physis, and this is what was done MRI, and this had a multifocal septic. So one side it was a septic hip which led to this, and no treatment was done. There was no abscess, nothing. And here what we did was, we did a physial mapping, and we found out that there was a small bar. But infective bars are very difficult to manage. But you look at this, there is no, the lateral physis looks like missing, and as an oxymoron, the missing person has come back here in the MRI. And another advice to you, as Taral had already, Sandeep said, that you have to have a fat suppress image. If you want to know what is the happening between cartilage and bone, you need a fat suppress. See, if you see in this image, you can clearly find out where the bar is. Right? So we approached this by creating a metaphyseal window. So provisional K-wire was passed. Then we did a thing. Then we did a physiolysis. You can see that is a window, and you can see there is a. You can see the white rim there. That is the normal physis. You can see here. You can't see, and this is on the lateral side. That is on the medial side, and then you put a fat graft, and then you fix the metaphyseal window back. Okay, so that metaphyseal window is back, and that is the K-wire, and that will act as a marker. And I would just say that I was lucky in this case. Gradually she improved. This is her more recent follow-up, and now she is completely correct. And then after a little bit of over coverage, this is her gait, and this is after over coverage. I have removed the 8 plate. Now she is 2 years out of removal of 8 plate, and she started getting valgus again. So that follow-up is not there. I just did her hip surgery. That also is not done very well, and now she has started developing valgus again. So infection is not like traumatic. Things can come back. You have to follow up this type of change.
So in this patient, however, I would suggest you wait and see, and let us know what is happening to this child.
Thank you. Thank you, Dr. Mahbub. Dr. Shubho Prasad. So the next case is from Dr. Shubho Prasad Dash. He is currently working at Detour.
Good afternoon. So this case was presented to us at the last OPD. It was done by elsewhere. It came to us as a follow-up The history was 7 days old boy, motor vehicle accident, presented 7 days post injury and no other injuries. This is a frequent case scenario we got in our emergency or OPD. What should be the plan in such kind of length unstable fractures in the proximal femur of a 7-year-old children, and it presented 7 days post injury.
7 days post injury without cast? Or
Without cast. Without cast, attraction.
So what's the public opinion? 7-year-old child?
Yes, sir.
7-year-old.
7-year-old child and 7 day post injury.
7 day post injury.
On a surface traction, skin
Right.
traction.
So how many of you want to do? Yeah. So how many of you want to put this in plaster? Just raise your hands. Elastic nails. Elastic nails. Okay.
Is only elastic nail is sufficient?
Elastic nail and external fixator. Okay. No, then you have to raise 2 hands. One for elastic nail and one for external. So again I will say elastic nail and external fixator. Okay, raise 2 hands. Elastic nail and plating as Sheetal shown. Submuscular plating, anybody? Submuscular plating. So what is your choice? What is your choice? Nailing and external fixator. Is it going to be an easy nailing to negotiate, or it may be difficult? Okay. Some people would you treat 7-year-old.
So there is another way of doing this, because this is length unstable and delayed presentation, and a long segmental spiral. Okay, proximal fragment is lying in external rotation. So you need to put a shank spin and derotate it to get the rotational alignment right. Then because it's already started gumming up, if there is a length issue, you need to distract. So I think just an LRS is also a very good idea to do this case. Put 2 pins up there, derotate it, pull it out to length, and just wait. In 6 to 8 weeks there will be callus. Once you see callus, remove the fixator and convert to walking spica. Everything is closed and everything is biological.
I think I have to go with multiple choices, and you give anesthesia and you distract. What type of reduction you get, depending on that you can go ahead and do. I think if I can get hold of 2 nails with temporary external fixator, I think that will be my first choice. The second choice would be submuscular plating, and the last choice would be only external fixator. So I think a combinated intramedullary is one of the best tolerated implant. But of course, this is being a length unstable, you will have to have some additional form of fixation, even if you are using under nail or even if you are using 10 nail.
Thank you, sir. The patient came to us as a follow-up and this was done. Yes, sir. Any comment?
Are you satisfied with the fixation and fixation methods?
It's fair enough. It's a
No, it's a closed case. It was a closed case. Yes.
Open method is
done as an open method. If I said it was a closed case initially.
Okay, with the fixation. So open reduction, and then you put multiple lag screws and neutralize it with a plate. In an adult, this would be an appropriate treatment, but on adult, actually, this could also be treated with an interlocking nail.
Yes.
In child, I would treat this with multiple nails, and I think my first nail would be from proximal to distal, because if you look at the X-ray, I feel a nail going from top to bottom will be much easier in the straighter nail in this child rather than putting a nail from below up.
Yes.
And once I get one nail in position, then it will be easier to put one more nail from down to up, and I will neutralize it with an external fixator.
Yes. Thank you, sir.
This is a case where I feel that the treatment, though okay, is a little overkill. Number one. Biological methods, closed methods, I think are much simpler and offer less morbidity as compared to an extensile open, entire thigh is open for just a good looking X-ray. It satisfies the surgeon's ego. You should ask the patient how he feels after the whole thigh is open. And God forbid there is infection, then the whole thing just will get destroyed.
Sandeep, one thing, let me clear, he didn't do it. He just brought the X-ray. It was done somewhere else.
Yeah,
so we feel this has been a crime. What do you think? This has opening the whole thigh, putting a trochanter to condyle plate in a 7-year-old boy after 7 days. I feel it is a crime.
So it's a double crime, sir.
What do you say?
They have to open it again, remove all the screws and
exactly.
And most probably extensive opening will be needed because interfragmentary screws are there, which are actually...
Let them have the...
So this is not really
whether this was very much wrong.
No, we would never do this kind of a treatment for a 7-year-old child because there are better ways of doing it. So where there is no Siam, you put Thomas plate and spica. This as Teddy Longo says, this is open reduction and internal decoration.
Maybe the parents...
so that the surgeon's ego is satisfied that I gave perfect reduction. Not needed.
I think currently there is a... See, I think... I'm sure so many people who are on the other hall would have taken a selfie and posted to their friends that I have come to see Jawan. And that is what is happening in orthopedics also. There are only 2 X-rays I see in most of the WhatsApp group and Telegram group. Pre-operative and with metal. Pre-operative and metal. Rarely anybody puts what exactly happened after a few months. I think as Sandeep said, you should ask the parents what is the amount of scar. And is it out of, and I think if this X-ray was posted about 25-30 years ago in an AO meeting, they would have really clapped very well for this X-ray. Of course, that time this was probably an apt treatment, but with invent of, and I don't agree that one who has got a digital machine would not have an IIT or could not arrange. Yeah. But this can be, there are special situations where you can take the child to a center where there is Siam.
No, but I agree that there are situations. I gone to Kenya recently and we taught them how to do elastic for K-wire fixation for supracondylar fracture. And they said, sir, we cannot do this because we don't have Siam. And it's easier for us to do an open reduction of supracondylar fracture or treat them in a traction. A close reduction and pinning is not a solution because there is no image intensifier. So it is situational orthopedics, and let's see what happens to this patient.
Thank you, sir.
Thank you, Dr. Shubha Prasad, for bringing us this interesting case. Now it's time for Dr. Torikula Alom Noman.
This patient, she was 4 years of age, fall from chair, presented to a bone setter with pain and swelling at her left leg. Without any X-ray, she was diagnosed as a case of activia and was treated locally by some bamboo sticks and some herbal paste. And ultimately, 7 to 10 days later, she developed pain and swelling. After that, her parents removed the bamboo sticks and presented to a quack. That quack prescribed her some analgesics and painkillers. With this X-ray, after 1 month of the occurrence, she was presented to a Upajala Health Complex. This was her first X-ray. The attending medical officer prescribed her some antibiotics again and referred her to a medical college hospital or a district hospital. But her parents denied their suggestions and treated at home with some analgesics and antibiotics. After 2 months, she presented to a local orthopedic surgeon at Netrakona. That orthopedic surgeon at first decided to do the operation. She did sequestectomy, and after corticotomy, she applied Elizarov external fixator. After 7 days, that orthopedic surgeon of Netrakona district started distraction. This is the X-ray. This is the X-ray after 1 month of Elizarov application, and this is 2.5 months after Elizarov application. After that, she was not under the follow-up of that orthopedic surgeon. After 4 months, patient was presented to that orthopedic surgeon again with this scenario. This gap was not followed up properly not properly, and she failed to obey the advice of the orthopedic surgeons. That orthopedic surgeon then referred this case to Mymensingh Medical College Hospital. She presented 2 months later with these X-ray, that is 6 months after application of the Elizarov. This is uniting, but here there is a gap, and compression distraction was failed at that period. Dr. Ghulam Mustafa, can you explain why the failure has occurred here after 6 months of Elizarov application?
Thank you, Dr. Noman. Elizarov is not just a friend, it is a biology, and when you are wanting to fill up a gap, you should meticulous follow up and have to distraction, it should be meticulously followed up. In this case, the follow-up
was not mixed. And
yes.
Distraction was not according to the advice of the patient. Arif Bhai, do you want to add something?
Thank you. First of all, I want to say the X-ray quality is very bad. I cannot understand the bony outline. And
this is the gap.
And that distraction gap you need not to worry about, because there are some rules in distraction. Whatever the time you needed for distraction, the concentration time can be twice or thrice. And before commenting on this X-rays and Elizarov, I have something to criticize the whom they operated the patient. I think the bony excision, that mass part, may not be rational. There are many ways to treat pandaphyseal osteomyelitis in tibia or long bone. There are different techniques with Elizarov. The bony excision on very much part is not a solution, I think. And that gap you need not to worry about. I think with proper follow-up, that will consolidate. And you need a very good X-ray to visualize all the bony fragment also.
Okay, thank you.
So Dr. Norman, Dr. Norman here. I'll give you a similar situation. See, this child was not following anybody's advice according to your. So to sit with the parents to understand what is the level of follow-up is very important. Because I got a paper to review in one of the journals. That paper had come from Syria. And what they had done was, because there are very bomb injuries, there were fragment loss, and many children with the fragment loss had come to that country. And few people who had gone to that country to help them, they were doing fixation. On day one, they were doing corticotomy and lengthening. So, and then they said that half the children were lost to follow, because in a war-ridden country, you know, that's not very easy to follow. So I think so most of the reviewers said that your treatment is novel, but is it relevant in the situation where you are? And you do not have any follow-up because you said because it's a war-ridden country, we cannot follow up. So in the war-ridden country, if you cannot follow up, are you justified doing certain treatments? So this is what is there, that at fragment transport, you have to talk to the parents that fragment transport is going to take at least 6 to 8 months. If you had spoken to that parent before doing surgery, probably then patient would not have gone away. At least my patient with the frame has not run away. I mean, nobody accepts patients with frames very eagerly. So that is something, we have to be, social circumstances are one of the most important things. People may ask you in the exam that forget about social circumstances, but when you are practicing, the most important thing which comes to decision making is social circumstances and sometimes finance as well.
Take opinion of both of you faculty. Let's go back to previous X-ray before Elizarov. Yeah. So Premal, you first and then Sandeep. If you were to treat patient at the stage of the sequestrum, was there a discharging sinus?
Yes, at that stage she was discharged.
And no fever?
Yeah.
No fever. Sandeep, how would you treat at this stage?
I think in osteomyelitis what we need to understand is one, immunity of the patient, how the body is responding to the infection. If you are seeing adequate newborn formation along the subperiosteal, which is the involucrum, then you would rather wait for stability to be achieved before extensive diaphyseal resections. Second thing you need to see is that what is the adjacent bone status. If the fibula is intact, that is giving length stability, it's not going to collapse. So if there are multiple discharging sinuses, there is nothing forming, there is no involucrum happening. CRP is high and child is in toxemia, then I will go ahead and resect it. Remove the sequestrum, and when I remove the sequestrum, I will do it like a tumor surgery, radically. That time you don't leave behind any dead tissue, and we use stimulant in our country. So local antibiotic delivery system, and many a times we have seen once immunity builds up, the whole thing ossifies without any external fixator, nothing. You just put plaster and it just heals up. Okay, that depends again, it's a play between immunity, bone formation, how much periosteum is intact and how much is destroyed. So it depends on that. But and if it doesn't form, you will then graft it when everything is dry, CRP is normal and child is non-toxic.
When I was a resident in 2001, 1991-92, there was an era of Elizarov, and there was a famous saying that infection burns in the flame of regeneration, and that era seems to be persistent in Bangladesh. It has gone away long back in India. The thing is that the principle is same. You have to control infection first and then start the reconstructive procedure. Simultaneously, it is not possible. You have to have a dry, sterile area with whichever method you say. Sequestrectomy, cementing if you do not have stimulant, or a cement spacer. Cement spacer is not necessary in tibia because fibula is intact. If this was a femur, you would have used a cement spacer as I showed in the morning. So once you have control of infection, then and then your reconstructive procedure should start. Otherwise, you will have a fire at both ends of the rocket.
Yes. One comment or observation I want to make for the young trainees. It's very important that you go and work with different people, because diseases are the same, but the approaches of different people are different. And then you can make an informed choice what you should be able to do in your situation. Sometimes you work with a certain mentor who does this, and then you develop a tunnel vision. You know, for a carpenter, everything looks like a nail. So, irrespective of age, disease, nature of the condition, situation, you will use only one method, because you are not aware of other methods. So, as a trainee, try to go to different people, see different ways in the same thing, how it can be treated, and then choose what works for you. It's wrong to blame Elizarov as a method. उसका क्या गलती है? जिसने अप्लाई किया उसका प्रॉब्लम है.
What is the current situation?
So after 8 months, at this stage she was presented to our hospital, Mymensingh Medical College.
Okay.
We then decided just to observe.
Okay.
And after 2 months, this was her condition, and patient was toxic to bear this. Then we decided to do this surgery. We removed the initial elizarov. We cut fibula below the neck of the fibula by identifying and saving the common peroneal nerve and shifted it here. Again put elizarov.
Okay.
And we started, this is the X-ray 1 month after the reapplication of elizarov, and this is after 5 months. By this period, the patient was under our follow-up, and we started to bear weight at 2nd month after application of second elizarov. This is after 6 months. This is after 8 months. And this is 8.5 months. This was the condition. And at this stage, we removed the elizarov. This is 2 days after removal of the elizarov. This is 3 weeks after removal of the elizarov. And this is her last X-ray.
So bone condition is still not improved that much. Are you using any external devices to support?
Tibia is linked to the fibula. No, now see, if you see from the day 1, nearly 2 years have passed.
About 2 years.
Has child gone to school?
Child,
How justified are we in offering such treatments when a simple radical debridement, a plaster, stimulant, and then fibula grafting would have done the job in 6 months or so? So why? It's not that elizarov doesn't work. It's that it's simply too long and too morbid and too uncomfortable for everybody. And then when it goes wrong, you cannot say, no, he didn't come for follow-up.
So I showed a case of Huntington in the morning.
Yes.
And you showed a similar way of doing it with elizarov. Suppose your near or dear one gets into this type of and what would not, I'm just near. So what treatment would you prefer? I mean, in elizarov for 3 years, I lost a patient because he developed a malignant hypertension, which is a reported complication. The patient was there treated only for comminuted distal femur fracture, because at that point of time one of my teacher was treating everything with elizarov. It didn't unite, and ultimately he developed malignant hypertension, developed renal failure, and died after with frame after 3 years. So after that I have been very judicial in using. So I'm not, sir, there are, if you wanted to do Huntington with so much thing, why again elizarov? There are other ways of doing it. You can just cut it at 2 levels, transport it acutely and put 2 screws. You could do Huntington the way I do it. You can take opposite fibula and put it in a simple way and put an intramedullary. I will be very much wary of this child. And what has happened? Your tibia has not fused to, your fibula is not fused to tibia. Only one end is fused and other end is going to the fibula. I mean, this is one of the complications I have never seen in my life.
Huntington was like this. Then they cut the distal part and bring it this side. So it is done in stages.
There is a synostosis here.
So, means ultimately what happens is that, see, you get so married to a procedure that by hook and crook you want to create a case which succeeds. I feel sometimes think about the child also.
What is required now is, I think we would protect this in a plaster and let the child weight bear and let the bones hypertrophy and get into a good, yeah, absolutely. Don't do any further procedures and just make this patient walk on either a packing and
now she is on brace.
Absolutely. And weight bearing and maintain a nutrition, bone health. I think things should be okay. Great case. Thank you.
Thank you, Dr. Tarikularam Noman. Now I would like to request Dr. Ashfaqur Rahman.
And very good evening to all. My dear colleagues and respected teachers. I am Dr. Mohammad Ashfaq Rahman, consultant orthopedist, Shibpur Upazila Health Complex, Narsindi, presenting today 3 cases. Already all of the cases have been described properly and simultaneously, and giving you the preoperative and postoperative cases now. My first case is an Naima, 12 years of age, hailing from Damra, Dhaka. She came to us with swollen left ankle. We usually do in emergency room swollen ankle joint. Okay, let's give a plaster and okay, then follow up after 2 or 3 days or 7 days. But now we learn to see the X-rays 3 or 4 times more and more and more. Here's the X-ray. So, from the audience, what is the diagnosis, please?
Anyone from the audience?
Now it is time for brainstorming. All have been.
Whoever answers correctly will get a ticket to Jawan.
Okay then. I know everybody know.
With a free popcorn. Yeah.
As Professor Kaji Shodilala already given lecture on poverties. Sandeep Padavardhan sir has already given lecture, and also Sir Salam sir.
So there is a fracture. Okay, let's give us a clue. There is a fracture.
Okay, there is a fracture.
What type of fracture is this? Yes.
So you are getting a.
So there is 3. Any name to this fracture? Is there any name to this fracture? Telos fracture. Is it Telos fracture? All right. Great.
So the brainstorming, the picture, Dr. Henry's step 3, Telos fracture. What will be the we have to do next? Treat her conservatively, or wait and see, or operatively?
Any investigations? They should be ideally, treated after the CT scan if available. If you don't have, it's okay, but if you have it, then it will make your treatment very easy. Because you will know the direction of the screw, a compression screw pass.
Conservative করবে কত percent?
Conservative করবে কেউ হাত তুলতে পারে না, কেউ না. Operative, nice to see. So open or close with the help of CM. Okay. We have done it on 5th October 2021. Anything regarding this postoperative X-ray?
Doctor, where was the fracture here? Can you go back on the first? Where is the fracture here? And is fracture on the medial side or fracture on the lateral side? Fracture is on the lateral side or a medial side?
Lateral side.
Now post-operative X-ray. Your screw is from lateral side or medial side?
That's why I'm asking. The middle side.
So that's why you are asking. You should have done a CT scan.
Yes, sir.
And if you just know the TLO, what you need is you take a small opening. What is the problem in making a small opening? Which patient will come and tell you that you have stolen away my beauty by putting 1 centimeter incision at distal end of tibia? Right. So I think with what ankle. The second thing is for TLO it is okay that your screw goes oblique and goes through the bicep. If it's a triplane fracture or a simple medial or malleolus fracture, then you should remain within the physis.
Yes.
TLO is the last part to fuse, so wherever you put a screw, it doesn't matter, whichever direction.
The 21st October, 15 days later, and this X-ray after 4 months, 17th February 2022, and patient having no problem at all. This is another case, 12 years of age after recently done. What is the diagnosis, please? Another zone ticket. Okay. Okay, same type of diagnosis. It's operated on 4th day of trauma. This is the CM view. And I think there is a perfect end-on view in lateral position, isn't it? In previous X-ray, is there any problem in fibula? I want to hear that from you, sir. But after reduction, as it is okay, we leave the patient, we discharge the patient. Anything we can do from here, operatively, after giving something? I just want to see here the arthrogram, that's it.
And I want to see the arthrogram.
Sorry, you haven't time.
Because if you look at your articular surface, I would not accept that articular step. So
that's why I am telling you about the arthrogram, sir. Learning from you, sir.
No, I think it has been mentioned so many times. Every time Sandeep and I come, we talk about one thing very passionately, is arthrogram. I think it is high time you just have few cc of dye lying around in the theatre, because in emergency you are not going to get this medicine. You have to have it stocked somewhere where you can use it. You are a big institute yourself, and I think that is, it's not a very expensive medicine.
This is the truth.
But of course, this may not cause much problem, but growth arrest can happen, and that will again demand chain of surgeries, and yes, outcome is not that good.
Yes, sir. Thank you, sir. My final case, this is the message I am giving, that in the form of a question. That is, when you insert the screw or guide wire, please see the CM guidance, through the CM guidance to proper trajectory where I am going. So then the passing of guide wire too many times, it will be not done. Any use of dyeing here, so already talked about that. What might happen if K wire is cross K wire is given, then facial bar will happen. Should I always go for close reduction and percutance reduction? Already answered. And this is the Raihanuddin, 8 years of age, history of trauma, 1 year back, rotator accident with some burn in his left ankle joint. He go to the many physicians and also Covidage for treatment. Ultimately came to me after 1 year like this. So what do you want to see next after coming to chamber like this? X-ray, okay.
No. What, before X-ray, what will you do?
We do that.
Distal pulse. You see, the entire interior compartment is showing fibrosis and Burns contracture. The first thing I would like to see is whether that child has a pulse or not, because further treatment depends significantly on what is the vascular status of this limb, and then I would go ahead and do an X-ray, because X-ray, of course, that child might have come with X-ray. In our practice, I think more frequently patients come with investigation rather than we doing investigation. So I think clinical examination, everybody jumped on X-ray. I think clinical examination is far more important than only X-ray, because if you happen to open in a case where there is a vascular injury and by chance there is an acute kinking of posterior tibial vessel which probably would be intact in this child, you had it.
This boy has a strong desire to wire rickets because he is fond of playing football very much. This is the X-ray. So what is the plan of treatment now?
Someone wants to go for Elizarov?
Go for anything?
Yes, sir.
Forget about anything.
Anything else?
So Rabi, what is the diagnosis here? Please enlighten me with the diagnosis.
I don't know, but
you said you want to do Elizarov, but I want to have the diagnosis first.
Maybe post-infective contracture led to AVN of the ankle bone. I think talus is there,
avian talus is visible there, calcaneum is good, but talus is not well visible there.
So any more investigation would you need, or will you treat this child only on X-ray? Because in AP X-ray there won't be AP X-ray possible with significant dorsiflexion contracture. I think this is a case where CT scan would definitely add a lot of information.
Just to ask, what is the age of this child?
8 years.
8 years, okay. So from the X-ray or the CT, because X-ray is not going to show you much, what is the thing that you want to see and what is your aim of treatment?
So aim of treatment to straightening the foot for now and give him a better walking state. I like to show the video next.
Yeah, exactly. So this is a bad deformity. There is some loss on the lateral side of composite.
Video.
Yeah, there is composite soft tissue loss on the dorsolateral aspect. So he is probably walking on the medial tibia.
Yes, sir.
So the question is, on CT, what do you want to see, or MRI? See, he looks older than 8, by the way. Is he 8?
8.
No, because you have to look at two things: the limb length discrepancy, how much growth is remaining for him, linear growth of the tibia. You want to preserve that as much as possible, and simultaneously you want to make the foot plantigrade. The minute you want to make the foot plantigrade, the dorsal soft tissue contracture will come in your way.
Yes,
so if you exercise that, you will need a plastic reconstruction.
Definitely.
Or then you will need an external fixator to counter all this complex deformity. If you are good at it and your patient is willing to follow.
I think what I would like to see in the CT scan is what is the situation of the distal tibial physis. Because if the physis is damaged, I would like to ablate the remaining physis. Second thing I would like to know is what is the joint surface of the ankle joint and what is the status of talus. Because if there is no ankle joint, you might as well correct at the level of the ankle joint, and in one surgery you can have fusion and you can have deformity correction.
That is why you need a CT, because in no plane can you define the distal tibial plafond. Is the ankle having some motion?
Yes, sir.
So we don't know what's happening, no? All this is clinical examination. See, now he is walking on the medial malleolus clearly. Yeah, so the movement may be subtalar. The heel is just moving outwards. The ankle may be completely stiff. Looking at the soft tissue loss.
Ankle was totally stiff and some subtalar movement is there.
Yeah, so you can't do everything. You are not God.
Yes, sir. Yes, sir.
So now
Sir, look the walking and then just grabbing the heel, some movement in subtalar joint, that's it, and tibia talar joint is all full fixed.
Have you treated him or no?
Yes, sir.
Show us what you did.
So after giving treatment,
what did you do? Yes. You shouldn't. This is
just lengthening the.
What did you do?
So I lengthening the tendons
dorsally
from
front
and give
so you did a contracture release from front
and skin grafting
and skin grafted
and
that area. So there was a defect, you had to release all the skin.
Yes, sir.
And then there was a tissue loss,
yes,
which you grafted. But you could get the foot completely straight.
Completely.
Very good. So now what have you done? You have put KVRs.
And minimal invasive KVR fixation, and already KVR also being removed.
Okay. Now
Mr. Was treatment is like preserve as much as he has.
This is the 2 months of.
Now that is
what are the purpose of the KVA is to just hold the correction.
To just hold the correction. That's it.
And the second thing is at that point, like if there is physis is there,
and I think
let's not
there is something.
Let's preserve that as much as you can.
Some physis is there.
foot planting rate, you have kept the physis, whatever is available for further growth. But this may not be the end of the story for this child. You may develop a central fascial arrest, painful stiff arthritis of the ankle, you will have to manage it, and the length also you will have to treat. And dorsiflexors are not going to work because there is a graft which is sticking to it now. But overall, this makes him much better. I don't know whether he can play football, but he can walk better.
After 6 months, I brought him a pair of cases, sir. Already.
And first wish was he wants
and
to wear sneakers.
So now he can wear sneakers.
That's why I got it.
That's one step ahead. Well done.
Thank you, sir.
Next.
What I would advise is just one small suggestion is people who don't have ankle movements, rather than having a normal sole, if you give them a rocker bottom sole, they are able to progress much faster. They are able to walk and run faster. So try that.
I would just like to counter your last slide. This is not the end. This is the beginning.
Yes, sir, I want to tell.
This is the beginning because I don't see the lateral physis very well. Even if you have fused the ankle, I would watch this child very, very carefully. Otherwise, he will come with the same deformity, valgus, because of the medial malleus growth, not gross valgus, but significant valgus.
Thank you, sir, for seeing this.
Yeah, so
just for a second.
After hearing you, you plan to brace that child for another 2 years.
No, bracing won't help. You know, growth aberrations can't be controlled by brace.
My only recommendation to you, you've got into a very good situation. If you don't show this case with good follow-up and pictures in 2025 IFICS, we will shoot you.
Yes, sir. Definitely, sir.
Good documentation is the key to a good presentation. Don't tell me lessons very lost to follow-up, we don't know what happened. Such a nice result, you must take photos and serially show us after 2 years.
Last 2 days, sir.
Today's date and age where all the patients have mobile phones, you cannot say that patient is lost to follow.
Last 2 days I phoned him, his mother about 10 to 20 times, but didn't receive. I don't know why, because I can found him.
She has blocked you.
Presenting my case report, it is for my junior colleagues not to criticize anyone. Our small mistake come disaster to a patient's life. So it is happened here. There is a polytrauma patient, Master Abdullah, age 8 years, sustained trauma, fall of a wall upon the child. And as a result, bilateral open fracture, both tibia fibula. We suspect that he may suffer from right-sided vascular injury. Patient was admitted in a private medical college nearby Dhaka. I don't like to mention their name. This is the picture. This picture is supplied from the files. I have no proper documentation as this patient was treated elsewhere. This is the picture. So it is the right side open wound, and this is the picture of the X-rays. What may be the plan of treatment? We know that in open wound there may be external fixator or like that, something like that. What they did at initial surgeon, day one they put a long leg back slap bilateral, and in the second day the surgeon opened the wound and pushed 2 KY. The wound incision was the medial side. This is the picture. Their long leg back slap, the wound on the left side and the KY put there. On third day, some consultant visited the patient and the skin of the child became changes. There is no vascularity and they referred for vascular surgeon. This is a scenario. Ultimately, what happened? The patient was seen by vascular surgeon, and this is the fake picture. This is the picture of the right leg. There is no vascularity. Already there is demarcated. So we bound to do the amputation here. And on the left side as well as also there is loss of skin and soft tissues. So we bound to do the local fluff and we remove the QR and put a external fixator, and this is the final picture. On the right side, as there is enough skin to close the wound, we talk with the orthopedic people. They advised me do this partial thickness skin graft. As the child will grow and the stump will grow in length, then they will put a prosthesis later on. So as the child loses limb, what is the fault? Is the fault with the teachers who teach their students properly, or the initial managing doctors, or the trauma itself? So my advice is initial assessment of the patient is very important. Over treatment is always bad rather than. If any doubt, please consult with your senior or nearby colleagues, and if any confusion, please refer the patient to a higher center. Thank you all.
Thank you, sir.
Since a radial head translocation, sir. It goes on the other side.
This is better type.
This is not a better. This is classified into elbow dislocation, sir.
This is elbow dislocation. But I think the MRSA and the...
Sir, the radial head.
I got this patient about 6 weeks after the injury. And what will you advise to do after 6 weeks?
So this, it's an unusual injury where there is translocation. Normally you should see radial head under the capitulum. Here you see it under the trochlea. Sometimes it twists around and the ulna also comes on this side. This is incomplete. Bedo. So this is not Bedo, this is translocated. Lateral is Bedo 3. Posterior is Bedo 2. So this is not montage, this is a translocation. And this has no non-surgical treatment. You have to open and bring it back.
Nothing was done, and after she came 6 weeks after, and this is after 7 years. With full movement, flexion and extension with bundle deformity.
No pronosupination.
No pronation.
Yeah, so there is now synostosis. Because ulnotrochlear alignment is good, she has full range of motion. And there is no lateral support, so she has valgus instability.
She has come to me for the ankle injury. And he showed me that, sir, you have shown me it was my elbow, and now it is okay, I accept it. So this was the injury. So this should be treated by open reduction. Is the open reduction will be easy? Question.
Cases I have done.
But is it a common cases?
It's very uncommon. It's very rare case.
Approach it question. That's
Okay, thank you. That's the end, but not the end. Now the valedictory. So I don't know the audience how you enjoy or like or dislike this conference, but some people help us do it properly. Among them, I'll call Rabbi is there. Where is Bobby? Kaji Shodilaram Bobby, please come here. Ashfaqur Rahman and Tariqul Alam Noman. So Kashi Rabbi was responsible for the total scientific thing and contacted with the faculties. Ashfaqur Rahman was responsible for arranging everything here. Kaji Shodilaram Bobby, he was responsible for the total registration process, and Tariqul Alam Noman, he was the master of this ceremony and saw all printing. So I also request the executive committee members of POSP present here to come. Professor Parviz Shaiji sir, Dr. Taposh Kumar Talukdar, Dr. Mehdi Nawaz, Dr. Kamrujaman, who else is here? Shamul sir, Professor Shamul sir is there, and Professor Dipankar Nath Talukdar, Professor A.K.M. Johiruddin, Said sir, are you there? Said sir, so no, you guys stay here. Because as you came for that, no, you stay here. So we will finish with the mic. We will take a group photo here. So we have some gifts for our foreign faculties. Imran, please bring the crests, mementos. Ignition, circuit dekha. Sir, dekha circuit. Sir, this was the thing. So, sir, please present it to Dr. Taral Nagda. Taral, please come here. No, sorry, Sandeep, come here. Sandeep. Sir. Okay. Dr. Premal Naik will take it from Professor Parvesh Aidi. He is our international secretary. And Dr. Taral Nagda will take it from Professor Said Ahmed. He is executive committee member. Thanks, sir. Oh, there are some Punjabis, Arun Punjabis. Bring it here. So, Tashfin has brought some Punjabis. Tashfin.
Ready? Shobai takai, ready?
Everyone say IFICS.
Mobile ka. Mobile.
Joined outside the IFICS meeting. I think it's a wonderful addition to meeting. Children's meeting should be with live popcorn. So I think we should have next time popcorn inside the hall. We enjoyed interacting with you. We were very similar to you when IFICS idea started. We had same issues like not having implants, not having CT scan, not having MRI. Everything has come to India. I think Bangladesh is very much like progressing in the lines of India. And I think when we come after a decade, I think you will all us be showing some very, very latest things. Probably will be the same in India. Thank you once again for your
Thanks all the delegates and the faculty. Thank you very much. Mr. Imran, the representative, for helping us in all these academic activities for about 15 years. Thank you, Imran.